All right, we will reconvene. Sorry to take away all the fun. Okay, thank you everyone for your patience. I just wanted to check if Barbara Goodman is in the room. Is Barbara Goodman in the room? Number 104. Going once. Maybe she just stepped out for a second. Is Barbara Goodman here? Not seeing her at this time. We are going to go to the next person, who is Ben Zura. Ben, you're on. Welcome.
Thanks. Good evening. How's my audio?
It's good.
Great. Senator Anwar, Representative McCarthy-Vahey, and members of the committee, on behalf of the members and the board of Connecticut Association of Paramedics and EMTs, I want to thank you for your continued focus on the crisis that our EMS system is facing. My name is Ben Zura. I'm the co-chair of CAPE's Legislative Committee. I'm the Director of Innovation and Strategy at Emergency Resource Management, and I'm a member of ChemSAB's Data Committee. Most importantly, I've also been an EMT in Connecticut since 2006. I'm here to speak in support of SB 1229 because we need a much better understanding of the current function and dysfunction of our state's EMS system. For decades, every analysis has pointed to the lack of a comprehensive EMS data system as a significant obstacle to the oversight and management of Connecticut's EMS system. Most of these deficits still exist. I've submitted excerpts from these reports with my written testimony, including a fairly scathing two-phase report from this body's Legislative Program Review Committee. Things have gotten better, with respect to Mr. Allard, who suggested in his testimony this morning that anyone concerned about this speak to the Data Committee. I'm on the committee, and I'm telling you, we don't have what we need.
Ben, we are losing your...
EMS.
Sorry,
Beyond
Ben,
just the aggregation.
can you hear me? We lost your audio. Do you want to turn your camera off? Maybe you'll have more bandwidth. Can you hear me, Ben?
Yeah, I can hear you now. I'm sorry.
I said your bandwidth dropped a little bit. If you turn your camera on, we'll probably hear your voice better. Camera off, sorry.
Okay.
Here.
How's that?
That's good. Okay.
Is that better?
Can you say your last two sentences, please, if you don't mind, and then start. You
Yeah.
said Allard's testimony.
Sure. Sorry, where did I drop off?
Greg Allard's testimony.
Yes. So, no, he suggested that if anyone's concerned about data, they should. I'm on that committee, and I'm telling you, we don't have what we need. What we need is to expand the scope of what's considered EMS data beyond just the aggregation of ambulance run forms, which is sort of what it currently is. And response times are a great example of why what we're missing matters. So none of the response times published by the state are accurate, and they never have been, because they only come from the run forms of the unit that completed the call, and they don't account for the mutual aid system. So basically, when a service is dispatched to an emergency, but they don't have a unit available, that call is passed on to another service according to the mutual aid agreements. If that second service doesn't have an ambulance available, the call to a third. Now, if service has an ambulance, they respond, they transport the patient, and they submit a run form. That run form is the source of the response times for the call. None of the time spent looking for an ambulance to respond is currently being counted, although it could be. The mutual aid system that is preventing the complete breakdown is also masking the extent of the problem because of the way that we're counting the data. So that's one of the missing pieces, but it's not the only one. Two other brief points.
Excuse me, Mr. Ben Zura, but your time is up. Thank you.
Actually, Ben, please continue. I think we lost a few seconds a couple of times. So finish your...
I'm sorry. So, all right, two brief points. The lack of useful data about Connecticut's EMS system is a symptom of the lack of funding of the oversight of that system. And secondly, EMS data would be extremely valuable in understanding the overall health of Connecticut. So many public health initiatives that would benefit from this data. So in closing, forget about any of the technical stuff. For the last couple of years, I've been asking a very simple question, which is when people in Connecticut call 911, does an ambulance show up? And I'm telling you right now that no one in the state can answer that question. So thank you for your time. Sorry for the technical issues, and I will
Thank you.
answer any questions.
Thank you. I do have a question. I first wanted to thank you for having multiple meetings with many of the legislators and sharing the data. Probably you have far more data on the number of people who are EMTs and paramedics in the state of Connecticut, and you've shared that with the trend, and the trend does not look very good. And that is why we are seeing many of the EMS services across the state going through some challenges. But I think that's one of the things.
And I'm telling you right now that
Representative
no one in the
Kijanga,
state
please?
can answer that question. So thank you for your time.
Thank you. So what I was going to say is, Ben, thank you for sharing that data, but also this dashboard part of the bill that should address a lot of the questions that we have been raising. Is that fair?
Yeah, absolutely. A lot of what we need to understand the EMS system is being collected by the state. Some of it is going to different state agencies, but to bring it together to sort of, put the pieces together, we do have what we need in order to do that. We just have to do it.
Right. And from having a conversation with DPH, it looks like DPH shares that every 6 months. Do you have an opportunity to look at the publications from DPH every 6 months?
No. Which data in particular?
I think one of the committees where which is in the bill that we are trying to include CAPE in it. There's a conversation about the data every 6 months.
ChemSab does put out a report to its members every, such amount of time. I don't know exactly what it is, but that's not that report is not distributed throughout the EMS system. It's pretty much within the committee.
But we truly appreciate the work you are doing, and then thank you for sharing some of the information and data and raising the concern about how we don't have enough EMTs and EMS system and the pending increase in the number of EMS deserts across the state. So thank you for your testimony. I don't see any comments or questions, so we appreciate you being here.
Thanks for having me.
Thank you. The next person on our list is Cassandra Esposito. Welcome, Ms. Esposito. Thank you for your patience with us. Welcome.
Thank you. Good evening, Senator Anwar, Representative McCarthy-Vahey, Senator Summers, Representative Claritas Ditria, and distinguished members of the Public Health Committee. My name is Cassandra Esposito. I'm an APRN and president-elect of the Connecticut Nurses Association. Thank you for the opportunity to provide testimony on behalf of the Connecticut Nurses Association with recommendations that immediately strengthen nurse staffing in Connecticut, now SB 1067. The legislature is hearing the voice of the nursing workforce, and we appreciate your commitment to finding meaningful change to retain nurses at the bedside and in the profession. We ask that the legislature prioritize finding those solutions that can be implemented without delay, providing immediate definitive action to redesign and strengthen the present hospital staffing committees, while providing transparency and accountability for their actions. Bedside nurses must have a clear leadership role in addition to their equal voices. Not only must nurses' role be well-defined, but also the reporting responsibilities of the committee. We continually hear that nurses do not know about the committees or how to join the committee. We support transparency by identifying a dedicated staffing committee and regularly informing the staff about their activities and opportunity to participate. We support the section 19A-89E, registered nurse objection or refusal to participate. We feel that a nurse needs to be protected if they speak up and not fear retaliation. This protection is foundational to the success of our approach. Nurses need to feel safe to share their voice and to share their concerns. Another core element of our approach is to establish accountability through DPH oversight to collect reliable and timely reporting that would support future evidence-based modifications. Our written testimony submitted by our Executive Director, Kim Sander, has all the details of our strategy to make an immediate impact on staffing and improve the workplace environment. I urge you to review our solutions-oriented approach to achieve immediate impact. Thank you. I'm happy to take any questions.
Thank you so much, Ms. Esposito, for your testimony. I do not see any questions or comments. We want to thank you for being with us here today.
Thank you.
Thank you. The next person on our list is Emily Matthews. Is Emily Matthews here? Going once. Oh, Emily Matthews is on Zoom. I thought you were, oh, well, welcome. See, people are going back and forth, which is great. So keeps me on my toes. Welcome. And can we mute? Yeah. Go ahead, Miss Matthews. Emily Matthews, she will be right back. Should we go to the next person? She's back. Okay. All right. Emily Matthews, you're on. Welcome. Number 112.
Okay. Can you hear me?
We can hear you, but we cannot see you.
Okay, let's give it a try. Okay.
Yes, now we can see you.
Okay, wonderful. I'm here today
were
to speak
here
in favor
earlier.
of SB 1067. I've been a nurse for 9 years, and I'm currently part of a cross-facility float pool in which I can be placed on any medical, surgical, or intermediate care floor in 3 different area hospitals that are owned by the same company. As a member of this float pool, I am not protected by union membership, but I am willing to take the risk of retaliation in order to share my experience and advocate for my patients and for my profession. I have witnessed how, even before the pandemic, unsafe staffing ratios compromise patient care to the point of being dangerous. I am joining you today to outline a recent shift that I worked on a general medical surgical unit. During that shift, we had 18 patients on the floor with 3 nurses, no nursing assistant, and no unit secretary to help answer telephone calls, patient call bells, and assist with communication between medical and nursing staff. What that means is I was responsible for meeting every need for 6 people, 6 patients all day long. Providing even the minimum of care at that ratio is impossible. There were 3 patients on the floor that day with dementia who were at risk of harming themselves due to lack of understanding of safety risks. 3 of the patients on the floor were unable to feed themselves and needed to be fed all 3 meals one-to-one with staff. You can do the math. It doesn't work. 4 patients had surgery and needed extra attention with increased frequency of monitoring of vital signs and pain control. 2 of my patients were diabetic, requiring monitoring blood sugar and providing insulin in all 3 meals. And with that ratio, I was unable to complete it for all 3 meals in a timely manner. Under the proposed bill, we would have had 1 additional nurse and 2 CNAs, which would have allowed us to meet the basic needs of our patients. I have listened to nursing leadership's testimony, stating that they are actively working to recruit new nurses and are concerned about building up the pipeline for nurses entering the profession. If safe nurse-to-patient ratios were mandated in our state, we wouldn't continue to lose experienced workers who have been leaving the field in droves to find a career that provides a working environment that is less physically, mentally, and emotionally taxing. The focus needs to be on retention in addition to recruitment. People representing hospitals' interests will tell you that it's too expensive to provide this level of staffing and that the staff does not exist. This is not true. The only shortage that exists is a shortage of people willing and able to work under these conditions. And the representation of nurses being like hospital hopping to go for a good sign-on bonus is actually a representation of the lack of retention efforts, and all the focus is on recruitments and sign-on bonuses. But we need to create an environment that will keep nurses at the bedside for the longevity of their careers. So this crisis
Excuse me,
does
Ms.
not-
Matthews, but your
Yes,
time
ma'am.
is up. Thank you.
Okay, thank you.
Thank you for your testimony. And I think you were here earlier for part of the day. So we wanted to thank you for physically being here, but you had to step out. We appreciate what you're saying. Do you want to finish your sentence that you were about to finish?
Sure. I'll just in conclusion, the crisis does not only affect healthcare workers and our working environment, it affects every citizen in the state because at some point everyone will be themselves or have a loved one become a patient. So if this legislation is passed, Connecticut will become a leader in patient safety. And as a nurse in the state of Connecticut, that's what I would like to represent. Thank you.
Thank you for your testimony. I see Senator Marks has a question or comment. Senator Marks.
Yep, thank you, Emily, so much for your testimony. I am a nurse. I don't know if you knew that. And when you tell that story about the day, a bad day on the floor, when I graduated in 1985, there was a nursing shortage, and I was in a very acute pediatric ward, and I still wake up at night, almost 40 years later. I still have bad dreams about some of those patients and about hanging platelets on the wrong person or hanging antibiotics on the wrong person, or, I mean, we all have them. So we really haven't talked about that. I've been on most of today's hearing. Do you feel that a lot of nurses are having that kind of, I guess it's PTSD, but that kind of anxiety, that those bad days or bad nights on the floor just stay with them for a while?
100%. Any nurse that's been working over the last, even longer than COVID, 5 years, 3 to 5 years, can tell you the shift that changed them. I can tell you right now, the shift that changed me as a nurse. I walked into a 7-patient acute care medical level assignment with 7 patients with 1 CNA for the 21 patients on the unit. That day changed me as a nurse. That day is what gave me the courage to speak up today, because our people are being neglected, and we cannot continue day after day after day to walk into that kind of a working environment. And sometimes we'll leave at the end of our shift. Last week, I left them at the end of my shift, knowing that the scenario that I outlined was exactly what I was going to be walking into that next day. Do you think I slept? I did not, because of the anxiety, that walking into such an unsafe situation puts on us. And I honestly, there was one of my colleagues was coming back the next day. I don't know how they did it. I was thankful I had a couple days off, but even that day I went back, I was still hesitant, very anxious about going back to the floor.
So we hear that people don't believe that the staffing ratios they're going to be able to do them, and that if they do, they're going to turn people away, which we all know the hospitals are not going to turn people away, and nurses don't want to. But what do you feel like from your heart? What will having the staffing ratios do for the morale, for the anxiety, what will it do for the nurses on the hospital floor?
I think it will make this job sustainable. What I've seen, I've been in this float pool for the last 3 years, and I've watched the 2 years of new grads come in and be burnt out because they don't have the training that I got as a nurse, as a new nurse in the before times, to be able to figure out the priority of everything that's kind of just flown at them. They're just running around putting out fires. That is not a sustainable working environment. You can't do that for 12 to 14 hours a day, 3 to 4 days a week. It's impossible to maintain any kind of work-life balance, any kind of mental stability. It's impossible.
Thank you, Emily. If you do get retaliated against, I know a few good nurses that will definitely help you. So give us a call, okay?
Thank you so much.
Yeah, bye-bye.
And I'll just add, good legislators will be there for you too. So,
Thank you, sir.
Seeing no other questions or comments, we thank you for being here with us today. And thank you. The next person on our list is Deeta Bhargava. Welcome, Deeta. Good to see you. Turn the mic on. Yeah, there. Perfect.
Can you hear me? Yes. Honorable representatives, I'm Deeta Bhargava, an ambassador for Shatterproof and board member for Liberation programs in Connecticut, and I'm testifying in support of Senate Bill 9. I'm joined here with my 14-year-old daughter, Aria Pelletier. 1 year ago, I testified for House Bill 5044, an act concerning opioids, imploring leaders to consider passing legislation to create overdose prevention centers to stop the bleeding of precious lives in our state. I am encouraged that this life-saving notion is coming to life through SB 9, and I plead for your support. Sadly, despite our state's best efforts, overdose rates continue to climb as the insidious disease of addiction spreads throughout our state and country. One such victim was our son, Alec Pelletier, who died unwittingly of fentanyl poisoning on his 26th birthday in 2018 while living in a sober home in Canaan, Connecticut. Alec was a warm, vivacious, AAA hockey player. As a teen, he suffered from a mild bipolar condition and was self-medicating, first with easily available opioids, then with heroin. In the end, Alec wanted nothing more than to live a life of recovery, empowered by the love of his family and friends. We miss Alec dearly every day. His younger siblings miss him every day as well, their older brother. And the real tragedy is that my family is far from being alone. Over the last several years, we have senselessly lost thousands of young lives like Alec in our state. Our moral, social, and economic obligation is to find bold solutions to end this crisis. The opioid-related bills passed last year were a good start, but 1,500 innocent lives have been snatched from our state since then due to overdose. We must do more. At my son's services in Sharon, Connecticut, I was told by the funeral home owner that he hosted 7 other funerals of young men around the same age in their 20s who died of an overdose in just that month. Why is this a pandemic that we cannot control? Because the fentanyl scourge in our country hunts down these innocent folks who suffer from substance use disorder before they can find a path to permanent recovery. This was my biggest fear for our son, Alec, which came to become a living nightmare. Overdose prevention clinics have proven to keep loved ones alive long enough for them to find help, and it would have saved our son's life. Like me, some of you might make decisions based on data. Well, here are some compelling facts which are impossible to turn your back on. The cost of the opioid epidemic to Connecticut is estimated at about $10 billion a year. Imagine the money saved due to avoided ambulance rides, ED visits, hospitalizations, and instead keeping people alive, working, and participating in our communities.
Excuse me, Ms. Barbara.
Provide a
but your
safe place
time
for education by connecting individuals to treatment and resources. OPCs have been 100% effective at preventing overdose deaths, are cost effective, reduce syringe litter in local communities, and increase engagement by visitors to treatment. Last week, some of you may have toured On Point, the New York City OPC. On Point has, in its 18 months of operation, intervened successfully in at least 819 overdoses and supervised almost 66,000 episodes of substance use.
Excuse me, Ms. Barbara, but your time is up.
I'm
Thank you.
almost done. If I could
Yeah,
please.
please complete your testimony.
In Vancouver, an OPC was established in 2003 and over 5,000 overdoses were prevented. Not a single person has died in any of these centers. The Biden administration has also been openly and strongly committed to harm reduction. Biden's Secretary of the Department of Health and Human Services, Becerra, told NPR, "We are literally trying to give users a lifeline," affirming that the federal agency is not going to intervene in state efforts to create safe injection facilities, or OPCs. Please also consider the following quickly. Support SB 9, Section 6 to 9 and HB 6913 addressing wide expansion of naloxone, which reverses overdose in its tracks before death. Prioritize the opioid settlement funds to prevent of overdose death by funding OPCs. urgently address the deadly fentanyl plaguing our communities. Fentanyl is responsible for 85% of overdoses. Imagine that dangerous chemical was anthrax being spread through our state. A few cases would lead to aggressive measures to find and punish the perpetrators. Therefore, please consider harsher penalties to deter high-level drug dealers who knowingly traffic substances laced with deadly fentanyl. And finally, expand youth programs and institute mandatory K-12 SEL education and warn kids about the dire dangers of illicit substances. Evidence-based K-12 life skill programs have known to reduce substance use disorder by up to 75%. Honorable Chairman and committee members, we don't have time to wait for bold measures. That need was yesterday, so please consider these ideas now. And if very quickly, if she may, my daughter Aria would like to say just a couple of words.
Go ahead.
Dear leaders, my name is Aria Pelletier. I miss my brother. I am pleading you to pass this bill so that could have saved my brother's life and will save brothers and sisters from going through the same sadness I went through. And while you're at it, please do something about helping to save the world from climate change.
Thank you so much, Dita. Thank you, Aria. I'm so sorry for your loss, and I'm so sorry that you had to experience this and you have to share this story multiple times just to be able to raise the awareness for everybody else. And I want to personally thank you for all your effort in how we've been working on this bill, and then helping us get to On Point and visit the site as well, and talking about this perhaps before a lot of people in the state of Connecticut have been speaking. So we want to thank you for that. Representative McCarthy has a question or a comment, and we'll go after that.
Thank you, Mr. Chair, and I'll go quickly. I just wanted to say hello to you, Dita. We've corresponded before. And just to let you know that your voice carries a lot of weight to me. Listening to you tonight, talking about the opioid prevention centers, because I am still learning about it, but we also had in the family a tragedy with the fentanyl overdose. And I know how much the family, it really impacts the entire family. And I'd like to continue some conversations with you, with Ariel, at some point, so we can look to talk about the youth and the families and what continues to go on. So I'm very focused on listening about how the opioid prevention centers can work and to see what we can do going forward. I was unable to make the trip, but anything we can do to help these individuals that are losing their lives to mostly to the fentanyl, I think is what we have to really look at. But and I know if you talk to Miriam Delphin Rittman, please tell her I said hello.
I will. And
All
thank
right.
you, Representative.
Thank you.
And we're happy to organize another trip to the On Point in New York if you and other legislators are interested in looking at it. I think, a picture says 1,000 words, and if you can see the people who have been saved as opposed to my son who didn't have access to one of these, I think it would really, really make all the difference in saying yes to this bill.
Thank you again, and we can't thank you enough for your work.
Thank you.
But we are hoping that we can raise the awareness for everybody to start to look at how we can make this happen rather than finding reasons not to make this happen.
Thank you.
Thank you.
Appreciate it.
Thanks.
Thank you.
Next person on our list is Brett Santo. Welcome, Mr. Santo. You're on.
Good evening, Senator Anwar, Representative McCarthy Vahey, and esteemed members of the Public Health Committee. Thank you for the opportunity to offer brief testimony regarding SB 1228, an act concerning the state's healthcare workforce, specifically to advocate for an amendment to include the counseling compact as part of the legislation. My name is Brett Santo. I'm a grad student at Southern Connecticut State University's Clinical Mental Health Counseling Program, a student member of Connecticut Counseling Association, and I'm also honored to currently serve as the president-elect for the Connecticut Mental Health Counselors Association. My beautiful 2-year-old daughter has aptly and unfortunately called me Daddy Busy on several occasions, which you all can probably relate to. But I digress. I'm providing testimony really urging the committee to include language as part of SB 1228 to join the counseling compact. For clarification and brevity, as was said before, the compact became fully operational in 2022 and now has 19 states that have joined, including Maine and New Hampshire. And as you've heard, 23 other states have introduced the compact this session. including New York, New Jersey, and Vermont. Privilege to practice through the compact will be available by counselors by early 2024, which would allow for rapid verification and immediate access to all compact member states. And the compact offers a sustainable solution to the current mental health crisis and related workforce issues by ultimately enhancing the workforce, ensuring that Connecticut remains competitive, meets increasing the demand for mental health providers by broadening client choice and creating a national database, as was referenced before, with a standardized network for the first time, allowing for advancements in behavioral health while optimizing client safety. The compact is really the most long-term sustainable solution to the issue of licensure portability, practice across state lines, and workforce shortages in behavioral health. For Connecticut to really remain competitive and meet the growing demand for mental health services, the Counseling Compact is definitely necessary. As an active grad student and aspiring leader in the clinical mental health sphere, I've been building roots here in the state of Connecticut with active involvement in leadership roles in local professional associations and university organizations. These connections have been critical for my current successes in this field, but I will say candidly that I share the same concerns as my fellow students regarding starting a career after graduation. Our professional identity as counselors needs to be standardized through an initiative like the Compact. And moreover, we would all love to stay in Connecticut and contribute to the workforce, but the prospect of being able to broaden our reach and our specialties across states where the Compact has been enacted is appealing. My aspirational interests specifically involve supporting those from marginalized identities, especially those within the neurodivergent community and those who have suffered trauma. I'd love to provide my services in the state of Connecticut to those in need. And enacting the compact will surely bolster the likelihood that my fellow students and I will stay in Connecticut, as the compact will augment the state's competitiveness, like I said, and surely impact the workforce accordingly. I hope you'll consider making an amendment to include the Counseling Compact as part of the legislation and appreciate that you're considering allocating resources to this important initiative. As an aspiring clinical mental health counselor, I can certainly appreciate the mental fortitude it takes to listen attentively for hours on end. So I thank you for providing me with the opportunity to provide testimony on behalf of the Connecticut Mental Health Counselors Association, the Connecticut Counseling Association, and my fellow counseling students.
Thank you so much, Mr. Santo, for your testimony. The good news is we are halfway done in 9 hours. So we have another 9 hours to go. So we are just getting warmed up over here. But we may need your support by another few hours. We could use you if you do telehealth for us. We can use you. I just wanted to share with you, the compact work both ways. So if there's a shortage on our end over here, and then you're looking at the market share in New Jersey, Vermont, there are going to be counselors who are going to be looking at the market share over here. So I'm sure you've considered that.
Yeah, absolutely. 100%. I mean, I know that it's definitely part of the conversation as to whether or not that's going to just take away our kind of ability to provide services. But I think just having the ability to, especially with those who specialize in certain areas, like I want to specialize in trauma and neurodivergence, I think having the opportunity, especially via telehealth, to provide services across state lines with something like the compact would be really conducive.
And many of the individuals clinicians have said, we want to be able to use the compact to access other markets, but we don't want anybody to come to Connecticut market, which you can't have it both ways. So it's important to recognize that reality.
Mm-hmm. Yeah, absolutely.
The technical challenge is that compact bills are very difficult to write. And then that's part of the limitation that we have. It takes a lot of resources to be able to write a compact bill. And then, as we had mentioned earlier, that we have a few compact bills, we have 2 compact bills that we are working on, and there's still some technical challenges associated with them. So that's why we want to be able to look at this. It is one of our priorities, but it's a bandwidth issue. So we will see if there's an opportunity to address this, but we hear you loud and clear.
Thank you so very much. Yeah, definitely appreciate.
And Representative McCarthy has a question or comment.
Mm-hmm.
Just very briefly, Daddy Busy, I love that very much. And thank you for your comments about the mental fortitude. I think we're all doing our best to listen and hear. And I just want to underscore what Senator Anwar said about our commitment to working towards getting this done.
Wonderful. Thank you very much.
Perfect. Seeing no other questions or comments, we move on to the next person on our list, which is Jennifer Weiner. Welcome.
Hello, good evening. My name is Jennifer Weiner, and I am a nurse director at Middlesex Health. I'm here to testify in opposition to SB 1067, an act concerning healthcare staffing. Specifically, I am opposed to the staffing ratios. I do not have an opposition to the part on the staffing committees. A little bit about me. Growing up, I had the privilege of being cared for by my great-grandparents, and then as they got older, was able to care for them. This instilled in me the value of caring for others and is what guided me to become a nurse. As a nursing professional, whenever I make a decision, I always think about the impact on our patients who we care for. I am greatly concerned about this bill because it will limit the community's access to medical care. Having long wait times in the emergency room for evaluation or holding in the emergency room until an inpatient bed is available is not only very uncomfortable for our patients, but also greatly increases their mortality rate. Nurses living in Connecticut are not an endless resource, and it is unreasonable to assume that if staffing ratios are imposed, hospitals will be able to keep the same number of beds open. While I understand there are good intentions behind this bill, I urge you to think about the long-term impact this will have on our community and the aging population requiring care. We need the government's help with other issues. So I'm excited that, nursing is, being talked about, such as workplace violence and retaining new nurses in the state, but not with rigorous staffing ratios. Thank you.
Thank you so much for your testimony. Seeing no questions or comments, we appreciate you being here and sharing your thoughts with us.
Thank you.
Next person on our list is Duncan Markovich. Welcome. You're on, Mr. Markovich. And you can turn your camera on as well. I see you have.
Good evening. Thank you.
Thank you.
Good evening, senators, state representatives, public health committee members, and the general public. My name is Duncan Markovich, co-founder and owner of Better Ways in Brantford. Thank you for the opportunity to speak today. I know it's been a very long day, so I will try and be brief. As for many, today's topics hit home deeply, and I am speaking in general comments on behalf of Raise Bills 6913, 14, and 15. I first and foremost must acknowledge all healthcare professionals that have spoken today on behalf of the other bills. Without doctors, nurses, first responders, technicians, and everyone else in the healthcare industry,
Duncan,
I would not be here alive today. I have
Duncan,
firsthand seen the impact on hospital staff and needs serious help in creating and keeping a safe environment for care. Turn it off.
Yeah, because we're losing your voice. We'd rather listen to you right now.
Sure, I'm sorry. Our hospitals and staff need serious help in creating and keeping a safe environment for care and for their very own safety and mental health. I hope everyone's concerns here are seriously considered. Lives truly are on the line. The opioid crisis has impacted everyone in some form or another. I personally have lost several friends in this epidemic while simultaneously experiencing my own personal hell with intense IV opiate exposure. In 2010, I underwent my 4th open heart surgery.
There's a lot of suspense. We need to know what happened after the open heart surgery. So 4. Okay, yes, good. Duncan, can you hear us?
And almost lost my left leg due to a surgical complication. In my 120-day hospitalization stay between Yale and Gaylord hospitals, I was overdosed and thankfully brought back twice. When it became evident that the opiates getting administered were placing my body into renal failure, an alternative protocol was administered.
Okay. And if you're able to join.
Can we pause, Brett Santo? Thank you. Go ahead, Duncan. Duncan, I think we are having, you're probably in a bad spot where you are at. So we hear you. If you can send us a written testimony, we would appreciate it. I think we got disconnected. We got disconnected. We'll move on to the next person. That's Anthony Sierka. Welcome, Anthony. Go ahead. Unmute yourself too, please. You're still not unmuted. Oh,
There
now
we go. How about now? Now we should be all
Go
set.
ahead. Welcome.
Good evening, Senator Anwar, Representative McCarthy-Vahey, ladies and gentlemen of the committee. I'm Anthony Sierka. I live in Chester, where we have an outstanding legislator, Representative Palm, who's on the committee and with us today. I'm here to speak in favor of Raise Bill 1073. I'm a registered nurse and have had a lifelong career in healthcare, which began in emergency medical services, where I served as a basic, intermediate, and paramedic level EMT and emergency medical services instructor. I was privileged to be a founding member of the Connecticut State EMS Advisory Board and was involved in the development of the structure of the system that exists today. Now, much has changed in the field of EMS over the years, but what hasn't changed is ultimately it's a battle against time. Every responder knows that if a patient's airway, breathing, or circulation becomes impaired, it takes just 4 to 6 minutes for brain damage to set in. There's no debate that epinephrine can reverse an anaphylactic reaction and has become the standard of care. We've known this for many years, and a safe and easy to use auto-injector, the EpiPen, was developed and is now widely available. And there are requirements for training of non-healthcare staff, and epinephrine is required to be in many different settings. Now, the EMS system is designed to work in tiers. The first responder is a key part of that system and in that battle against time. But in the case of anaphylaxis, basic life support is just not enough. And this is being recognized nationally. The National Standard Curriculum for the emergency medical responder level now includes training in recognizing anaphylaxis and the use of auto-injectors. There are 46 states, including Connecticut and the District of Columbia, that recognize the emergency medical responder as a level certification just below that of an emergency medical technician. And so far, 17 of those states, including Massachusetts and New York, have added epinephrine auto-injectors to the role of the EMR. I'll be submitting a detailed list with references in my expanded written testimony, but I'm trying to be more concise in the interest of time. You've heard the tragic story of Eddie Rabinowitz in heart-wrenching testimony earlier. I considered Eddie a brother of mine. Our families have been close for many years. And though it's a very emotional situation, what I want to emphasize is that the EMS system in the city of New Britain worked exactly the way it was supposed to that day. First responders were on scene in just 5 minutes. Paramedics arrived just 7 minutes later, but it was still too late. Now that's a paid multi-tiered municipal EMS system. Now let's take into account much of Connecticut is suburban and rural with volunteer first responders and ambulance and ALS response times far in excess of this case. Eddie's case begs the question, what if the first responders were able to give epinephrine, and would it have saved Eddie's life? That what if haunts our family to this day and should haunt all of us, because something like this can happen to anybody, anytime, anywhere. I want to thank Dr. Anwar if I could, I'm just going to say thank you. I wanted to thank Dr. Anwar for submitting SB 22 initially, and now the committee in the whole as for crafting this very important piece of legislation. I want to thank Bruce Baxter from the Britain Emergency Medical Services Foundation, who's been a strong advocate and supporter of this, and passing this bill and having it become law. Maybe we can call it Eddie's Law. Will save lives, and I ask each and every one of you to vote in favor of this bill.
Thank you. Thank you, Mr. Sierka, for your testimony. And your time was up, but when you said thank you, Dr. Anwar, I just said let him finish the sentence. I have Representative Palm who has a question or a comment.
Very quick question. I just want to say thank you, Anthony, for that moving testimony and for all the work you do for being here. It's astonishing to me that this is not a routine piece of equipment. And so my eyes have absolutely been opened tonight. And I'm just very grateful that you're here. Thank you, Senator.
Thank you. And I just wanted to share, like I shared earlier, that 3 EMS services, first responders came, not the EMS, the 3 first responders that come in one of my towns, and none of them had an EpiPen. And it's like the people who were in that home were, and it's all on video. And then I saw the video and I was very sad to see this. And that's why we wanted to push for this to happen so that we do not lose anybody. So thank you so much. Your testimony, again, puts a human face to the tragedy that's happening, and then that's a preventable tragedy. Thank you.
Thanks again.
Seeing no other questions or comments, we move on to the next person on our list, which is Sue Petorini D'Amico. Welcome.
Thank you. Good evening, senators and members of the committee. Hopefully you can hear me. My name is Sue D'Amico, and I am the Chief Nursing Officer of Johnson Memorial Hospital in Stafford Springs, Connecticut, and also the Chief Nursing Officer of Mercy Medical Center, which is in Massachusetts, Springfield, Mass. I'm here to testify in opposition to Senate Bill 1067, an act concerning adequate and safe healthcare staffing. I'm a resident of North Haven, Connecticut, and I've been a nurse for 32 years. Many of those years as a critical care nurse at the bedside. I have great concern for the proposed law that would mandate rigid nurse staffing ratios at every hospital in Connecticut. You've heard a lot of those reasons tonight, and I really don't want to repeat a lot of those reasons. I will tell you, at about 280 colleagues, a vacancy rate of 23%, 82 unfilled positions, 36 of them for nurses. We have done everything we can to try to fill these positions, including sign-on bonuses, shift bonuses, anything that we can do to recruit, scheduling, flexibility. It's very, very difficult. I also know as a nurse who's worked again for more than 32 years that making decisions regarding patient care should be made at the bedside. You've heard a lot about that today, that staffing decisions really are based on acuity and the knowledge of the people making the decisions. What I really want you to hear from me is that having responsibility for nursing care at Johnson and also at Mercy Medical Center in Springfield is unique, gives me a unique perspective, because at Mercy Medical Center, we have staffing ratios in our critical care units. I have seen firsthand the impact that these mandated ratios have had on access to care. I have been in the position of closing beds in our ICU because we have not been able to care for the sick patients who've come into our emergency room. Somebody said here earlier that hospitals won't close beds. We do. We have in our critical care unit. We've had critical care patients stay in our emergency room overnight, or have had to send them out to different hospitals because we could not bring them up to our critical care unit because we did not have the staffed beds to do so. This is putting patients at harm. So I have a direct knowledge of closing beds, of keeping people in our emergency rooms who will be overcrowding our emergency rooms when we do this. We routinely in Massachusetts look to transfer critically ill, unstable patients to other hospitals instead of bringing them to the safest place they can be, which is within our walls in our critical care unit. Mandated nurse staffing ratios will have the same impact in Connecticut. I am living this in Massachusetts. So I ask that you not take away the professional judgment of nurses and reject this proposal. And I will take any questions.
Thank you, Ms. D'Amico, for your testimony. I just was quite impressed that you are a chief nursing officer for not one, but 2 hospitals. We may have to have a bill that we'll have to have ratios for the hospital with a chief nursing officer. That'll be next year. We appreciate your testimony, and thank you for the work that you do. We have a question or a comment from Representative Dauphiny.
Yes.
Thank you, Mr. Chair, and thank you for your testimony. I just wondered, when did the mandatory ratios go in the hospital in Massachusetts?
I believe it was 2018.
2018, and have you seen an improvement in the shortage of nursing there since then?
No, not at all. In fact, you know, we all know what happened in 2019 and 2020. So the nursing shortage has not gotten any better. Their staffing ratios don't help the nursing shortage. The only thing that will help it is the things that we've talked about this evening, right? Increasing that pipeline, recruitment, retention, providing a real resiliency care for our nurses so that they really feel empowered on the job and are taken care of. Those are the things that work. A rigid staffing ratio that's mandated and takes the really the decision-making away from the people who should be doing it. I partner with every nurse who've testified tonight because I think that it's those nurses and those of us who manage the healthcare that they provide who should be making the decision and putting the patient right in the center of those decisions.
Thank you
Senator
for your
Marks.
testimony. Thank you, Mr. Chair.
Thank you, Senator Marks.
Thank you, Chair. Thank you for your testimony. So I just do question though that if you have to send a patient out because of the nurse staffing ratio, and you're saying, you know, that that's dangerous for the patient, but yet putting the patient on a floor where they don't have enough nurses to care for them is just as dangerous. And I know nurses don't always put their oxygen mask on first, we never do, but it's also bad for the nurses if day after day after day they have inadequate staffing. So truly is taking that patient that might have to be transferred to another hospital that has enough nurses to take care of them if they have a low census, isn't at the end, isn't that better for the patient?
So I have two things I will say about that. One is when we don't have enough beds, pretty much everybody else doesn't have the staff beds. We're all in the same predicament. So what we have is possibly an intubated patient on several vasoactive drips being driven around the city of Springfield looking for a hospital to land. I don't want that happening to my mother or my father or my loved ones. And I don't believe that the emergency room is a place to keep a patient like that all night. Secondly, staffing ratios in Massachusetts talk about location, not acuity. So we could have a couple of patients in our ICU that are really either step down or on medical surgical level of care, but we have not the room to move them to. So we cannot move the patient up to that critical care unit, even though the nurse can probably really care for that patient based on the acuity. It's location, not acuity. And that's what we're asking for us, those of us who understand the acuities to make those decisions.
Okay, I doubt that they're driving around while they're looking for a bed. I mean, I hope that first you find the bed and then you take them. Is there anything positive you could say about the staffing ratio in the ICU?
It's very difficult for me to find something positive about it. I think what happens is that the conversations get more difficult between the staff and those of us trying to manage them.
Do you think your staff might have positive things to say?
I won't speak for the staff, but I know that we've partnered with the staff quite a bit around the staffing ratios. I believe that they have varying degrees of opinions about it.
Thank you. I appreciate your testimony tonight. Thank you.
Thank you so much, Representative Nicole Dietra.
Thank you, Mr. Chair. Sorry. Thank you for your testimony tonight. I didn't see it online. I want to make sure that you submitted it. And if you didn't, if you could do it for us, please. Thank you, Mr. Chair.
Thank you. Seeing no other comments or questions, we appreciate your testimony. And the next person on our list is Diane Kosenko. Welcome.
Thank you. Mr. Chairman, Madam Chair, I'm Diane Kosenko. I live in Bristol, and I'm just representing the Connecticut Society of Radiologic Technologists. Thank you for the opportunity to provide testimony on Senate Bill 1228. The Connecticut Society of Radiologic Technologists is an affiliate of the American Society of Radiologic Technologists. Here in Connecticut, the CSRT represents the more than 4,000 licensed medical imaging and radiation therapy professionals currently practicing in our state. The CSRT opposes this bill as currently drafted. The CSRT agrees that a study to establish an inter-district magnet school program that provides education and training to students interested in healthcare professions is a positive step forward in attracting students into the medical field. But as currently drafted, our understanding of the pathways you have listed in this bill would not result in professional credentialing and subsequent employment of medical imaging and radiation therapy professionals. The American Registry of Radiologic Technologists is the primary credentialing organization for the medical imaging and radiation therapy professionals. Credentialing eligibility with the ARRT requires the student to complete an approved higher education program in medical imaging or radiation therapy and earn a minimum of an associate's degree. And according to the pathway proposed in this bill, Section 1, Number 1, students completing this program would not be eligible for professional credentialing in the medical imaging and radiation therapy profession. So we've submitted some revised language we hope that you agree with. This would encourage and provide curricular pathways for students to prepare for entry into higher education programs in allied health, pre-medicine, and nursing. And earlier today, the respiratory therapist, they spoke on and gave the same suggestion. So the CSRT does support the Commissioner of Public Health studying methods to address the current shortage of healthcare professionals in Connecticut. And as the CSRT does represent the more than 4,000 licensed medical imaging and radiation therapy professionals in our state, we would like to be included in the committee makeup to address the shortage and to help with the development of a plan to address such shortage. Thank you. I know it's been a long night for you guys.
Thank you. Did you submit a testimony as well?
I did, and I also submitted, and it's under my name, the revision to your bill.
Okay, we appreciate your testimony and then we will look at that for sure. Thank you.
Thank you.
Seeing no questions or comments, we will move on to the next person on our list, which is Tina Waldy.
Waldy, you got it.
Waldy, thank you. Welcome.
Thank you. Good evening, Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. I'm here tonight to voice my support for SB 1228 and specifically the inclusion of language in 3 particular areas that are connected to APRN practice. I am currently, I've been an APRN for 15 years. I'm a psychiatric mental health nurse practitioner. I'm currently the co-director of Yale Nursing's PMHNP program and also the owner of a private practice in Madison, seeing primarily children, adolescents, and young adults. The area for incorporation that I would like to see regards reciprocity for APRNs, collaboration, changes in collaboration to allow other APRNs to serve as collaborators, and also global signature authority. So I want to note first that none of these changes are scope of practice issues. There are no changes that we are requesting to change education or the practice of APRNs. This language would be inclusive and provide equity, removing barriers that many of our neighboring states have addressed. So the first issue I'd like to talk about is reciprocity. This one is personal to me. I'm a 2008 graduate of Yale School of Nursing and went in practice for the next 11 years in rural Oregon and Washington. While I was there, I worked with migrant farm workers, refugees, teens with substance use disorders, and I became faculty at Oregon Health Sciences University. And when I returned with my family to Connecticut in 2019, I required a collaborative practice agreement to practice in the state of Connecticut. It was very difficult to find a collaborator. I made lots of phone calls, tried to make lots of connections. I didn't have a lot of physician connections in the state. I did have some nursing networks. Many of the physicians that I contacted were unaware of what a collaborative practice agreement was, what it would require of them, and many stated that they simply didn't have the time to serve as a collaborator for an APRN. Ultimately, the person that I found to be a collaborator for me was a resident. When she was a resident, I was a new RN on the floor of Winnie 1, the child psychiatry unit at Yale New Haven Hospital. And so we had that connection, but unfortunately, after a year, she moved to Texas, causing an immediate risk to lack of access for my patients because I couldn't continue to practice until I identified a new collaborator. And so those are some of the barriers that can potentially impact our patients. I'd like to speak also in regards to APR and collaboration in general. Right now, Connecticut requires a physician collaborator, and I would ask that language be amended to allow APRNs to serve as collaborators for other APRNs. This, again, does not change our education or our practice, but it does maintain integrity in our profession. It also expands the pool of available mentors that are intimately familiar with nurse practitioners that are transitioning into practice, which is really the intention when collaboration was written.
Excuse me, Ms. Waldy, but your time is up. Thank you.
May I please finish my thought in terms of collaboration?
Please. Go ahead.
Thank you. So currently I write curriculum for nursing students to become psych mental health nurse practitioners. I precept them in the workforce and I'm unable at this moment in time to continue to serve as a collaborator for them when they graduate from the program. And then I'd also just like to say in terms of global signature authority that I think it's really important that we update regulations and forms that were written before APRN practice so that we can appropriately sign forms and serve in roles that are already within our scope of practice. Again, adding to the equity inclusion of APRNs in legislation. And I thank you all for sticking around for so long today to hear all of our testimony. I know it's a long day and I welcome any questions that you have.
Thank you so much for your testimony. Seeing no questions or comments, we thank you for being with us today. Thank you. Next is number 119, Robert Glaspie. Welcome, Mr. Glaspie.
Thank you. Thank you for having me. Thank you to Chairs Anwar and McCarthy-Vahey, Vice Chairs Kushner, Marks, and Parker, and the esteemed committee members. So I'd like to thank you all for your hard work, time, and effort that you've been putting into all of the issues that we're facing today. I'd like to start off by addressing 6605. This bill, unfortunately, I can't support or oppose at the moment, but I would like to start off by sharing my concerns with you about this topic. So this topic is one that should require transparency and accountability, both when making decisions that impact citizens throughout the state. Statute's very clear that DPH through OEMS has its responsibilities, as do local municipalities, which will be made clear by attachments that will be added to my written testimony. I feel no matter what the approach is that we take, what we really need is transparency and accountability throughout the process. This is important when we look at local EMS plans and evaluate the statewide system, the EMS system as it is. There's a process which was established in 2014. However, this legislative remedy is not being used by approximately 46% of the municipalities throughout the state. So the question is, how well is the process being conducted, and are local municipalities actually participating? Moving on to 1229. I consider this one to be good legislation, and we are definitely in support of that. I know that as a member of CAPE, the Connecticut Association of Paramedics and EMTs, we would like to thank legislators for hearing us, because this addition to KIMSAB of a person from an association in the state representing paramedics and EMTs will ensure that frontline first responders or frontline EMS workers are represented and not just the leaders of organizations or companies. The Connecticut Association of Paramedics and EMTs is the state's first professional association by and for frontline EMS providers. CAPE works to grow and improve the emergency medical services profession in Connecticut by advocating at the state level. Again, thank you for all of your hard work and I'm open for any questions that you may have for me.
Thank you, Mr. Glaspie, for the good work that you have been doing, and thank you for helping us with somewhat part of this bill. You have not talked about the epinephrine part. Do you want to touch on that at all, or?
Well, I mean, to be honest with you, I think that's something that Nick Paparotsky would be better off handling. I know that he's done a lot more of the research when it comes to that topic. So I'm not sure where I particularly stand on that situation right now. But I know as far as CAPE, if I'm not mistaken, he's submitted testimony for that.
Yes. And Representative Haynes had just spoken about the challenges that she has, and that's why 6605 has some value for municipal leaders who feel that the current challenges, that their responsibility for their community, they cannot fulfill that because of this patient service area law. And how do we find the balance there?
Well, I think that balance is going to come from different discussions. I think that stakeholders need to meet. I know that this past summer, CAPE was able to set up a meeting between stakeholders and OAMS. I'm not sure we weren't included in any follow-up conversation after that, but we were able to bring these two parties to the table to have a conversation about educating local municipalities about EMS, their job functions. I mean, this could be something where we look at and evaluate funding as well. So I think it's just going to it's going to be one of those things where if CAPE were to have its way, we would be able to advocate for having all of the stakeholders at the table while we delve through data and information with Benzura and look at it as a whole.
Good. We thank you for your testimony. I know my colleagues, Senator Kushner has a comment.
Okay.
Very briefly, I just want to say how great it is that you're here tonight. I know when I first met you in 2019, you were pretty unhappy with the process, and we did it the next year. And I see you got hooked on this, so it's great
Love
to
it.
have you here, and thank you for your continued advocacy.
Thank you. Definitely, I appreciate it. It's been an educational process, and I don't think I would actually have it any other way. It's been nice to be able to step out of the ambulance and kind of stay connected to that and represent that while having these productive conversations. I've really come to appreciate the legislative process and all of the hard work that you folks at the state put into these bills. So thank you.
Thank you.
Thank you. Seeing no other comments or questions, we will move on to the next person on our list, which is Melissa Moreau. Welcome, Ms. Moreau.
Hi, thank you. Good evening, Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Melissa Moreau, and I am a resident of Norwich and part-time Montville. I work as a registered nurse in the birthing center at Bacchus Hospital, and I am a member of the Bacchus Federation of Nurses. I offer the following testimony in support of SB 1067, an act concerning adequate and safe healthcare staffing. I support this bill because hospitals are using the mandation of overtime as a way to regularly staff the hospital. I have been at Bacchus for 20 plus years, and the mandation of overtime is one of the highest levels I've ever seen. When nurses are scheduled to work an 8 or 12-hour shift and then get mandated to stay for an additional 4 to 8 hours, this affects them in many ways. Sometimes they are forced to miss family obligations for fear of disciplinary action. Other times they are left searching for childcare with little notice so that their children are not left home alone. Most of them are due back to work within 8 hours, leaving them exhausted and unable to safely care for their patients. Mandation is not always due to unpredictable patient census, as the hospital would like you to think it is. In specialty units, such as mine, mandations happen frequently due to a normal amount of sick callouts or scheduled vacations. You can almost predict ahead of time when someone will be being mandated if no one volunteers to pick up an extra shift. Nurse staffing plans hold the hospitals accountable, not just to say they are doing the right and safe thing, but to make them actually do it. The nurse staffing plan for labor, postpartum, nursery, and NICU laid out in this bill is very, very similar to the Association of Women's Health Obstetric and Neonatal Nurses, AWON, suggests in their staffing guidelines. These staffing plans have been researched and are evidence-based standards of care. They promote safety for the patient and then now allow the nurse to provide the safest of care to all their patients. Isn't that what you would want if you or your loved ones were the patient? When nurses are rushed because they have too many patients and are trying to provide care to all of them, mistakes happen. This is a nurse's worst nightmare. As an RN, I went into this profession to help people in their time of need. No nurse wants a bad outcome for their patient. Simply keeping them alive should not be our new standard. Sadly, it has become the new normal in our current working conditions. We are being asked to flex more and more, and the patients and the nurses both suffer. SB 1067 will hold hospitals accountable and stop them for relying on mandated overtime to routinely staff the units, and will allow the nurse to provide safe care to all patients. I urge you to support this legislation. Thank you for the opportunity to testify, and I would be happy to answer any questions you may have.
Thank you so much for your testimony. We appreciate your willingness to come and share some of your concerns. Representative Zupkus has a question or comment.
Thank you, Mr. Chair. Good evening. Thank you for coming or staying with us so long tonight. I have just two questions. Did you mention, I wanted to make sure if I heard you correctly, that you knew that there's staffing committees already. Are you aware of that? I may have misunderstood.
Yeah, I didn't mention that in my testimony. Our hospital does have a staffing committee, is my understanding. Previously, Danielle Dufour had spoken on that. I'm not a member of the staffing committee, but my understanding is that the staffing committee is not what it should be and needs improvement.
Okay. And my second question is, no, you're from what hospital? I'm sorry, Bacchus?
Yep, Bacchus Hospital in Norwich.
Are you part of a union?
I am.
So when you were talking about overtime and all of these things, isn't that negotiated in your contract?
It is a very hard thing to get the hospital to agree to not allow us to do mandated overtime. It is one of the things that is in our contract that we do allow them to mandate us for patient care and that they must pay us double time. But they're using it above and beyond these days for just the serious unexpected incidences, and they're more using it to routinely staff some units.
And I'm not picking on you, but you said, I just have these questions. So if that's happening, then why wouldn't grievances be filed?
Sometimes they are, and they are things that are worked out. We also have labor management, and there are things that go through that.
Okay. Thank you. I appreciate you answering my questions. Thank you.
You're welcome.
Thank you. And thank you for your testimony. Seeing no other questions or comments, we'll move to the next person on our list, which is Mary Consoli. You are here. Welcome. Thank you for staying with us the whole day. You're probably an expert on multiple topics by now.
Yeah. Well, thank you all for being and staying here and willing to listen to me. Dear Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee, thank you, as I said, for being here now. My name is Mary Consoli. I've been a nurse for 50 years. I still hold a practice, an active license. I work as a staff nurse at Danbury Hospital for 25 years, and I was the president of Danbury Nurses Union for 17. Thank you for the opportunity to testify on Race Senate Bill 1067. I will briefly highlight my written testimony, which I submitted. Every citizen in Connecticut deserves the right to enter a hospital and expect quality health care. I'm urging you to support Senate Bill 1067 to protect the public you serve. At a social event in June of 2022, I spoke firsthand with many nurses who stated unequivocally things for staffing at the hospital, Danbury Hospital, was worse. They told me I retired at a good time. I've been coming before the Public Health Committee since 2008 for safe staffing. You have the ability and the power now to make a change by adopting Senate Bill 1067. Hospital executives often view hospital nurse staffing as an expense to be minimized as much as possible. They use FTEs. Many studies have proved them wrong. If you refer to the Linda Aiken study from the 1990s, which I cited in my testimony, her results showed higher nurse to patient ratios is associated with lower mortality rates, fewer healthcare related infections, fewer readmissions, shorter length of stays, and many other cost-saving measures noted in my testimony. The California ratios were based on this study. The data shows that ratios work. At Danbury Hospital, we've had a long history of using unsafe staffing forms. I was asked by my colleagues who cannot be here today, she was in the hospital as a patient, and I have them here and I would like to enter them as part of my testimony. They're the January and February 2023 unsafe staffing forms. I want to enter, the purpose of these forms is to notify the hospital that the RN will do their best to care for the patients as assigned, but in their professional opinion, it is unsafe to meet the patient needs. The hospital did not pay attention when I was working, and they continue to give limited credence to these forms.
Excuse me, Ms. Consoli, but your time is up. Thank you.
Lastly, I want to note that if a qualified pilot was not available to fly a plane for a certain flight, the flight would be canceled. Patients cannot be canceled. Nurses are the most trusted profession. I urge you to listen to the nurses and adopt Senate Bill 1067. I'm happy to take questions.
Thank you so much for your testimony. Senator Kushner has a question or comment.
Yeah.
Hi there, Mary. It's good to see you here today.
Thank you.
As somebody who lives in Danbury, I want to thank you for your service to our community for all those years and your continued service. So
my pleasure.
But I do have a question. I know that you and I've talked before on this issue, and I believe you have some experience with the hospital in terms of a staffing committee that's come up. You know, staffing committees have come up in our topic of discussion tonight. Can you tell me a little bit about your experience with the hospital and staffing committee?
Oh, I'd be happy to. I didn't include it because I had 3 minutes and I had to summarize it. I did have something in my testimony. Yes, I was on the staffing committee when we've had them since the 80s. They've called them all kinds of things, but they weren't effective. And then we had a new CEO come in, and she came up with the idea of shared governance. In fact, I was the first union co-chair president of the Shared Governance Committee. And we made some inroads, but the issue, Senator Kushner, is that the nurses weren't always released to go to these committee meetings. They didn't staff up so the nurses could leave, and someone else would have to try to take their patient load. Well, that couldn't happen. I fortunately at the time was a part-time nurse, so I went on my day off. But that wasn't practical for some people. And if you're a full-time person on your day off, you need a day off for workplace balance. So that these staffing committees, we also made plans, staffing plans, but they weren't in effect. And they weren't applied for the patient care needs. We used acuity, we had great plans, and they were submitted to the public health, but they weren't followed. What they did is they say, well, the hours per patient don't indicate that you need these, the number of nurses that you have. And not only do we need the nurses, it was the unlicensed assistant personnel that was needed. And they could answer a light or a bell. So I have had experience, vast experience with the staffing committees, but they weren't as effective as they needed to be, or we made these plans and they weren't followed. And that's discouraging.
Just to follow up quickly on that. So if a plan wasn't followed, did you have a process to grieve it through the union contract?
No, that's what we use, the unsafe staffing forms, and that's why the nurses still continue to fill these out. Because that's exactly what happens. If you have, make a med error or something happens, the nurses were protected themselves because they filled out a form. In fact, we went to a grievance process with this and up to arbitration, and it was the unsafe staffing forms. And that's why they were started. And when I took over as president, I expanded them. And Janice, who is the president now, use them. I have some blank forms. And this is what saved the nurse from being disciplined. And we've also used them because when the hospital was being sued by a patient, when the nurse was questioned and interviewed, she had a copy of her unsafe staffing form, and she showed that to the hospital's lawyer. And you know, the case, I don't think any further. I was not privy to that information. But that's why we use these forms, because the plans aren't followed. In the professional opinion of the nurse, they take the assignment, but they don't think they can carry the work done. They can give the meds, you can do the cursory treatment, but you can't do the education. Somebody's facing going into surgery. You can't sit and hold their hand for the anxiety. In fact, if I have the privilege to tell you an incident I had. As a patient, I worked 19 years of nights, and I had a patient that couldn't sleep. So I went in and I said, "What's the matter?" rather than just throw a pill at her. And she said, "I'm nervous that I wake up," because when she was told in the emergency room, she heard that she would be okay, depending how much her brain would expand, because if it swelled, because of the skull. So she was nervous that her brain was going to expand and she was going to have more of a stroke. So this is something that she heard and was carrying on about and was nervous, but didn't say because no one had the time to spend with her. And this is what you need. It may not be the physical need, it's the emotional need and the teaching needs that you can't do. And I don't know why the hospital administrations say that ratios don't work. Linda Aiken is a world-renowned researcher. Back in the 90s, this proved. In fact, we went down in 1995 and marched on Washington about unsafe staffing and how poor it was. So this is not new, and it was long existed before COVID. And it's been a problem all along, and no one's listening. And they're talking about the crisis now. There was a study done. I graduated from nursing school in 1969. And there was a study then that said, what's going to happen when these baby boomer nurses are in the workforce now? What's going to happen when they retire? Well, all of a sudden there's a nursing crisis, and that nobody did anything then. And what is happening now? And you're trying to figure out what's going to happen.
Well, thank you. I appreciate your sharing.
I got
it.
a little carried away, sorry.
That's okay. You've been doing this for 50 years. I think we need to give you more than 3 minutes to talk. But I do want to say that I want to make the point, I guess I'm assuming this, but I assume you would agree that having the forms might help protect a nurse in a disciplinary situation where there's an unsafe staffing level.
That's why we continue to fill them out.
But that's not really what you want to have, because you don't want patients to be in an unsafe situation. I'm assuming that's the reason why you're still here testifying.
I say that again, I have a hearing loss. I didn't quite get it.
I'm assuming you would say that while you can protect the nurse with those forms, you're not protecting the patient when you have unsafe staffing.
Exactly.
Thank you.
Thank you. Representative Dauphiny, followed by Representative Zupkus.
Thank you, Mr. Chair, and thank you for your testimony. We appreciate it. Appreciate your years of service. My question is, you said that every patient deserves quality patient care. We had heard some testimony earlier from an individual who runs two different kinds of hospitals, one with mandatory staffing ratios and the other without. And she described the challenges they had when they had people come into the ER and they couldn't take them due to mandatory staffing ratios, and that they had nowhere to put them, and that some of them were acute patients coming into the ER. Can you speak to that?
Sure, they probably haven't hired enough nurses, and they say they can't hire nurses now. It's because of the nurses that don't want to work at hospitals. Nursing is a great profession. We've got such a vast area that we can go into. We can become advanced nurse practitioner stuff. And the problem is they don't want to be in the hospital at the bedside. And I wanted to be able to get back to you is to do that. If they have enough nurses, it's cost effective to have the nurses, but the hospitals haven't been hiring them. And no, you can't pull them out, and you have to have some plan. And I know I'm not answering the question that you asked, but what they have to do is, if they did have positive work environments, as data has proved, then they would have the nurses there and they wouldn't have a nursing shortage. And that's the point that the nurses are making. If there were good work conditions, nurses would be working at the bedside and wouldn't have to try to recruit them.
Thank you for your answer. That's not how she described it. She did say that they had imposed mandatory ratios and that the shortage never improved. And this was over several years. So that ratio didn't enhance more nurses coming to the hospital to work for them. That's just my comment, but thank you for your testimony. Thank you, Mr. Chair.
You know, and I can't, testify. We can only theorize what had happened, but according to the data in the study, that the higher nurse patient ratios is cost effective and would help and lower the cost for the hospital. And, I don't know how it was implemented or how it was done.
Thank you.
But,
Representative Zupkus has a question or comment.
Thank you, Mr. Chair. Thank you for coming and congratulations on 50 years. That's amazing. I do agree with you about people being anxious. I know I went through surgery in July and my husband couldn't come in with me. And I was scared to death, to be honest. And the nurses were fabulous because it was horrible, especially because I'm scared of needles. So, it was bad, but they were wonderful. So I completely get that compassionate side also. And I think nurses are very compassionate people, everyone that I've dealt with. My question is, because I asked the woman prior to you, and you were talking about, I think you were head of the union, right?
Yes.
So with these issues, why can't the union do something?
We've tried. And what we do is we keep filing because the nurses get tired of fighting. We had the ICU nurses who had this wonderful plan. We took it all the way up, and the day before arbitration, we met with the hospital and we devised a plan to do this. This nurses felt that it was important to go to arbitration because our new heart unit in ICU was put in peril. So they were doing this. They developed this plan on their own, and they said, this is what we need to do. They showed how they could improve it with the nursing plan and hiring more staff. That was the bottom line. And the nurses, it was implemented 6 months and then it was stopped. And then we were going to take up the arbitration, and the nurses said no. She quit and left the hospital, the one that spearheaded this, because they were tired of fighting, and it just wasn't anything made a difference.
Thank
And they
you.
didn't want to continue.
Thank you. So I guess what I'm hearing is that the unions really can't do anything. And it,
No, I beg your pardon. The union can do it. The union is the one that gave these we developed these unsafe staffing forms to protect.
yeah, those forms
to
sound good.
protect-
That's,
To protect the union. And we have, we agreed to the staffing committees, because if it wasn't for these union staffing committees, we wouldn't have any at all. So we're making some inroads
mhm.
to try to help, and we're trying to work with the hospital. But if you can't, if you don't allow the nurse to be on the committee, and you can't, you don't have the staff to release them, and the nurses can't come in for the day,
Right.
how does that help?
Well, I do agree that that should be something, because everybody should be able to make the meeting and they should have their input. So, but thank you.
You're welcome.
Thank you.
Thank
Mr.
you so
Chair.
much for your testimony. I just wanted to ask you a quick question.
Sure.
First, thank you for being here and the work that you have done all these years and the work that you continue to do with your advocacy work. We just heard today from some of very smart, intelligent leaders from our state and beyond, who are nursing leaders, whether they have been in the positions of larger responsibility for hospitals or for the nursing associations. Their perspective is that the ratios do not matter. But when I look at the Linda Aiken study, which was a landmark study, which resulted in the Institute of Medicine giving her an award because it was a landmark study about the ratios and how the patient health outcomes were so different that it revolutionized how we should look at medicine. Did the Institute of Medicine make a mistake? Because all these experts are telling me otherwise today.
No, I don't think they made a mistake. I don't know what the experts are saying. They didn't try to implement the care. And if you, one of the groups that I referenced, they did an international study. This information has gone out, it's worldwide. So saying if you implement the ratios, you're going to end up, it's not going to happen overnight. If they started it tomorrow, in 5 years, it would be better. That the outcome, the patient outcomes and the cost is better for the hospitals, but the hospitals don't see it that way. And when I was on the shared governance committee, they didn't share their fiscal and financial details, so we could really work and develop plans. We kind of worked on these shared governance committees in a vacuum because we didn't have the real basic numbers. They went by FTEs. And if and that's why you're talking about, what are you going to do if the census drops? God forbid that nurses can get to lunch and go to the bathroom. So that's one of the things. They just went by numbers.
Okay.
And there's a nursing shortage. The patients aren't getting cared for now. So
All
they
right.
think the ratios aren't going to help. They're wrong.
Thank you
my
so much.
opinion.
So I think the Institute of Medicine was not wrong in awarding her for the study and the work that she did, which revolutionized how we should look at nurses. Senator Kushner has a question or comment again.
I'll keep this
I'm
brief.
I'm sorry if I misinterpreted. No, they were not wrong to give her the award.
I was just making that same comment. Do you want to turn your mic on? I think we may have
Did it?
closed. Thank you. We got.
Okay. Yes.
One other issue that has come up and relates to this conversation is whether or not the hospital is required or voluntarily posts the ratios somewhere publicly so that people can know exactly what the ratios are at any given time. Has that ever happened?
No, and I think it should be done. And just put yourself in this situation, Senator Kushner and the committee. Would you buy a house if you did not know how many rooms you have, what your taxes were, what the electric bill is, what the water bill is? Or would you buy a car without knowing what all the expenses are? You wouldn't do it. So why would you go to pay and go to the hospitals, or actually the insurance pay, when they don't know what the service they're getting, what the staffing plan is? Posting the staffing plan is simple. That should very simple task for the hospital to do. So if someone wanted to know what's supposed to happen, what is the plan? And then when they say, when they ring their bell and there's nobody there to answer, then they know, why.
Thank you.
Thank you. Thank you so much for your testimony. We appreciate you being here. Thank you.
Thank you all. Thank you all.
We were earlier here, we made a little mistake. Our actually behind the scenes administration has been telling us about somebody that we had skipped earlier by mistake, and then that person has been waiting for a little while. So it was because of a technical issue that we were experiencing. Melissa Willett, if you can join us, we will appreciate you joining us, and please accept our apologies for missing you earlier. Welcome.
Thank you, sir. I appreciate it. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Clarice Detria, and distinguished members of the House Committee on Healthcare. I join you this evening to testify regarding the policies reflected in Senate Bill 1228. My name is Melissa Willett, and I'm the New England Region Liaison for the United States Department of Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. Our office works with policymakers, elected leaders, and stakeholders on issues affecting our military service population. Taking care of people remains the top priority of the Department of Defense and is at the center of our national defense strategy. Military spouses provide the strong foundation upon which their loved ones in uniform stand, and both our communities and nation rely on their resilience. To further expand employment opportunities for military spouses, the department views passage of interstate licensure compacts as a barrier reducer for spouses who must go through the often challenging and frustrating process of transferring their professional licenses with each move. Should the Public Health Committee include compact language in Senate Bill 1228, the Department of Defense would certainly support those policies. To address license portability for military spouses, states have turned to occupational licensure interstate compacts, which streamline relicensing between member states of a compact for all practitioners in an occupation. This is significant for military community in that, along with active duty military spouses receiving the benefit of compacts, active duty members, members of the reserve component spouses, transitioning service members, and other veterans benefit from the mobility provided through the compact. There are many unique requirements that come with a life of service in the United States Armed Forces, and those requirements are not only bestowed on the service member, but also on the spouses and children of those who serve. For military spouses in particular, professional licensing requirements remain an enduring challenge. Due to the nature of the military, most active duty service members change duty stations every few years. Not only is the service member expected to reacquaint themselves with a new installation, unit, and command, the spouse too is forced to reinvent themselves professionally. The Interstate Counseling Compact would allow counseling professionals to transcend these boundaries. Frequent moves and cumbersome licensing and certification requirements limit career options for military spouses. Removing these barriers, creating reciprocity in licensing requirements, and facilitating placement opportunities can help a military family's financial stability, speed the assimilation of the family into its new location, and create a desirable new employee pool for a state. With the above stated benefits in mind, we look forward to engaging in efforts that will create increased quality of life for all populations we aim to serve. We appreciate the opportunity to provide comments this evening, and I'd like to thank you for your time and support.
Thank you so much for your testimony. My co-chair has a question or comment.
Thank you. Very briefly, Melissa, I want to thank you for your testimony. And as a longtime military spouse, though I didn't have licensure issues, I know when I moved here to Connecticut, it was a difficult transition. So I appreciate what you're saying. And as you probably have heard here before, this is a conversation that we hope to continue. Thank you, Senator.
Representative Reddington Hughes has a question or comment.
Thank you, Mr. Chair. And I too appreciate this. My husband was a Naval Academy grad, and we certainly moved every 2 years for a long while. My question is, are you suggesting that this would be license portability for only the military or for everyone across the board?
Everyone across the board that is a counselor, we support the compact because many of our military spouses hold such professional licenses. So we're just advocating for that specific part of the population.
Oh, thank you very much.
You're welcome.
Thank you, Ms. Willett, for your testimony. And I just wanted to mention that this was not a policy issue from our perspective. We agreed with the policy. It was just a bandwidth issue because it's very complex to write state laws, which would have compacts across all states. So it's a lot of work because we have to change every part of the statutes for the state, and that's part of the complexity. But your testimony really helps, and we will see if we can figure out ways of increasing our bandwidth to change this and improve this. So thank you so much.
Thank you.
Seeing no other questions or comments, we'll move on to the next person on our list, which is Lauren Pisto. Lauren Pristo, you're on. You're muted.
Sorry
Well-
about that. Good evening, members of the Public Health Committee. My name is Lauren Pristo. I'm Director of Community Engagement at McCall Behavioral Health Network. I have a master's in public health and epidemiology of microbial diseases from the Yale School of Public Health. Over the last several years, I have had the privilege of working alongside many community partners in the northwest corner of the state, committed to addressing the overdose crisis. As a result of these partnerships, I have been a part of implementing and conducting community-based programs, including harm reduction throughout the region. You have heard from many of my colleagues and fellow supporters of Senate Bill 9, Sections 4 and 5 regarding the value of harm reduction centers, also known as overdose prevention centers. I would like to underscore the importance that we take this courageous step towards improving access to care for people who use drugs. As a community, we must admit the systems we are depending on to save folks who use drugs are failing us. And as a society, we have historically pushed people in need of support into the shadows, deeming them unworthy of care or connection unless they're abstinent. However, we know that it is in those shadows alone where people are dying. We cannot sit back and leave the treatment system as it is, with barriers and gaps in services that have proven deadly. We cannot sit back and wait for someone to be deemed ready and morally deserving before they can receive critical care. While some of our community providers have made strides towards integrating harm reduction into every level of care, we still have a long way to go. We are missing a key entry point into the system at this time, and overdose prevention centers are a necessary intervention to fill that void. Let's lead the way in shifting towards compassionate care that will be critical in saving many lives, just as the examples today from around the world have shown. Thank you.
Thank you so much for your testimony. We appreciate you being with us today and the good work that you're doing and your advocacy. Seeing no questions or comments, we will move to the next person on our list, which is Robert Heimer with the Yale School of Public Health. Dr. Heimer, you're on.
Good evening. My name is Robert Heimer. I'm professor of epidemiology and pharmacology at Yale. I've been working on the problems related to unsafe drug use, opioid overdoses, inadequate treatment for opiate use disorder for more than 30 years. This work has evaluated projects to identify programs and policies that actually solve these problems. We've shown that increasing medications for the treatment of opioid use disorder can lower overdose rates. We've demonstrated that harm reduction programs that distribute naloxone can train the individuals in communities who are most likely to witness an overdose and to do so safely and efficiently. Over the past decade, as overdose doses have tripled in the state, this has been despite the implementation of some harm reduction measures, because the changes in the illicit opioid markets have made consumption more dangerous. Therefore, reducing opioid mortality and morbidity will require further actions, especially those that deter individuals from using opioids alone. One such action would be the establishment of harm reduction centers as proposed in SB 9. The benefits of this are obvious. Trained providers can offer medical treatment in the event of an emergency. They can attend to soft tissue infections and necroses that produce significant morbidity among those who inject drugs. They can provide clean injection equipment that reduces HIV and hepatitis transmission. They can initiate medication-based treatment for opioid use disorder with buprenorphine or refer people for immediate entry to programs that dispense methadone. While harm reduction centers remain controversial in the United States, there's a 20-plus year history of their effectiveness in other countries throughout Western Europe, in Australia, and in multiple locations in Canada. After thousands of doses of illegal drugs taken in harm reduction centers, no fatalities have been reported. This is also true based on reports from the 2 centers operating openly in New York City and the underground one that has been operating for 9 years in California. These programs have attended to the medical needs of people using drugs and reduced community nuisance by affording people clean and sheltered places to use their drugs and assisted in reducing or eliminating people's use of more dangerous illicit drugs. In sum, the health benefits far outweigh the detriments, and there are potential cost savings if the number of overdoses that require EMS response are decreased. SB 9 proposes a pilot program of 3 centers to be determined by DEMA's commissioner in conjunction with the municipalities where the centers are located. This is similar to 1990, when the Connecticut legislature courageously voted to allow a pilot syringe exchange program to open in New Haven. I was part of the evaluation of that program, which became a bellwether, leading other U.S. jurisdictions to begin reducing HIV transmission among people who inject drugs. When that program started, there were 650 new infections diagnosed each year in the state of Connecticut. In the last 5 years, we've averaged 16 per year. That's a 95% reduction, better than prevention achieved by most vaccines. Syringe access was a big part of that decrease and the first of several interventions that reduced HIV transmission. I hope that history will repeat itself and harm reduction centers will become the first of several synergistic strategies that reduce opioid overdose deaths. With these facts and Connecticut's history in mind, I fully support the passage of SB 9 with the expectation that the establishment of a pilot program of harm reduction centers will further the reduction of opioid overdose deaths seen in 2022 as another key harm reduction step is introduced in Connecticut. I have only one quibble with the legislation as proposed.
Excuse me, Mr. Heimer, but your time is up. Thank you.
Thank you so much, Professor Heimer, for your insight. This is very helpful, and thank you for drawing the historical background of critical decision-making that happened in a similar time when there were legislators who listened to the science and made the policy and then changed the direction of HIV spread in our state. And we are pretty much in the same ballpark right now. I have Representative D'Amico who has a question or comment. Representative D'Amico.
Yes, thank you, Mr. Chair. I couldn't help but notice Dr. Heimer said he had one quibble. If he can do it briefly, I'd like to hear the one quibble with the legislation as proposed, Dr. Heimer.
Yeah, the one quibble is that Section 5 calls for the establishment of an advisory committee, but key stakeholders have been omitted from the list that's in the bill. There's no one with community experience or research expertise in harm reduction included in that list of stakeholders, even though such individuals have provided the practical and analytical foundations for the potential of harm reduction centers to reduce opioid overdose deaths. I hope that SB 9 can be amended to include such individuals.
Great, thank you, appreciate that. Thank you, Mr. Chair.
Thank you. Senator Marks has a question or comment. Oh,
Yep, thank you. Thank you, Dr. Heimer. I actually think we should call you a rock star because I live and represent New London, Connecticut, and I have heard your name so many times when I work with the not-for-profits who are working to combat this pandemic. So I thank you for your dedication to this cause. My question is to you, what are the positives for the communities that decide to be one of the pilots for this program? I'm sure it's going to be a little difficult to find some communities that will say yes to this. Can you just briefly tell us what some of the positives are for those communities that raise their hand and say, yes, we'll take this on?
Let's start from the perspective of the individual drug user who's not going to die. Let's add to them their family members, friends, and loved ones who won't see a friend and relative die. Let's recognize that such centers will replace public injection and public nuisance by bringing people to a place where they can use the drugs they're going to be using anyway more safely, with less apparent or obvious, external awareness on the part of the community. And for many of the people who use such programs, the evidence suggests that these people, if their drug use can be stabilized, will eventually move toward seeking treatment and moving away to, or at least reducing the amount of their illicit drug use, which is a benefit for everybody.
Thank you, sir. And it was a privilege to have you speak with us tonight.
Well, thank you for the opportunity.
Thank you, Representative McCarthy.
Thank you very much, Mr. Chair. And just very quickly, good evening, Doctor. Can you tell me, with your experience, and I know worked with you in New London, is there any data showing that individuals that go into the harm reduction center later seek the treatment? Do we know what the percentages of individuals that go on to get treatment and then go on to stop using the drugs?
The funny thing is that when these programs were set up in Europe, they were set up sort of as a pragmatic approach. They weren't really studied. So there's really no hard data on that, except the anecdotal notes that people always talk about. And I know that the plural of anecdote isn't necessarily data, but I think that most people will tell you that at least some of the people do go on to seek treatment. And it's especially true that one of the things that encourages people to continue drug use is that living a chaotic life of a drug user sometimes means that you're actually using those drugs to, how would you say it? Not have to focus on the amount of chaos in your life. If something provides stability in your life, then you can focus on making things better. So between the sort of self-evident benefit of helping people to stabilize their lives and the anecdotal data, I think we can suggest that it's probably worth setting these things up in Connecticut, these harm reduction centers, and studying this to find out, as we did with needle exchange, 30 plus years ago, to demonstrate the benefits of setting them up.
Thank you very much.
Thank you, Senator Gordon.
Thank you very much, Mr. Chairman. And Dr. Heimer, thank you very much for your testimony. If I may ask a question, very many hours ago, we heard from the Commissioner of the Department of Mental Health and Addiction Services, who raised concern, just not in verbal testimony, but also in written testimony, about setting up such facilities in Connecticut because of federal law. I don't know if you happen to be aware of her testimony, but my question to you through you, Mr. Chairman, is what concerns do you see regarding existing federal law and how that might prevent or create a legal quandary if the legislature were to move forward and authorize these types of facilities? Thank you, Mr. Chairman.
First, let me say that there's still federal prohibitions against marijuana, and the state of Connecticut nevertheless sought to legalize recreational marijuana. So I think we have some precedent for the idea that Connecticut can buck the badly designed, ill-conceived measures and public health practices in order to improve the health of our community. Second of all, I think the experience in New York and the ongoing court case in Philadelphia, where they tried to set up one there that's moved through the court slowly, but has almost always favored the rationale for the establishment of these types of centers, suggests that we're not going to see a lot of blowback, at least during the current administration, I can't tell you what will happen if there's a different kind of administration in Washington. We did see that with the establishment of needle exchange early on, that there was some political blowback. And I think one of the things that we did by conducting a scientific evaluation of the needle exchange program 30 years ago was to have the data to say all of your concerns about the downsides of such programs are misplaced.
Thank you, Mr. Chairman.
Thank you, Professor Heimer. I just wanted to make a quick comment. I've known about you for a long time. I joined Yale in 1995, and I actually learned about the program that you had started, and my knee-jerk reflex was, doesn't sound right. And then I started to look at the data, and I said, oh my God, you're way ahead of your time. And it was pretty brilliant. And so I was a student at the School of Public Health, and we never exchanged, our paths did not meet in the past, but it's such an honor to have you. And I agree with Senator Marks, you are a rock star. You've been a rock star all these years, and you continue to be one.
Thank you. I'll be on tour again next week.
All right. With that, we'll move to the next person on our list, which is Clarice Fairbanks, who is here. Welcome.
I have good afternoon here. I guess it could have been good morning, but now it's good evening. So good evening, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Clarice Ditria, and distinguished members of the Public Health Committee. First, as a nurse for 37 years, I want to personally thank you all for listening and caring to everyone's testimony tonight. My name is Clarice Fairbanks, and I'm an advanced practice registered nurse and APRN, specialized and board certified to provide psychiatric mental health nursing care in the state of Connecticut. Thank you for giving me the opportunity to testify today in support of Senate Bill 1228, an act concerning the state's healthcare workforce. Advanced practice registered nurses like myself are registered as independent healthcare providers in the state of Connecticut. I independently assess, diagnose, and treat the acute, chronic, and complex psychiatric mental health needs of the residents in Connecticut and have been licensed here since 1993. I'm here today advocating for experienced APRNs who are registered with Connecticut DPH as independent clinicians to be added as collaborators for new APRNs, along with current physician collaborators. This will allow new APRN graduates to enter into their required collaborative agreements without hindrance or deterrence. My Connecticut licensed business is psychiatric wellness care, and my private practice services the residents of Connecticut, providing much needed psychiatric care. I take almost all insurances, including Connecticut Husky Medicaid, and within the last 6 months, I have had to turn away from hiring 2 psychiatric mental health APRNs who wanted to join my private practice full-time. In order to grow my practice to care for the people of Connecticut who overwhelmingly look to me for additional mental health care, I need to hire additional APRNs. I actively assisted the 2 APRNs in finding a collaborative physician without success. The 2 APRNs could not find a collaborative physician anywhere in this state. Every physician we contacted was unwilling to be a collaborative physician, even after lengthy explanations of the role. One of the APRNs has moved to another state to practice specifically because of Connecticut's physician collaborative agreement restriction. As an assistant university professor, I've taught many students over the years in Connecticut, Massachusetts, and Rhode Island colleges, and experienced APRNs like myself are the strongest collaborators for new graduates. And I want to be clear that I'm not here to testify about taking away the 3 years of practice or the 2,000 hours, but to expand the collaborative agreement to include APRNs. So I would like to stress to you that none of these are scope of practice issues or scope of practice changes. And
Excuse me, Ms. Fairbanks, but your time is up. Thank you.
Can I say my last sentence?
Please finish your.
I was just going to say, please allow experienced APRNs like myself to collaborate along with physicians to guide new APRN graduates so that we can give the best care to Connecticut residents.
Thank you so much for your testimony, and thank you for staying with us throughout the day. We appreciate you being here and the good work that you do. We did have a conversation with DPH, and they do feel it's a scope issue. And then I think what we should do is have a conversation and more in-depth discussion about how we can make this happen. I think what we've heard from a number of APRNs, I think few who have spoken, there is a structural issue. So if, for example, somebody had spoken that they were having a conversation on the phone for oversight, that is no clinical oversight, because you can't do that on the phone. Maybe in the pandemic, perhaps, but not anymore. And so we really have structural issues, and we also need to find out why is it that the physicians are not having the APRNs be collaborators with the APRN. So I think that's something that we have to look at. We heard some testimony a few weeks ago about that, but I think we need to go deeper into the understanding and fix this for sure. So your testimony is truly appreciated.
I also submitted it as written as well.
Thank you. Thank you so much. And with that, let's move to the next person on our list, which is Kaylin C. Welcome, Kaylin. Good to see you again.
Hi. Good evening, everyone. Esteemed members of the Public Health Committee and Chair Senator Anwar, thank you so much for having me this evening. My name is Kaylin C., and I'm the Senior Director of Programs for OnPoint NYC and the operator of the two first public overdose prevention centers in the United States. You've heard from many experts this evening from all around the world, so I'll not touch on their powerful testimony that speaks to the evidence that supports this intervention. I'll speak very specifically to what's happening in New York City and its relevance to what you're considering in Connecticut. First and foremost, I'll let you know that our centers have far outperformed the projections of both New York City and New York State Department of Health in terms of this intervention's ability to engage successfully a very difficult to reach and engage population of people who uses drugs in New York City. To date, we have over 3,000 people registered to the two consumption sites, one in Washington Heights and one in East Harlem. The sites have been used just under 70,000 times. That's 70,000 instances of public drug use that were picked up out of the public sphere and put down somewhere safe, private, and dignified, connected to additional supports, including mental health care, traditional medical care, buprenorphine, connections to detox and treatment centers, holistic health services, case management, etc. I'll also mention that since launch in November 30th, 2021, our team has intervened in just under 850 overdoses, many of them 75% fentanyl involved overdoses, and we've only called the ambulance 14 times. The estimated cost savings to the emergency services and hospital system is well over $25 million. And this doesn't take into account the projected cost savings to police and law enforcement. In New York in particular, we have something called the Fentanyl Task Force, which means for every overdose call, detective level officers are dispatched to attend. Before opening the overdose prevention centers, it was not uncommon for up to 11 officers to attend a single overdose call. That has evaporated with the implementation of the overdose prevention centers. But that doesn't mean that the police and law enforcement are excluded from our operation. In fact, it's quite the opposite. The partnership with NYPD is something we're the most proud of in New York, in addition to, of course, the lives that we've saved and the people that we've engaged into this very unique program. We work very closely with the NYPD in both of our neighborhoods, and they don't often get a lot of good press. So I'm always keen to shout them out for being really lockstep with us in this journey to successfully launch this program. For us, working with the NYPD was not if we should, it was how we should, and the NYPD were the same. They wanted to know what we needed from them to support the operation of the site. And our simple feedback for them was, if people are afraid to use the site, it won't work. So as long as you're not impeding their access, we expect you to continue with community policing in the neighborhoods where we both operate. And we'll do our very best to take a big piece of work off your plate, which is, of course, the low-level enforcement of street-level drug crime, petty crime and recidivism, and the overdose work that we were doing. There is also, of course, an irrefutable—
Excuse me, Misty, but your time is up. Thank you.
Okay. I'm happy to pause there for questions. I'll just wrap up this last thought. The positive impact on public safety is quantifiable in the case of New York. Between the two sites, we've removed over 2 million units of hazardous waste from the parks and public spaces in New York City, because none of the paraphernalia that is dispensed to people within the site to use there leaves the building. Beyond that, we're doing a lot of drug testing in partnership with the health department and relaying that information to PD as well. So we're able to do a little bit of mapping within the city in partnership with law enforcement about overdose and fatality hotspots, and triage those really effectively in partnership with the Overdose Prevention Center. I'll pause there to see if you have any questions, and thank you for your time.
Thank you, Kaylin. Good to see you again. Thank you for your testimony, and thank you for hosting both me and Representative Mara a few days ago. I think it was a week ago, but all the days have become one big day for us.
It was my pleasure. It was great to have you with us.
I wanted to ask you a quick question. Could you talk to us a little bit about the financial component and the support component, if you feel comfortable, about how it's sustained? And it's important because we had our commissioner and others tell us that it's going to be difficult even with the opioid settlement fund.
Yeah, that's a great question. So as we've seen from our partners in Rhode Island, and we now have the New York example, there are multiple funding pathways available and in practice for overdose prevention centers. Rhode Island, as you know, is using the opioid settlement fund money. We're not doing that yet in New York State, but we intend to, and we're continuing to advocate for that at the state level. Our partner and our strongest funding partner has been New York City Department of Health. They've been instrumental in allowing us to not only support the overdose prevention centers, but really co-locate the overdose prevention center within a larger harm reduction hub, offering closed loop service provisions. So co-locating medical services, mental health services, holistic services, additional harm reduction services, and the overdose prevention center all in one space. Where the sticking point is, of course, funding the activity of observing consumption. But when you look at a time and effort breakdown of the activities that are occurring within the room itself, within the overdose prevention center itself, what you find is that it's really a minute amount of staff time and effort that is actually expended for the activity, the actual act of observing consumption. Comparatively, every other activity that takes place in that room, whether it be safer use training, wound care, overdose prevention, overdose intervention, care planning, connection to case management, medical care, cleaning, stocking, staff training, etc., are all funded activities and widely acknowledged to be evidence-based public health harm reduction interventions for people who use drugs. 98% of the activity that happens within that room falls under that category of fundable activities. So we are very grateful to the robust financial backing of New York City Department of Health for the vast majority of our efforts within the Overdose Prevention Center and beyond its doors in other parts of our building. What is still under contention is that last 2% of effort. But having said that, I think the point I'd like to make is that the health department, as a funding partner for this work, will be an important asset for local jurisdictions who are considering mounting these sites. Really, what we're seeing at the federal, state, and local landscape is that strong backing from city, local jurisdictions where these problems are happening at a micro level, and just beyond them at the state level, will really win the day for overdose prevention centers.
Thank you so much. I just wanted to clarify a couple of things, because when we visited the site, you're helping individuals with their social work. There was a care coordinator, there was behavioral health support, there was mental health treatment, there was physical health treatment. You were taking care of individuals' wounds. There was a place for them to rest at times. There was also nutritional support. There was, along with that, you had somebody to do hairdressing as well as laundry services. So it's all of them under this very, very small part of observed consumption. That's the part that actually is under contention, but everything else is part of a comprehensive care of individuals who need the care and love. Is that a fair way to put it?
That's a fair way to put it. And I'm really glad you're not under a 3-minute time limit because I couldn't fit all of that in. But yes, it often we're very fond of saying the least interesting thing that happens in our harm reduction hub is actually the drug consumption itself. Interestingly, and this is sometimes a little bit difficult for people philosophically to wrap their heads around, it's allowing the activity of drug consumption to occur that provides us a platform for engagement with this population that no one else has. Because there are no other sites in the US, it's difficult for us as a public to take this leap together. But for people who have operated consumption sites in other parts of the world, what we know fundamentally to be true is that this is an engagement tool unparalleled by any other. Oftentimes, people visit the site multiple times a day. For instance, in New York, the average visit to the Washington Heights site is 51 minutes. The average length of a visit to the East Harlem location is 38 minutes. If you sort of multiply that by 1, 2, 3, 4 visits a day, you now have a captive audience open to additional services, medical care, mental health care, discussions about medication-assisted treatment, discussions about tapering, maintenance, reduction, housing, dental work, podiatry, holistic care, hygiene, all of it. You have a captive audience willing to listen to trusted healthcare professionals, because that's what people who work in these sites are, sort of guide them and accompany them when they are ready for further care. A case management session, by comparison, is maybe 15 minutes, maybe 20 minutes once a day, once a week. And we see people much more frequently and for much longer duration.
Thank you so much. My colleagues have questions and I have more as well, but I think my colleagues will be asking the questions that I'm going to ask. So I will start with Representative Zupkus, go to Representative DiCaprio, and then to Representative Carpino, and then to Representative Mara. So
Thank you. Thank you, Mr. Chair. Thank you for coming and explaining. I do have some questions. Senator Anwar started one about the funding. So you do get some money from the state?
We do. I want to be clear. Our two main funders are New York City and New York State Department of Health. New York City is by far our largest funder. New York State is second. New York State currently is not funding any activity within the Overdose Prevention Center itself. We're hoping and we're optimistic that that will change soon. Certainly that's their intention at the Office of Drug User Health located within New York State Department of Health. And we are not currently using opioid settlement funds. Right. We do also have foundation and discretionary money that we're carrying the sites before we transition to a different funding model with New York City Department of Health, which is more in line with what I was describing as the time and effort sort of allocation of funding.
Great. Thank you. I do have a couple of questions and they're only going to give me a couple of minutes. So are you part of a state agency?
We're not part of a state agency per se. We're a community-based organization, a 501c3, but we are a New York State waivered syringe service provider and sort of harm reduction entity.
So you're so 501c3, and are you licensed by the state?
I wouldn't say it's not a formal licensing process in New York State. It's more of a wavering process. It's not really a licensing process.
Okay, great. And my last question is, you talked a lot about all of the services that you offer and the opportunity of how many people you get to meet each and every day, which is, I don't really want to use the word amazing, but it is amazing that you can have contact and offer these services to these people in need. And so do you take these folks that come in and try to get them all into recovery and offer them all of these services, or is it just voluntary if they choose to do it?
That's my favorite question. I really appreciate you asking it. When people say, what is the point of these sites? Is the point of these sites sobriety and abstinence? I want to be very honest with you. It isn't on its face. The objective of these sites is the successful engagement and stabilization of a very high-risk population who are, generally speaking, not connected into any kind of care at all. Once you start to achieve stabilization and consistent, reliable access to a safe consumption site or an overdose prevention center is what promotes stabilization and safety. It's what encourages people to leave behind the traits and the behaviors associated with survival drug use. And a great example of that would be, ooh, I don't know when I'm going to have access to this McDonald's bathroom again. This is my one shot for the day because I could get arrested if I'm found outside loitering by a business. I'm going to do all of the substances I have on me now. I overdose in the bathroom and I pass away. So that's survival drug use. Consistent access to a site where you can safely practice maintenance use, work with our health educators, where you don't have to use large doses of drugs all at once because you can come back if you need to. That's when people start to believe that they can be maintenance drug users and they can sort of be stable in their drug use. It's from that platform of stability that people all of a sudden, and it usually happens around the 6-7 month mark, it takes time to achieve stability, especially if you've been practicing survival drug use for a long time. It's from that platform that we start to see that you're suddenly a better candidate for housing. You become interested in medication assisted treatment, right?
With them. Yes.
Right.
Yes.
But what I will say, just to wrap that up, is that 100% of the people who have access to, oh, I've been muted. Okay. I think I was muted. I don't want to overstay my welcome. So if I was muted because I was going on too long, I apologize.
Reb Zupkis, you're muted. The whole CTN is muted.
Do you think they can't hear us?
They cannot hear us.
Okay, I'm going to text them.
Yeah, and unfortunately, you were not muted. I think we just lost the feed somehow. There's been weird network issues all day.
We can hear you.
We
Can
can
y'all
hear you,
us?
so don't say anything you don't want us to hear.
Oh, me?
You must
We can
be
hear
back.
you. We can hear you.
Oh, I thought I was going on too long. I just wanted to wrap that
Thank you,
thought
but
up.
yes, so thank you. But I am allowed only one more question with you.
Go.
I just need a number. If you could please tell me what your success rate is of getting people off of drugs, like a number.
You're going to love this. I can't tell you that. What I can tell you is that 100% of the people, I told you just over 3,000 people have been registered to both overdose prevention centers. 100% of those people have been to detox and treatment, on medication assisted treatment, on methadone, many times. 87% of that over 3,000 have been connected directly into treatment services, healthcare, or mental health care from the overdose prevention centers. We are just about to release a 1-year report, which will give more specific numbers on treatment adherence, periods of sobriety, etc. But that report is not quite ready to come out yet. What I can tell you is that the early impressions are really positive, but I will not tell you that the site.
Can't give me a number.
I can't, no.
That's okay. Thank you. Thank you for answering my questions.
Thank you. Next is Representative DiCaprio.
Thank you, Mr. Chair, and thank you, Kaylin, for your testimony.
Just on the hazardous waste units you mentioned, just the, are these, you're talking about sharps, are these for individuals? Is that what this is? And just the number again that you mentioned, because I thought it was a significant number.
2 million. 2 million units of hazardous waste. So that would be syringes, pipes, drug baggies, crack cocaine vials, Band-Aids, gauze, cookers, things of that nature would be considered a unit of hazardous waste. And those are all collected by our outward facing programs, which are a very integral part of the overdose prevention center model. Whenever you open an overdose prevention center, you open an outward facing program that complements it. So those would have been collected in the neighborhoods where we operate during the hours when we're closed, because we're not 24 hours. So we're only open during the day at the moment, working towards 24-hour expansion at both sites. And in the other neighborhoods that we serve.
So again, just for clarification, is that one per person, or is that a volume of materials?
Great question. So, and I should clarify that includes all of the hazardous waste that does not leave the overdose prevention center, because it all stays in the room, right? So that's diverted from parks and public spaces. With fentanyl, the game has kind of changed. So it's not generally per episode of use or per instance of use or dose, as we call it. It's often not just one syringe that's generated. It can sometimes be up to 5 or 6 syringes per individual per dose. In New York, the vast majority of the overdoses are polysubstance overdoses. And in the neighborhoods where we operate, speedball injection, so the administration of a stimulant and a depressant at the same time, is very popular. Speedball injectors often consume drugs up to once an hour if they can. So you can imagine in one 24-hour period, when we think about the half-life of fentanyl in the body, which is 2 to 3 hours, and the half-life of cocaine in the body, which is 45 minutes to an hour, speedball injectors can sometimes be producing just one person up to 20 to 30 syringes a day. This doesn't account for all of the additional paraphernalia that can be produced by speedball injection. This wasn't the case when people were using heroin, the half-life being 4 to 5 hours. There were far fewer syringes produced when heroin was the drug of choice and more available than fentanyl.
Okay, thank you for that. The reason I ask, I have some experience with meth lab cleanup in Connecticut, and so anyway, just curious about that. Thank you very much. Thank you, Mr. Chair.
Thank you, Representative Carpino.
Thank you, Mr. Chairman. Caitlin, thank you for your time, but I'm going to ask you just a couple of questions, and I'm hoping you can give me some short answers to.
I'll try.
No, it's okay. I appreciate all the information you're sharing. I just want to be respectful to all of the folks that we still have to hear from. So I just want to, my first couple are just, I want to confirm some information that I think you said earlier. I thought you said that you treated over 800 folks that had overdosed, and only 14 of them required, I thought you said a 911 call. If that is accurate, does that mean that they required or didn't get any additional medical care other than your on-site staff?
That's correct. We have trained, because of our proximity to the drug-involved medical emergency, because we're there at onset, as opposed to playing catch up with time, which is often the case when emergency responders arrive to an overdose and it's quite progressed. We are there the second things start to unfold, and thus we have many more tools and many more intervention strategies at our disposal. Further, we've trained all of our staff to respond at the level that a registered nurse would. Having said that, not all of our staff are registered nurses. So we've given clinical and professional skills to paraprofessional people to ensure that they are really effective responders. This is a part of our goodwill effort to take a piece of work off of the plates of a very overburdened emergency services system. We know that we're really good at doing this. We know we are very skilled responders. And we're proving that with these numbers. So we've intervened in over 150 overdoses, and we've only had to call EMS 14 times. In those 14 cases, 11 of those were for reasons not related to the overdose itself. Our team had successfully resolved that. It was due to underlying health complications and other sort of ailments that we felt were beyond our scope.
Okay, I just want to ask you to clarify. I thought earlier you said over 800, and I thought now you said 150. So
850.
850. Okay, thank you. So my next question is, of those overdoses, can you tell me how many of those were that occurred to the same individual?
Occurred to the same individual? I can tell you that we have several registered individuals at the overdose prevention centers who have overdosed with us multiple times. I couldn't sort of speak to exact numbers of people who have had previous overdose occurrence, but it's quite common, especially when the concentration of fentanyl in the drug supply does not increase incrementally consistently. It's when it fluctuates that we start to have really problematic overdose activity. If it were to increase incrementally consistently, the cohort who is relying on fentanyl would have a better chance of adapting slowly over time. It's the fluctuations that are really problematic. But short answer, yes, there are several people who have overdosed with us multiple times.
Okay, then the flip side to my question, and I'll be respectful to the others and save the rest of my question is, and I think it's a yes or no question, and I think the answer is no, but I just want to understand at this late hour. Are you unable to quantify the number of individuals that have overdosed at your facility, unique individuals?
We can. To clarify, we do have all of the data you're requesting. I just can't sort of communicate that data to you now. It's all coming out in our 1-year report. And I don't want to misspeak here, but I can't quote the exact number of unique individuals who've experienced an overdose in our program, but we do have that data and we'll be releasing it soon.
Thank you. Thank you, Mr. Chairman.
Thank you. And I understand the Journal of American Medical Association had your 6-month data that I had seen in that publication, which was quite impressive. The next person is Representative Myra.
Thank you so much, Mr. Chair. Kaylin, thank you so much for coming and speaking with us again. And it's really nice to see you here. And thank you for the tour the other day. And once again, your enthusiasm here at almost 10 o'clock at night has excited me. So I think I need a little uplift. So appreciate that. One of the things, and I think you did just kind of mention this just now, but you stressed this when we visited you, is how important that outward facing unit is. Could you explain just a little bit of what that actually does? And you don't have to go into big details, but just kind of briefly.
Yeah, thank you. The underlying philosophy is that we open these programs for 2 distinct stakeholder groups. We open them for the people who will use them, of course. We also open them for the community members who live and conduct their business, go to school, go to church in the neighborhoods where these programs are located. And from our perspective, if you are not meeting the needs of both stakeholder groups, you have not done your job. So a well-run overdose prevention center should integrate into the tapestry of the neighborhood really well. It should make itself useful, and it should be a community member with sort of equal responsibility to the neighborhood as the other stakeholders and city agencies where they're located. So the outreach and public safety teams, that's what we call them. They do the labor of cleanup in the communities. That's important. They need to be seen to doing the labor of cleanup. They work really closely with elected officials, principals, parents, the business administration, the city, etc. They should be, and certainly ours are, they should be able to talk paint off a wall. They have to be really good and understand the issue, and they have to be able to understand community concern. And they also man our public safety hotline. So again, in an effort to be useful to other stakeholder groups, I think for you guys, it's 211. In New York City, it's 311. But when the community calls and says there's syringes here, or there's a person who's intoxicated in my doorway, do something about it. 311 often can't respond for 72 hours. And that's, in the interest of community well-being, and good relationships and being a good neighbor, that's not going to quite cut it. So our public safety hotline guarantees a response within an hour during our hours of operations and within 4 hours if you call when we're not open. Absolutely critical that they be out there hearing and feeling what's going on in the neighborhood, tracking the migration of people who use drugs through our community spaces, working closely with police, reporting back to us how our services are impacting the community as a whole. You'll remember this because I remember it really shocked you when you arrived at our site. There is a daycare center across the street from the largest consumption site in America, and they are a good partner to us and we are to them. Our site in Washington Heights is located a block and a half away from 7 schools and is across the street from a playground. Is this ideal? Absolutely not, but it's a symptom of an urban environment, and we have found our way to integrate with these communities and be useful. Our outreach and public safety team is present at school drop-off, at lunchtime, and at pickup after school. We know the principals, we know the parents, we are there loud and proud, not hiding what we're doing, but being really transparent that we as a neighborhood, as a community, are in this crisis together, and we have to get through it together. We host interns from the high schools, where I think we're the only harm reduction program in the United States that does that. And I could go on, but in the interest of brevity, it is possible to have good community relations and be an asset to your community when you run programs like this.
Thank you so much, Kaylin. Really appreciate your answer. Thank you, Mr. Chair. That's all.
Thank you. And I just wanted to mention that both Representative Mara and I almost passed out when we saw the daycare right in front of us. And so we were taken care of immediately, and then we learned about how things were working. Representative Dauphine, followed by Senator Marks.
Thank you, Mr. Chair, and thank you so much for all the information you're bringing to us. Just a couple questions I don't think I've heard you answer yet. How much does it cost to run your facility?
That's a great question. Our overdose prevention centers, if they were to operate 24 hours, 2 programs, 24 hours would be $4 million. That's nothing, considering the early estimated cost savings is upwards of 25 million. Our entire program, both harm reduction hubs, so 2 buildings in 2 neighborhoods, and Representative Mara and Senator Anwar have seen them. They're not small buildings. And our fleet of 7 outreach vehicles, including a mobile medical unit, is $17 million. Again, nothing, considering harm reduction has been so underfunded for so long. You know, we're happy to have what we have, but it's really not a lot for what we do.
So, so is that 4 million plus 17 million?
It would be, let's say it would be 19 million if the overdose prevention centers were at 24-hour operation.
And how many hours are they now? You said there weren't 24.
No, they're not. So currently they're operating from 6 in the morning until 8 o'clock at night in East Harlem, and 8 in the morning until 8 at night, 7 days a week in Washington Heights. Incidentally, all of the fatalities of overdose prevention center participants in both programs, every single one is tracked to hours outside of our operation. So they all occurred when we were closed.
Yeah, that's interesting, because you did speak about some people needing as many as 24, I think you said 24 syringes in a day. So we were talking about almost like 1 an hour. So I'm assuming that when the facility's not open, they're going somewhere else to use their drugs. Is that correct?
Yes, that is correct. And it's been a real challenge for us, going back to that idea that we need to meet the community's needs as well as our participants. Any sort of pushback from the community really results from activity that's occurring in the neighborhood during the hours when we're closed. So that syringe litter cleanup, the overdose activity, the public drug use, everything that we are doing a really good job of addressing during the day is still absolutely an issue in the overnight hours. Staffing challenges that we're all experiencing. You've heard about them at length this evening with the nursing challenge. We're facing those too, and that's the impediment to getting to 24-hour operation.
And thank you. And just one last question. How many do you serve a day? How many individuals?
The organization globally serves 15,000 people. The overdose prevention centers serve just over 3,000. So again, that's great evidence that overdose prevention centers don't create drug users. They're really a niche service for a target population. The East Harlem site is the overdose prevention center is seeing around 300 visits a day, between 200 and 300 visits a day. And the Washington Heights site is seeing between 100 and 150 visits a day. The Washington Heights cohort is much, much younger, and it's a smaller cohort, but it accounts for the vast majority of the overdose occurrence, really because of their high risk drug of choice, their modality, and because of their age.
Thank you so much for your testimony and your answers. Thank you, Mr. Chair.
Thank you, Senator Marks, followed by Representative Claridis Dietrich.
Thank you. You and Ms. Evans' testimony has been brilliant today, and I think we're going to have another field trip because I know all of our interest is piqued and just fascinating. So just real quickly, we seem to like a lot of numbers this evening. So how many people do you think you have saved, lives you have saved?
Well, first off, I don't know if Liz Evans shared this with you, but I learned everything I know from that woman. I worked for her for 12 years in Vancouver before moving to New York City. So yes, you have the best of the best in Connecticut. You should know that. How many people have we saved? We ran an unsanctioned program for 6 years before launching the sanctioned program. So it's difficult to say. We know that we have intervened in 850 overdoses that had the potential to be fatal. That's just in the overdose prevention centers. Our outreach and public safety teams are doing street-based response all of the time. And we had, I think, almost over 1,000 saves under the unsanctioned program. So a lot. What we know is that an overdose will not be a fatality if there is somebody there when it starts to happen. It's that simple. You know, safer consumption programs aren't complicated. It's somebody to observe who knows what to do. That's what it is. They're really quite simple on their face, you know? And I say that to embolden you to open your own, right? We don't need to get in our own way and overthink this. This is patient-centered care for people who use drugs. This is a public health intervention for people who use drugs. Let's not complicate it with all of the very complex feelings we as Americans hold around drugs and people who use them and the war on drugs and things of that nature. That's all there in the periphery, but on its face, this is simple. This is public health care, and it works.
Yep. And they're people, and they're really good people.
Yep.
Yeah, they're really good people.
Absolutely.
So yeah, thank you so much. Thank you. Thank you.
My pleasure.
Representative Claridis Dietrich, followed by Representative McCarty.
Thank you, Mr. Chair. Thank you for being here today. And I'm sorry I missed the visit. Hopefully some more legislators can come and visit your sites.
Anytime.
I know you mentioned that your sites are not 24 hours. So the question I have is how much does it cost to run 2 facilities with the hours that you mentioned? One was from 6 a.m. to 8 p.m. The other one was from 8 to 8.
About 2 million.
Total?
Yeah, about 2 million. Yeah.
Okay.
And the bulk of that is staffing costs, of course, right? You need really good staff. You've got to pay them well. This is tough work. It's not an easy job to sit in witness of people consuming drugs. There's a lot of it's physical work. There's emotional and psychological loads to bear. So you need good staff support programs, and good wages.
So now I'm not clear. If you go 24 hours now, you said it'll jump up to 17 million a year.
Let me clarify. So the overdose prevention is a program within our organization. So our harm reduction organizational budget, including the operation of 2 harm reduction hubs, that's 2 separate buildings, and 7 vehicles, including a mobile medical unit, that is $17 million. The overdose prevention centers themselves, as they're operating right now, come in around 2 million. Were we to complete the expansion to 24-hour operation for both programs, they would come in around 4.
Okay, thank you. And then do you have any zoning requirements for your facilities?
We do. We're zoned as a social service agency. If that's what you're asking, our buildings are zoned that way. Our certificate of occupancy filed with the Department of Buildings reflects that as well.
And any restrictions, meaning within so many feet of a school, or I know you said you're down the street from a school, but I didn't know if there were any restrictions that way.
So that's interesting. So you're sort of tiptoeing towards the notion of regulation. And what's interesting about the New York experience is that these sites didn't exist. And thus how and who was going to regulate us, right? The health department didn't know how to regulate us because they'd never done this before. And in their, infinite wisdom, they behaved unlike a bureaucracy and allowed us to lead. The health department was just an exceptional partner to us in this work, sort of acknowledging that they didn't know what to do in this case, that they were not a leader, they were not an expert in this way, but we were. So they kind of got out of their own way and allowed us to lead the process. We hope, in partnership with other experts in this field, to be really involved in the regulatory process, because it's going to be key that it not happen without us, because it's such a new area of exploration for the United States. But, succinctly to your point, no regulations, concrete regulations around distances and zoning exist as yet, but they will soon.
Okay, thank you for your time here today. Thank you, Mr. Chair.
Representative McCarty.
Thank you very much, Mr. Chairman, and thank you for answering all the questions this evening. I'll just very briefly notice that you offer mental health services and counseling and other types of services. So I'm just wondering, with your staff qualifications, if you could just briefly let me know what type of professionals are working at your center?
Yeah, absolutely. Absolutely. So we have MDs, RNs. We're hiring a psychiatric nurse practitioner. We have LCSWs and LMSWs working at our sites at the moment.
That helps. And thank you. It does appear from what I'm reading in the data that your center is saving lives. So thank you very much.
It is. Thank you.
Representative McCarty, followed by Representative McCarthy-Vahey.
Thank you. Kaylin, I think we're getting close to the period of wrapping up questions, but I want to thank you for the conversation. I do appreciate your comments with Rep. Claritas Detria's question. She talked about zoning and you said tiptoe towards regulation. Connecticut is certainly not New York City in terms of our neighborhoods, our density and population. And I'm very interested in what you said, particularly about being a resource to the community, equally as a resource to those who are using. And I think that's one of the challenges I think about here in our state, is that what many neighborhoods are not seeing is use on the street. What's happening in many neighborhoods in Connecticut is that it's happening. It's just hidden. And we're not talking about it. We're not talking about it. We know it's happening because people are dying. But that's one of the challenges that I see for us. And I just, more a comment than anything else, because I see that Senator Gordon has a question, but I want to thank you and I look forward to visiting you at some point in the city.
Thank you for your comment.
Senator Gordon.
Thank you very much, Mr. Chairman. I'll try to be brief. Caitlin, thank you for testifying. I had two quick questions. Well, one's a question, one's a comment. When it comes to zoning, I can tell you towns and cities in Connecticut would very much have jurisdiction. In addition to a state senator, I'm chairman of my town's Planning and Zoning Commission. So these types of things actually would have to undergo some degree of review locally. There's already well existing town and city regulations how to handle all sorts of things. So that would be a process already in existence. But my question to you is, and I wasn't quite clear when this was discussed before during your testimony, my question is, does the state of New York, not New York City, but the state of New York actually give you funding that covers the supervised use in dealing with overdoses. When I went through a lot of detail on their website, they really didn't say much about it. They talked about other harm reduction things, but not some of what you're doing. So what exactly does the state of New York fund for your operations, and what exactly does it not fund? Through you, Mr. Chairman, thank you.
So New York State, to state very, very clearly, New York State Department of Health does not fund the Overdose Prevention Center. They want to. The Office of Drug User Health is a unit within the New York State Department of Health, and they are a strong supporter of this work and of On Point, and very much intend at some point in the future to fund our work. They can't at the moment because we need state backing, right? So at the moment they don't. What they do fund, and we are the longest holding syringe service program waiver in New York State. We've held a waiver with New York State Department of Health to dispense harm reduction supplies since 1992. So they provide us and fund us to dispense harm reduction supplies, provide harm reduction education, drug testing supplies, mass spectroscopy. They fund our drug user health hub, and a bunch of other wraparound services, mobile medical unit, et cetera, all within our harm reduction portfolio, but they are not currently funding inside the room. With respect to zoning, I hear you. It's going to be a regulatory consideration in the future. Certainly in New York City, with the crisis evolving and unfolding the way it was, emergency measures were deemed appropriate to get the sites open, and that's the path we took through city agencies. And that is certainly at Connecticut's disposal as well, because this is a national public health crisis.
Thank you, Mr. Chairman. And just one quick clarification question. If New York State itself is not funding, separate from what they may want to do in the future, is there a reason that you can tell us why they are not funding? Does it have to do with any concern about existing federal law?
I think there are a couple ways to answer that. So this is just our opinion, right? This is not the state's opinion. So this is sort of our conjecture based on what we have been, our conversations with the state and our conversations beyond the state. We are of the opinion, based on various signals from the federal government, that the federal government is looking for the states to lead on this issue. They're not ready to weigh in. They are preparing to weigh in, but they would very much not have to. They would very much like the states to lead on this issue. In the absence of the states leading on the issue, local municipalities are taking action as they see fit. If the crisis warrants, an intervention such as overdose prevention centers, then that's what they're going to do. And that's the New York story. Rhode Island is, I think,
if I just may interrupt, because I know I'm going to run out of time, but specific for New York State, is there a reason why New York State itself is not funding the supervised use and response to overdose, separate from what the feds may want to do or not do? Is there any particular reason holding New York State behind that, which would be certainly of interest to know if there is, or it's just something politically that they just don't want to do it?
I think you'd have to ask Governor Hochul directly herself, but we are waiting for the state to authorize. We believe the state is close. We believe Governor Hochul is in support. It's just a matter of her making the decision to go forward. Yeah.
But thank you, Mr. Chairman. I do have a query out to New York State to learn more from them. Thank you.
Certainly.
Thank you. I looked at the list of the people who are going to testify. Governor Hochul is not on it just now yet. But Kaylin, I wanted to thank you for this. I wanted to clarify a couple of things, if you don't mind. And is the 2% a separate entity and the 98% a separate entity, legal entity?
Good question. The overdose prevention centers are not a separate entity from the 5013C that is the organization, but they do have separate administrative and fiscal centers. So separate set of books, separate bank accounts, All of the money in the administration is kept separate.
Okay, and the reason I'm asking this is that the observed consumption is what the federal law restricts. And the wraparound services have become the largest part of the service that you're providing, but the observed consumption is the access point where people come there. So when they come there, they would be part of a, theoretically in Connecticut, they would be part of a separate entity XY, and that would not be funded by the state or the federal government. But that entry point will lead to individuals getting all the treatments that they need. And then that would be part of an entity AB, and that would allow that to be served by the state of Connecticut to help out. And that's what I'm trying to see is there are ways to be able to achieve this to save lives and stay within the legal realm and make sure that the federal laws are not broken and the state can help the entities.
Yeah, I think that's right. Especially if you're, able to demonstrate in an audit worthy by a federal standard, your practices are tight, that no public dollars are being used to pay for any activities related to the observation of consumption, then you should, and this is the New York example, feel relatively secure in proceeding.
Good. And one more thing was that something happened in New York, which led to everybody coming together and saying, this is too much. What was that? And because I want to find out what is that too much going to be for the people in all levels of leadership in our state.
What happened in New York was, watching the country pass the 100,000 fatality mark, and watching a slow climb over a decade to the point where well over 1 million Americans had lost their lives to overdose. Further emboldened by having two, unsanctioned programs operating in New York City, and operating very successfully, the health department very bravely decided to back On Point as an organization and partner with the city to take this leap together. It's a bit trite to say, but we were all swimming in the same direction. And it is about political will. And the New York story really demonstrates that. It's about a bureaucracy trusting a provider to be the expert to run a good service. It's about the health department doing what it could to mobilize and maximize its clout and its power in the public sphere as a bureaucracy. And it's about the city asserting its authority and its authority to act in the face of a burgeoning public health crisis, and knowing that it had a tool that could that could be impactful, and not waiting. And I think it's a powerful example. We have not been shut down by the federal government. We have been visited by the Department of Justice. They were at our site for 6 hours, and it was extremely positive visit. By the end of the visit, they were saying, how do we regulate this? How do we allow for adaptability and scalability in other parts of the country, like Connecticut, where a big site isn't going to make sense? How do we get tents in Kensington? The federal government is not going to come after these sites. The court of public opinion is on our side. The fatality rates are soaring. All signs point to yes for really advancing this public health evidence-based intervention.
Thank you so much. I cannot thank you enough for being here with us throughout the day or part of the day. And this testimony was very powerful and very helpful and very timely for us. Seeing no other questions or comments, we have exhausted our minds and your mind as well, but we're very appreciative. Next person on our list is Karen Caffrey, who is over here. Thank you so much, Karen, for being here with us throughout the day. We appreciate you being here.
Thank you. Yes, is this on? Okay.
Yes,
Okay.
Go ahead.
Good evening. I'm Karen Caffrey. I'm going to attempt to read in the interest of being a little more, not read in the interest of being a little bit more interesting. I am a licensed professional counselor. I'm here this evening in my capacity as the co-chair of the Public Policy and Legislative Committee of the Connecticut Counseling Association. I'm here to speak regarding two bills. The first is Senate Bill 1228, an act concerning the state's healthcare workforce. As you've heard previously, the Connecticut Counseling Association is requesting that the committee consider putting some substitute language in to add the interstate compact to that bill. And also regarding Senate Bill 9, Section 10, to include a representative of who is a licensed professional counselor on the newly created Healthcare Career Advisory Council. Currently, there's a designated list of members, one a representative of an association of social workers and one for psychologists. And we'd like to see a licensed professional counselor, or perhaps a generic description of like mental health professionals. And it could be anybody holding one of those types of licenses. Let's see. The Connecticut Counseling Association has been around for quite a number of years. I myself have been licensed since 1999 in Connecticut, and I was very happy to learn today that the Demas Commissioner, Navarretto, is a licensed professional counselor. So we are everywhere. And that is one of my points that I want to speak to tonight. I have spent the day here with all of you, and there is so much pain here in our state and in our country now. And there's such a need for help. And that is what we, amongst all the other people here, are trying to do. We want to help. That's what what we devote our lives to. And so one of the reasons we want the compact to be enacted is because we believe it will help us with our mission of helping. And in this particular instance, we believe joining the compact will help the workforce in two ways. First of all, we actually are part of the workforce. There are actually 4,500, more than 4,500 licensed professional counselors in Connecticut, 600 what are called licensed professional counselor associates, and then graduate students, and of course, many academic programs here in our state and private universities that provide master's degrees in counseling. So anything that allows us to practice and attracts and retains counselors in Connecticut will benefit the workforce. I'm not going to go into specifics. It was testified to previously. I'm happy to answer questions, but I want to address two concerns that have been raised. The first has to do with whatever legislative resources need to be devoted by this committee to draft statutory language. I can only say this jokingly, but I am formally an attorney. I'd be happy to help draft anything. I know that can't be done, but I just thought I would say it. Obviously, that's a decision that the committee needs to make. I would like to speak to a question Senator Anwar, a point he raised, and this is about how the compact works. Is it allows licensed professionals in compact states to practice in each state. I will say first, our membership strongly supports this, being aware that it will mean not only can we obtain a privilege to practice in compact states, but others can obtain a privilege to practice here.
Excuse me, Ms. Caffrey, but your time is up. Thank you.
I'll do 2 cents. This
Actually,
is
you were answering my question, so please
I'm
go
going to
ahead.
answer your question. This is the future of counseling with telehealth, with the compact itself, which is probably going to be enacted within about 20 or 30 states within the next year. There's going to be a national market. And if it's not a matter, if we want to stay competitive with other states, we need to enact the compact. Because why is someone going to go to school and come to Connecticut and be a counselor if they can only practice here? Whereas they go to a compact state, they can have a privilege to practice in 30 or more states. So to us, this isn't about like getting ahead. This is about not falling behind.
Thank you so much for your testimony. And I
Thank you.
appreciate seeing no question. Representative McCarthy has a question.
I know, almost. Karen, it's wonderful to see you and to be
Great to
working
see
together again.
all of you.
I would just like to answer a question, and just, this is also for members of the committee. You used legislative language when you talked about S language. Our JF deadline for those watching at home, oh, who's watching at home at 10:30 at night? Yeah. Is next Wednesday. And for better or for worse, our attorneys are the ones who draft the language. The compacts are actually pretty lengthy documents. So
Yes.
we're probably not going to have S language, even if all of us wanted to do that, just because of the other issues that we're going to need to address. So I just want to be totally upfront and transparent with everyone here about that. That doesn't mean that we're not interested in this conversation, as you've heard over and over
Yes.
again today. And I want to thank you for also giving us some of the numbers and just reminding us about that piece of not wanting to fall behind. I think an example of what you're talking about is for example, some of our students who are in and out of state, or our young adults who are perhaps moving, you know, especially with COVID, maybe they've been home for a few months, and then they're, not that this is happening in my house at all, but then they're, you know, moving to a new location. So I think what you're talking about is very practical, and providing more access is exactly what we want to do.
Yes, thank you.
Thank you, Mr. Chair.
Representative Daphne.
Hi, thank you, Mr. Chair. And I just wanted to thank Karen for her testimony. It's nice to see you again.
Nice
I
to
haven't
see
seen
you
you in
too.
quite some time, and it was very informative. So thank you.
Thank you, Representative Dauphiné. Thank you.
Thank you. Seeing no other questions or comments, we appreciate you being here. Thank you.
Good luck.
Thank you.
I hope you brought your PJs.
Well, are you going to stay with us for the rest of the evening? There's such
I'm going
important.
to home, getting in mine.
We will need some counseling.
You have my card.
Thank you. All right. Moving on to the next person on our list is Leslie Lincoln. Welcome, Ms. Lincoln. Thank you for your patience with us tonight.
Thank you very much, and good evening. I was going to say good afternoon, but we're well past that. Esteemed members of the Public Health Committee, my name is Leslie Lincoln. I'm a registered nurse. I'm a doctorate of nursing practice. I'm a nurse executive, advanced board certified, and I'm a clinical nurse leader. I list these accreditations in introducing myself because nursing has been at the core of my identity for more than 30 years, including 20 years at the bedside. Today, I'm addressing you as the Chief Nursing Officer at Norwalk Hospital. With this and every previous role I've had, informing my opposition to stringent nurse staffing ratio mandates in Connecticut. I'm not opposed of the goal to maintain ratios, but the mandation of those ratios. Nurses are trained to think on our feet, using a wealth of clinical knowledge and understanding of our units to make informed decisions about patient care. These decisions vary by hospital, unit, shift, and sometimes, as you've heard, even hourly. Patient acuity is another factor we always consider. It's crucial that our nurses have an open and collaborative relationship with hospital leaders so we can make these decisions for our patients and their families in real time. Staffing mandates eliminate the flexibility that is so crucial to this collaborative process, with the unintended effects of removing caregiver autonomy, reducing and endangering the access to high quality care across the state. Mandated staff ratios operate under the assumption that nursing is a uniform profession. Those of us who have spent time on the front lines know the opposite is true. Every nurse brings a different expertise to the team, and we take this into account as we fine tune and operate our units. We especially saw this to be true during the pandemic, and as our nurses grappled with the long-term effects and widespread staffing challenges that we saw. Each patient is staffed based on individualized treatment plans and on a nurse's skills, abilities, and experiences. These individualized staffing procedures allow younger nurses to learn and work their way up to treating more patients, while allowing our more advanced, experienced nurses to collaborate and play to their own skills. I agree that we must look for opportunities to support and empower our nurses, and this is a top priority for all our hospital leaders across the nation, across the state. But that said, enacting mandates that would override a professional judgment is not the path forward. There will always be sick calls. There will always be FMLAs out there. There will always be resignations. We need to maintain flexibility in staff in Connecticut's hospitals so our nursing teams can continue making collaborative decisions based on what is best for the patients and families that we are all here to serve. Thank you for the opportunity to speak.
Thank you very much for being here with us and for hanging in throughout the day and sharing your perspective. Seeing and hearing no comments or questions. Have a great rest of the evening. What's left of it. Okay, next on our list, I believe we have, oh, hang on one second. See, Senator Amour's been doing such a great job. John Lally. Mr. Lally here with us. Oh, yay. Thank you. Welcome. Don't forget to press the button and turn on the microphone. There you go.
There we go. Thank you. First of all, I want to just thank you all for, we've had a lot of talk about rock stars today, but I am impressed with everyone else in this room on the committee, both here and virtually. Sitting through this long, and we got a long way to go, but it shows me a commitment to the people of Connecticut, and I want to say thank you, first of all. Second of all, if you don't mind, before I start my testimony, I think it's only fair, being what we've talked about a lot today, is I'd like to give 10 seconds of my time to a silent reflection for the 4 people that we're losing today in Connecticut and every day. Thank you. Next, good evening, chairpersons Anwar and McCarthy Vahey and all the other esteemed members of the Public Health Committee. My name is John Lally. I am, to get to the point, and then I'll embellish a little bit. I'm speaking in support of SB 9, Section 4 and 5 and overdose prevention centers. I think enough's been said today that I can't do a better job talking about what good they are. And other than maybe some obstacles with funding, I've not heard any downside of all the testimony today. So I think that speaks volumes to how efficient they are in saving lives. But I also want to just mention, I support the expansion of naloxone access in SB 9, Section 6 to 9, but I'm worried that the specific grant system now will place extra obstacles into obtaining and getting naloxone out, which we need to get out as quick as possible. As I said, with all these people dying, we need to be able to get it out quickly and efficiently as much as possible. And that may get easier. Hopefully the FDA is going to approve it being over the counter. I'm hearing some talk about that by this summer. So as some of you may know, it's an entirely safe medication. It's saving lives every day and it can't hurt anybody. So there's no danger having it as accessible as possible. I also want to mention HB 6913, Section 2, which I'm generally for, but I'm against the Section 4 that restrict the distribution of life-saving medications in mobile units. Anywhere there's a certain, I guess, geographical distance that have to be from a school. And I understand that in theory, but the whole purpose of a mobile van is to go where the people are that need it. And if the people that need it are near a school, well, that's where they need to be. These are not vans that are giving out narcotics. These are vans that are prescribing life-saving medications by professional healthcare people who have the license to prescribe. So I just wanted to make that clear. I myself am a psychiatric nurse practitioner. I've been working in addiction and mental health in some way for almost 39 years now. But I'm here speaking as a grieving father. This is my son, Timothy. I lost Tim 7 years ago to an opioid overdose here in Connecticut. And we've heard a lot about facts and figures today, and those are important, and numbers. But I'm not here to talk about a number. This is not a number. This is my son. This is Timothy Lally, who deserves to be remembered. But he's only one of millions. No, he's not unique. His story is not unique. But I want you to understand when we're talking about these programs that we should provide for people struggling, there's a lot of misconception about what it's like to be someone who uses these kind of substances. And I want to tell my son's story is probably typical, though there's so many different paths to addiction. He developed a severe anxiety and depression problem in high school. And his anxiety got to the point where his panic attacks were so bad, he couldn't get out of bed in the morning. He'd literally be crying and shaking and weeping. I can't do this. I can't get through the day. And he struggled with school that way. And even
Excuse me, Mr. Lally, but your time is up. Thank you.
So quick. He struggled, but can I just wrap up a
Yes,
couple
I
of
was
quick
just going to
things?
say, Mr. Lally, wanted to, I think I see the heads nodding of our committee members here.
Just a couple of quick things then. Someone gave him a Percocet one day and he felt better. He got through his anxiety, which psychological work helped him, didn't help him. Medications for his mental illness didn't help him very much, but someone gave him an opiate and he felt calm. And he thought, geez, I could get through the day. Well, as we know what happens with addiction, one opiate turns to 10 opiates, turns to 12 opiates. And it wasn't long before his whole life was consumed by using drugs or finding drugs or figuring out how I'm going to get these drugs, because he couldn't get through the day. He couldn't survive without them. He tried treatment. He got into treatment a couple of times and he liked it when he was in treatment, but then he would eventually would relapse, which happens a lot with these disorders. And he hated himself. I want people to understand, people use drugs. He wasn't having fun. He was not out partying. That was not his life. His life was desperation and survival. And at one point he relapsed and overdosed. You know, we were fortunate enough that he was revived enough, though, that we could spend 36 hours with him in the hospital. He was brain dead, but he had no awareness of us. But the EMTs were able to get his heart beating again and on a ventilator. But when they did the testing, he was brain dead. There's no way we could bring him back. As a family, we had to make the horrible decision to let him go. Imagine that. Your parents, you bring this into this world. We had to make the decision. This is too much. This is not what he would like. And we had to let him go. And my wife stood there sobbing uncontrollably. And my other son was holding Tim's hand and crying. And I put my ear to his chest. I wanted to hear his last heartbeat. I wanted to be present with him for that time. And I'll have to live with that the rest of my life. That moment, that decision, and the fact that I've missed my son dearly. I love him. These are the lives we're talking about. Every one of these are the type of people that are struggling. Again, I want, you know, again, they're not partiers. He was not a party. He was not having fun. He was struggling. He got into a mess he couldn't get himself out of. So I think I just want to encourage everyone to please, I know you do that. I know you're caring people, obviously, but think about lives, not about numbers. This is what we're talking about. This could be your son or your neighbor that this is happening to, or your spouse or your parents. Thank you.
Mr.
For any
Lowry.
questions?
Thank you very, very much for sharing just your incredible pain with all of us to help us understand the humanity and the hurt behind what's happening. I'm going to go to Senator Kushner.
I appreciate your words here tonight and sharing that story, because you can look around the circle and I think there are many of us who have had that experience with a loved one or someone who we love had that experience with their child. My brother, my sister-in-law, you know, dear friends. So we know what that pain feels like. And so thank you for sharing it, because it is really important to remember what we're talking about here.
It is. You know, we run an organization called Today I Matter, named after my son, Tim. And one of the things we do besides education and advocacy and support, we have a memorial poster project, we call it. We travel around New England. We've been to Washington, D.C. We have 600 posters like this, 2 by 3 foot posters. We set up a memorial to remember these people. And on the posters, it says their name and the town they're from, and it lists 2 traits of them. My son says artist and musician. We have carpenters, we have fishermen, we have mothers, fathers, we have teachers, we have nurses. This is how these people need to be thought of and remembered, not as junkies or as addicts. Yes, they had a problem with dependency, but that didn't define them. And we have to remember them, but they were more than that.
They were somebody's son, your son, Representative Carpino.
Thank you. Tim, I will remember Tim's name. So thank you for bringing his name forward.
Thank you.
I can't imagine losing a child. So for publicly making sure that he is remembered for who he was, I commend you. But I do have a particular question, if you don't
Okay.
mind. Do you think a center like this would have helped your son?
I don't know. I'm going to be honest. I don't know if he would have used it. This is not for everybody. It's probably, I would imagine, for people, why we put them, why they tend to be in big cities where there's a concentration of people. You know, out in a little town like Ellington, there probably wouldn't be a center like this, because I don't know how many people would use it. And I don't know if Tim or other people would drive from Ellington into Hartford or New Haven to use. I don't think they would have that kind of a motivation. there's such a desperation and need that takes too much thought and planning. But for populations, especially in high population centers, in concentrations like bigger cities, I think you get more of a amount of people that will use them. I don't know if it would save my son.
I appreciate your honesty and I appreciate you sharing your story and Tim's story with us tonight. Thank you. Thank you, ma'am.
Thank you, Representative Carpino. Representative McCarty.
Thank you very much. I too just wanted to thank you so much for coming in, and I've seen you before, and for your ongoing advocacy all the time, and just to let you know that, you know, depression and anxiety and all of the issues that you spoke about, there's a lot more awareness now, and we're working much earlier with our students and trying to intervene early to help with the parents. So to avoid what you're talking about. So I just want to, I'll remember Tim too. And thank you for bringing the poster, and just to give you that little bit of hope that we're trying hard and we want to see this end. So thank you very much for coming in.
Thank you for saying that. And I appreciate that we're trying to teach younger people about, and appreciate the need for mental health support for younger people. I think that's where it starts. There's a lot of talk these days about because fentanyl is such a big problem, that we need to arrest people. We need to get these people. And if we stop people at the border, we're going to save this problem. I think that's missing the point. The point is what is driving people to use substances? Because if it's not fentanyl, it's going to be, it was heroin, it's going to be cocaine, it's going to be something else. It's not the drug, it's the drug use that's a problem. I mean, yes, certain drugs are deadlier. I get that. But the fact that someone's going out into the street and feels the need to search out some kind of a drug, there's a need inside of them that we have to pay attention to.
Thank you, Representative McCarty. And that's very powerful what you just said, that there's a need inside of them that we need to pay attention to. And there are many ways that we need to address these issues that we're facing. And that's a really important one that you just added. I want to thank you. And I want you to know that there are legislators not on this committee who are listening tonight, who have been texting me and just telling me what powerful testimony you've shared. So you're really making an impact and reaching out to a lot of us. And I want to thank you for that.
I hope so. If I can make something positive come from my son's struggle and my family's struggle, it helps take the edge off a little.
Thank you. Thanks for staying here with us, Mr. Lally. Next is Andrea Riley, who I believe is here in the room. Yes, welcome. We had you listed as remote, but here you are.
Thank you for having me. My name is Andrea Riley, and I'm a nurse in the emergency department in the state of Connecticut, and I'm here to testify in support of SB 1067. It's been a long day. I've changed my good afternoon to good evening already. I also probably had good morning at some point. But it's not quite as long of a day as a nurse is. And at this point, what I would like you to do is I'd like you to stay seated in your chair. Picture staying seated in your chair for 12 hours without a bathroom break, and maybe just one cup of coffee, okay? And then maybe one can understand the plight of the understaffed nurse. I wrote a speech earlier today. I changed it after listening to what many people have talked about earlier. And I've summed it down to a few words. Framework. 1067 provides a framework with which hospitals must work within. Think about when we went to school, what did we do? We always had an outline and we worked within that outline, is that correct? That's basic fundamentals right there. Proactivity, and let's throw preparedness into this as well. It's an approach that would assist in not only recruitment, but retention within the acute care setting. This also corrects hospitals' continuous unacceptable reactive behavior that leads to dangerous behaviors such as mandatory overtime. And let's be clear, mandatory overtime leads to poor patient outcomes and can even result in death. And I'd like to say something else. The very idea that nurses must have to negotiate against mandatory overtime implies a gross misunderstanding of what healthcare is about, and that is about the patient and positive patient outcomes. Accountability. Nurse-to-patient ratios and safe staffing models hold hospitals responsible to develop acceptable standards that result in safe patient care and holds them to the obligation to adhere to such standards. It promotes continuous recruitment and retention of the employee. Thinking outside of the box, color-coded treaded socks and fall risk signs outside of a door does not physically catch a patient. That is antiquated behavior. The hospital is responsible for hiring the staff. It is not the floor nurse responsibility to do so. Nor is the floor nurse to be the scapegoat for all poor patient outcomes, especially those that could have been prevented with adequate staffing models. Collaboration and empowerment. Staffing committees empower staff and allow for collaboration between the hospital and the employee. There is no better feeling when all parties involved in patient care can align in the best interest of the patient. It is certain that nurses will be involved in new policies, procedures, and guidelines. There's a famous movie quote that says, "If you build it, they will come." Today, many administrators discussed lack of staff, but they never dove into why. They just stated, "It won't work, we don't have the staff." Nurses are telling you that this is a key brick in the foundation of building safe healthcare. I worked in California. I worked under those ratios. Not once did I ever hear a nurse say, "I just can't simply handle my day." And not once did I ever hear an administrator that I worked under say, this just cannot work at all. California.
Excuse me, Ms. Riley, but your time is up. Thank you.
Thank you. The nurses of Connecticut deserve better, and the residents deserve better. Thank you.
Thank you very much. Thank you for staying here with us for the day and for your passion and your advocacy. We have, well, don't go anywhere yet. One quick question from Senator Kushner.
Just quickly, you started to talk about California when your time
Yes.
ran out. Could you just tell us what they have in California?
So I worked under the emergency department. We had a 1-to-4 ratio. We were able to take lunch breaks, and we also had 15-minute breaks as well. I remember when I went to California and I traveled there for about, just under 2 years. I had traveled as a nurse there. It is strictly adhered to. And I will tell you something else. There's this whole idea, and it's false, that these patients are going to be driving around. We're not going to accept patients. When you come up with nurse to patient ratios, it forces administrators and it forces a collaboration, not only on the administrator, but as well as the employee to work together to come up with ways to avoid that, to make sure that all patients are going to be treated and seen. So in the emergency department, there would be a computer, and it would have all your area hospitals with your census when they were in green, yellow, and red. Ambulances knew how to divert appropriately if that was warranted, but never did we turn anybody away. We also have something, I don't know if you're aware of, a triage nurse in the emergency department. So that's the nurse that lays eyes and determines the acuity of the patient. So if you don't have a bed, this whole idea is we're not going to have a bed is completely false too. You then develop a plan as the triage nurse. How do I start treating that patient if I don't have a bed in the back, or if I have to adhere to these ratios? What can I do to that patient in the waiting room to start their care? So we would send people to the lab. We have protocol. We work under certain protocols. We have certain protocols that I'm allowed to do. So if I have a patient that comes in and I want to do what's called an EKG on the heart because they're having chest pain, I have the ability to order that as a nurse. They had far more advanced protocols. And this was back in 2007, 2008, that would allow, these be like, okay, we're going to go to the lab. You're going to start your lab work. You're going to get this x-ray. They also had practitioners out in the triage area that were beginning the care for those patients as well. Everything is possible. Healthcare is not about profit. It is about patients. And if you hold yourself to a framework and a standard, you will make it happen, and it can happen. So California has made it happen. And there was also this thing about there's 40,000 people. That's a staffing shortage in California. Go back and do your research. COVID created what's called, somebody had brought up to the baby boomers. We've known that the baby boomer generation is set to retire, right? We're in that moment. This should have been discussed and thought of years and years before. COVID kind of expedited that as well. That's why they're in that short staffing model right now. That's why a lot of us are dealing with it. So guess what we need to do now? We need to recruit and we need to retain. Hospitals used to love to have nursing schools. Where are they? Bring them back. You see what's going on with Stone Academy. Start bringing this stuff back. There are ways to bring nurses into it. Bring the LPNs back. Take a look and see what hospitals have eliminated with licensed practical nurses to RNs. There's so many ways to fix this problem and to go back and look. Collaborate with the nurse, listen to what we are saying, and we will solve this problem.
Thank you.
Thank you, Madam Chair.
Thank you, Senator Kushner. Thank you. Next on our list is Sarah Hayes. Welcome. Please proceed.
Hi, can you guys hear me okay?
Yes, we can.
Okay. Good evening. My name is Sarah Hayes. I'm a proud Danbury resident, and I've been a registered nurse at Danbury Hospital since 2006. For as long as I can remember, I wanted to be a nurse. I began my career on a med-surg floor before progressing to critical care. I am proud to be among the ranks of the profession rated #1 for honesty and ethical standards in Gallup polling for 21 years running. Despite the challenges that we have faced before, during, and after COVID, I always held out hope that our working conditions would improve. I tried to reassure myself and others that if we pushed through, things would get better. After 3 years, conditions have only deteriorated. I've witnessed many nurses leaving the bedside because unsafe staffing has taken its toll on them. Both nurses beginning their careers and nurses with decades of bedside experience are leaving. I always planned to provide bedside care until my retirement, but I too have made the painful decision to take my nursing career in a different direction. The majority of my shifts in the ICU have me working above a safe nurse to patient ratio, which is considered 1-to-1 or 1-to-2. Most often I am responsible for 3 patients, making it impossible to provide the level of care the sickest patients in the hospital require. To keep our patients safe, we have had to resort to drastic measures. We've needed to restrain some patients that we normally wouldn't have to keep them from pulling out a vital device or prevent them from falling before we can reach the bedside. Despite our inability to provide an ICU level of care due to poor staffing, the hospital still bills our patients for ICU level care. Reports to administrators informing them of the conditions on the floor are met with silence. If a bed is available, the patient will come. Requests to divert patients or deny patient transfers from New York hospitals within the Nuvance network are rejected as it's bad for business. Meanwhile, administrators have asked us not to share with patients and outsiders just how staffed we really are. Every day I come into work anxious about the shift ahead, knowing my unit will most likely be working short-staffed. Most days I leave feeling defeated, not being able to provide the level of care for my patients that my patients deserve. We feel this heavy burden and moral injury on an almost daily basis. For nurses to speak out is not an easy decision, is not a decision made lightly, as many of us fear retaliation. But I've listened to hospital leaders tell you today how they want nothing more than fully staffed floors, as if they've already done everything they can. At our hospital, financial incentives were put in place to reward nurses willing to pick up extra shifts as a Band-Aid for short staffing. Those incentives were working until the hospital reduced them to protect its bottom line. The hospitals do not want this crisis and their lack of action exposed. Running a hospital that is safely staffed adds cost and responsibility for them. Administrators have told us to accept this as our new normal. We are asking that you do not allow unsafe healthcare staffing to be our new normal. Connecticut patients, their families, and nurses deserve better. I urge you to support SB 1067. Thank you for the opportunity to testify, and I will be happy to answer any questions you might have.
Thank you so much for being here with us today and for staying within your 3 minutes. Really well.
Thank you for having me.
Appreciative laughter here from within the room. Have a really wonderful evening. Seeing excuse me, Senator Kushner has a question for you.
I don't have a question, and I know I'm not supposed to do this. I won't do it again, I promise, but I do want to do, because I'm, as you know, your representative, your state
Yes.
senator from Danbury, and you know what you all do at Danbury Hospital really is amazing, and we appreciate it so much. And I know you feel defeated at the end of the shift, but you should know that you should feel very appreciated by the people of Danbury. Thank you.
Thank you. That means a lot.
Thank you, Senator Kushner. Thank you, Ms. Hayes. Have a great rest of your evening.
Thank you. You too.
Next, we have here in the room, I believe, Donna DeSaulniers. I don't know if I got that right. And to be followed by Bright Johnson online. Welcome.
Good evening.
Thank you, distinguished members of the Public Health Committee. My name is Donna Desaulniers, and I am a proud member of the Bristol Hospital family. I'm blessed to be a nurse for the past 39 years, of which 37 have been in the ICU. I have been actively involved for the past 10 years in our Nursing Professional Practice Council, as well as our Nurse Executive Council, both of which directly shape and dictate our practice, which includes staffing guidelines. I'm here to speak in opposition to the proposed mandatory staff ratio bill, number 1067. It is a given of every shift, no matter what department you work in, that the environment is fluid, changing in the blink of an eye. The ICU staffing guidelines call for 2 patients to every 1 nurse, with some exceptions in special circumstances. I cannot count the times we have had to adjust and adapt based on the acuity of our patients. There are times where we can readily take 3, times when a nurse can take only 1, even times when there are 2 or 3 nurses caring for 1 crashing patient. Our decisions are based on our knowledge base and, most importantly, assessing the acuity and safety of all situations for all our patients. The concept that you are proposing would take away 2 of the very core characteristics of all nurses: our critical thinking skills and our autonomy. Here's the reality: an ED full of critically ill patients, and they just don't stop coming in. There have been times in my role as per diem nursing supervisor, which I also do, wherein I've made several calls attempting to go on diversion due to a full ED and house. Times where we have had no choice but to safely push our ratios in order to care for those who needed us. These decisions were made in collaboration with our clinical nurses and nurse leaders. Our patients will not hear that they can't stay or we can't help them simply because the government dictated the number of patients we could care for. I have watched healthcare change from a time of too many nurses to where we are today. I lived through AIDS, SARS, the swine flu, and now COVID. We are all aware there is a shortage of nurses. Hospitals were forced to take whatever measures necessary to continue to provide the best care possible to the community. But what you are proposing is an attempt to treat a symptom. I'm here to urge you to look at the problem. Connecticut is a respected state. Let's be leaders in fixing the nursing shortage. Nurses want to partner with state and national leaders to come up with creative ways to increase the pipeline of healthcare team members. Mandating staffing ratios is like putting a Band-Aid on an open wide wound. It won't work. Solutions have to start at the top. We need your help reinvigorating the nursing profession. What about increased insurance reimbursement rates to hospitals and providers to free up monies for pay raises and incentives? Discounted insurance costs to healthcare workers as there used to be in days of old. Pay rates for nurses and other healthcare workers that equal what they are worth. Raises nowhere come close to inflation rates and insurance copays, not to mention the daily delays in insurance authorization that prevent us from discharging patients, thereby adding to the bottleneck.
Excuse me, Mr. Solimán, your time is up. And
I have 2 paragraphs this big.
No, I'll ask my question. What are your last 2 paragraphs?
We all want the same thing: adequately resourced teams, patient safety, high quality care. Nursing needs to be more appealing to the younger generation. I ask that you not tie our hands. Allow us to continue to function in the roles we have proudly chosen. Let's build on what we agree on and work together to find solutions that benefit patients.
Thank you. Thanks for staying here with us today and for all your work. You've heard me say and Senator Anwar throughout the day how grateful we are to all of you, the nurses who've been on the front line, especially in the past few years. So thank you. Seeing and hearing no questions or comments, have a wonderful rest of your evening.
Thank you all for staying with us throughout the day as well.
It is our privilege, truly. So next we have online Bright Johnson, to be followed by Dr. Alan Weiner. Bright, welcome. Please proceed.
Good evening, Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network in support of HB 6914. Just want to make a couple of very quick points. First, we agree with earlier testimony that the bill should be amended to increase the funding level to the CDC minimum of 22.7 million, in part because it's the right thing to do, and also because it matches what was done by this committee earlier this week. And I think that continuity is important. And then secondly, and lastly, we hope that that money is meant to be used in addition to budgeted funds and not in lieu of budgeted funds. Thank you.
Mr. Johnson, that was wonderful. Thank you. I was chuckling. You want us to be consistent as a committee? How about that idea? We heard you very clearly, the 22.7 million, and thank you for that, along with Mr. Williams earlier. And I see Ms. Canovi's up later, although she might be in bed by the time it's her turn to testify. Have a great rest of your evening.
Thank you.
Next up, we have Dr. Alan Weiner, to be followed by Frank Amafuna. Excuse me. Dr. Weiner, welcome.
Thank you. Good evening, Chairman McCarthy-Vahey, Chairman Anwar, Senator Summers, Representative Claritas Detria, and other members of the Public Health Committee. My name is Dr. Alan Weiner. I'm the Chairman of Emergency Medicine at Stanford Hospital. I've been in that role since 2018. I've been a practicing emergency physician in Connecticut for almost 30 years. I'm here tonight to testify in opposition to Senate Bill 1067. I'll limit my comments to the part of the hospital that I'm most familiar with, which is the ER. While I have no doubt that the proponents of this bill have good intentions, I can tell you from my own experience as a practicing physician, negative consequences are foreseeable if nurse staffing ratios are mandated in the ER. Unlike other parts of the hospital, patient volume and acuity in the ER is predictable. I agree with many other people who've testified today that a nurse managing a critically ill patient is not going to be able to manage many other or sometimes no other patient at the same time. Most patients in the ER, however, are not critically ill. There will be times when nurses in the ER will need to manage more than 4 stable patients at any one time, as is mandated by this bill. With the conditions in the ER constantly changing, it's essential for us to be able to be flexible to meet the needs of the patient at any given time. Adopting inflexible staffing rules will hinder our ability to be nimble and to shift resources to where they're needed the most. I urge the members of the committee to leave decisions on staffing to clinicians and nurses at the bedside who have the training and experience to delegate those resources, including these nursing resources, to where they're needed the most. Second, from my own experience of knowing how the ER works, I can foresee delays in all aspects of ER care if mandated ratios are enacted. It will take more time to bring patients in from the waiting room if nurses are limited in how many stable patients they can manage. The bill also has the potential to delay the transfer of patients out of the ER. You heard earlier from a speaker who talked about the experience in Massachusetts in getting ICU patients up out of the ER. I could see the same thing happening to patients who need transfer to the operating room or to interventional radiology or some other part of the hospital. Can those patients safely wait until a nurse can be found in that unit to satisfy mandated staffing ratios? I'm not sure that will be the case. In closing, let me say that patient safety is at the heart of what we do as healthcare professionals. From my 30 years of working in Connecticut emergency rooms, I do not believe that mandated nursing ratios will equate to improved patient safety and actually has the potential to delay patient care. For these reasons, I ask the committee members not to support this bill. Thank you.
Thank you, Dr. Weiner, for your time, for sticking with us, as so many have today, and your testimony, also for your work in the emergency department.
Thank you.
The last person who testified, all of you have been on the front lines, especially these past few years. You have our thanks and respect.
Thank you.
Seeing and hearing no questions, we're going to go next to, I'm going to try again. Frank Amafuna, am I saying that correctly? Please correct me.
Yes, Frank Amafuna.
Welcome.
Hello.
Please proceed.
Hello, thank you. Good evening, members of the Public Health Committee. My name is Frank Amafuna, and I'm pursuing a degree in dentistry and public health from the University of Connecticut, School of Dental Medicine, and Yale School of Public Health, respectively. These opinions are my own and do not reflect those of my academic institutions. Testifying today in support of Senate Bill 9, specifically for Section 4 and Section 5. Last fall, when I started at the Yale School of Public Health, I had the pleasure of taking public health law at the School of Public Health under the instruction of Shelley Jabal, and she gave myself and classmates, Mark Hocevar, Winnie Ho, and Nishar Islami, the opportunity to conduct research into the success and implementation of overdose prevention centers globally. While we conducted this research, we were presented with an abundance of data indicating how successful overdose prevention sites have been across the globe, from Switzerland, where the first prevention centers were opened up in 1986, to New York City, where 2 overdose prevention centers have been operating. And we've seen some of the people working on those clinics today here speaking before you all. And we've seen the success that these clinics have had. And Dr. Heimer actually gave a history lesson about public health interventions in Connecticut. And believe it or not, there is one that dates even further back. Between 1918 and 1920, the New Haven Police Department operated a morphine maintenance clinic for addicts, many of which were World War I veterans. And the data, though limited, showed that a large percentage of these addicts that registered at the morphine clinic died from causes unrelated to drugs. And in recent years, we've had thousands of Connecticut residents die of overdose, and totals going far above what we've seen in car accidents. Aside from what we can do to help save the lives of Connecticut residents, overdose prevention centers have the potential to save the state ton in funding. And these resources can be used to fund other health issues that we are facing in the state of Connecticut. The report that the Institute for Clinical and Economic Review compiled showed that OPCs that offer syringes, when compared to single syringe service programs, were much more cost effective. And when this analysis was run in over 6 major cities across the country, Atlanta, Boston, Baltimore, Philadelphia, San Francisco, and Seattle, there was a difference in ranging from 3.6 million to 4.9 million in how much money could be saved by choosing an OPC over a syringe-only program. I know that there's a lot of data that we can talk about and discuss today, but everyone has presented a number of reasons why we should strongly consider funding overdose prevention centers. And I'm happy to provide the sources that I talked today about, and I thank you so much for your time.
Thank you so much for the research that you've done, your commitment to health and public health, and to helping to educate us about what you've learned is effective. And thank you for taking the time to be here with us today. Seeing and hearing no other questions or comments, we'll go next to Sharon Adams, to be followed by Henry Schneiderman. Welcome.
Good evening, and thank you for the opportunity to the Public Health Committee. My name is Sharon Adams, and I'm a registered nurse. Since joining the healthcare community for more than 25 years ago, I've held a number of nursing and leadership roles leading to my current position as the president of Danbury and New Milford Hospital, as well as the regional president of Advanced Health. Before I get started, first of all, I would just like to say how proud I am of all the nurses, particularly the Danbury Hospital nurses that have been testifying today in advocacy of patient care, as well as their colleagues. Today, I want to express my strong support for Connecticut nurses.
Ms. Adams?
Yes.
I'm just going to say, if there's a way to adjust your microphone, we're having a little bit of difficulty hearing you here in the room.
Okay, I'm sorry. Let me turn it up a little bit. Is that any better?
Yes, a little bit.
Okay, I'll make sure I speak up then. Today, I wanted to express my strong support for Connecticut nurses and the collaborative planning currently in place regarding staffing decisions at the bedside. In doing so, I also wish to share my opposition for the mandated nurse to patient ratios proposed in the legislation. Every day, nurses work closely together to plan and adjust for staffing in response to fluctuating patient volume and changing patient needs. This requires a breadth of knowledge specific to each given unit and varied with each shift. Among the factors that we must consider are unit's physical layout, patients, acuity, the years of experience of each nurse. These decisions are complex and individual, taking them out of the hands of our committed team of nurses, putting them into the hands of legislature, no matter how well-being, well-intended, will potentially harm nurses, degrade patient access, and ultimately undermine our hospitals. I understand why this proposal sounds appealing on paper. I too am concerned about caregiver burnout, staffing shortages, and am passionate about finding solutions to help our nurses. However, rigid nursing staffing ratios are not the answer. We need to empower our nurses at the bedside to work collaboratively with their leaders to make crucial and fast-paced decisions about patient care, as we were able to do throughout the pandemic. The proposed ratios will remove our nurses from decision-based making processes altogether, instead enacting flexible mandates that will enforce 24/7 statewide, regardless of the caregiver input, hospital size, or patient acuity. As New Vance Health Eastern Regional President, I oversee hospitals that are as diverse as the communities we serve. Holding a small yet high-quality facility like Sharon Hospital, same rigid ratios as a large medical center like Danbury Hospital, is not only impractical, it's potentially detrimental to patients' ability to access quick care that they need. Connecticut hospitals are lucky to be home to an incredible group of caregivers, including our nursing staff, our nursing leaders, and direct care nursing staff care deeply for our patients and are continuously proactively working together to share the responsibility of appropriate staffing so patients can receive best care possible.
Excuse me, Ms. Adams, but your time has expired. Thank you.
Thank you.
Thank you, Ms. Adams, and thank you for the work that you do together at Danbury Hospital. We have a question from Senator Kushner.
Hi there. I'm so sorry that the transmission was really poor and it was very hard to hear you and understand your testimony. I'm sure people on the committee will read the testimony, and I just wanted to acknowledge you and thank you. I have spent time in the hospital, as you well know, with you, and I do, as you know, I support this effort by the nurses and by this committee, members of this committee, to pass this bill. And I know that we have a difference of opinion on that, but nonetheless, I really value Danbury and New Milford Hospital in our community and everything you do to serve our community. I can't say enough about how much I appreciate it, given the terribly difficult times we've been through. And Danbury Hospital has been a resource that is so much needed in our community. So thank you for that.
Thank you, Senator Kushner.
Thank you, Senator Kushner. Representative Zupkis.
Thank you, Madam Chair. Thank you, Mrs. Adams, for coming tonight. My question is, we have actually heard a lot of people in favor of this bill, and I would have to say, by my estimation, most of them are from Danbury Hospital. And I'm curious as to, are you aware of, I would say, the frustration with the nurses there, and are y'all working together on this? Because it seems that most people are from Danbury Hospital that are in favor of this bill.
Yes, first of all, thank you for the question. And I am aware, we are aware, and we have been working with them. We do have a staffing committee that we actively work with them on. We do have shared governance. We are doing extensive recruiting. Some of the models that you did hear other nurses suggest that we used, we have already started LPNs back in the care hospital that we had already started working on. We do have a number in our our inpatient units as well as in our emergency department. We have been working with universities and colleges, so a great deal of workforce recruitment initiatives and working with staff. That does not mean that they're not still, as they have mentioned, having workforce challenges every day in their experience. So I am aware, as well as the chief nursing officer, have been working with them and partnering with them.
Thank you. I appreciate that. And so if I heard you, so y'all are working together to
Yes.
try to do something with this. I don't, a lot of people have said these ratios are going to, there's not a nurse shortage. It is nurse, I'll say, unhappiness, and don't want to come to work in an environment. So I believe personally there is a nurse shortage, and hopefully if this bill passes, it would solve that problem, but I'm not sure that it will. But thank you. I appreciate your comments.
Thank you, Representative Zupkis. Seeing and hearing no other questions, thank you, Ms. Adams, for being here with us today, and have a great rest of, well, the day, I guess. Thank you. Next, we have Henry Schneiderman. Welcome.
Thank you. Good evening, members of the Public Health Committee. My name is Henry Schneiderman. I support SB 1228 and SB 9. But SB 9 does not appear to correct the difficulty with APRN collaboration, a process well described by Clarissa Fairbanks about 2 hours ago in her testimony, only with licensure. And so I request that APRN collaboration, which is adding APRNs as persons who can be the collaborator with newer APRNs, fulfilling the need for the 2,000 hours of being overseen, be addressed and endorsed in this bill or in Senate Bill 9, Section 22. Scope of practice is the activity that a provider is authorized to perform, such as examinations, prescribing, procedures. These have been published for NPs by the state following the work of the Scope of Practice Committee on which I testified in 2013-14. The scope was thoroughly discussed at that time and agreed upon by stakeholders. It is a settled matter. A representative of DPH has written formally that this is not a scope of practice issue. Collaborative authority, meaning having the right to be the oversight person to whom a new NP reports, is not a scope of practice issue. Licensure means an APRN is authorized by the state to practice. It does not specify whether a collaborator is required. Independent practice is a further authorization achieved after a specified time in practice with a collaborating person, whereby the APRN no longer requires a collaborator. APRNs take major roles in training APRN students, and it makes no sense to cease their oversight, mentorship, and teaching once the student has graduated to become a licensed APRN. Adding APRN collaborators will enhance the healthcare environment by offering patients more choice in their providers. It will empower newer APRNs to obtain the oversight they require for those first 2,000 hours, and thus will enlarge the workforce with skillful, devoted persons. Patient satisfaction instruments show high favorability toward APRNs based on their careful bedside work, their superior communication, and people skills. Everybody wins if APRNs gain collaborator authority status. The people of our state foremost, and APRNs themselves, of course, but also us physicians, who now will find that workforce shortages, especially for the most underserved among our patients, are suddenly and enduringly ceased. Finally, Section 22 of SB 9 does not provide for reciprocity between states. It won't alleviate the difficulty of getting more out-of-state APRNs to practice here in Connecticut, although it is a step in the right direction. Thank you for the opportunity to speak, and I would welcome questions.
Thank you. So is it Dr. Schneiderman?
It is.
Yes, I apologize. I was taking notes during your class. I just wanted to point out that you are, and maybe you can help us all. On our sign-in sheet, it says that you are professor of medicine at the UConn School of Medicine, Quinnipiac, and Yale School of Nursing. Is that right?
Well, I am a clinical professor of nursing at Yale, and that's because I teach APRN students. I don't have a nursing degree, but like everybody else who's spoken today, I have the most intense respect for nurses.
Thank you. I appreciate that. We've had some healthy debate around this. It's actually an oval, and circles as well, related to our roles. And I appreciate your testimony here today. It's actually very helpful. Representative Claritas Dietrich has a question for you.
Thank you, Madam Chair. Thank you for your testimony. I'd like to get your opinion on the collaboration portion. Do you think that a currently practicing APRN should be working in practice X amount of years before they would be able to get the authority to collaborate with another APRN?
So I don't look for a change in the current requirement, which is that they have 3 years practice under the supervision of a collaborator and 2,000 hours, and that they are then able to practice independently. I think at the point that they're authorized by our state to practice independently, they are then suitable to serve as the collaborator. Right now, the collaborator has to be a physician. You've heard eloquent testimony about the difficulty finding collaborating physicians. Some don't want to, some don't understand, some feel that nurse practitioners are economic competitors. Some don't look at the big context. Some, like myself, simply are stuck because they would have to incur malpractice coverage, even though the role of the collaborator is relatively limited. And so I think if we open up collaboration, that is to allow the nurse practitioner to continue to teach his or her younger colleague postgraduate as they do before the obtaining the APRN license, we will ease this problem. We will attract more nurse practitioners to work in our state, and we will create a healthier healthcare environment. I hope that answers your question, Representative Claritas.
Yes, it did. Thank you very much. Thank you, Madam Chair.
Thank you, Dr. Schneiderman. We very much appreciate you sticking with us to be able to have this conversation and to share your perspective unique to the role that you have as a teacher.
Thank you. My privilege.
Have a great rest of the day. Next, we have Lindsay Downing. It's impressive how many people are still here with us in person, I will say. Thank you very much. Welcome.
Thank you. Hello, everyone. Well, not good night, but good evening into the night. My name is Lindsay Downing, and I thank you for hearing me today. I'm here to speak to the proposed SB 1067, an act concerning adequate and safe healthcare staffing. I'm here out of concern that this bill is being brought forward for consideration. While it is being presented as an attempt to advocate for nurses and patients, the direct result, I'm afraid, is that we are actually putting our patients at risk. As nurses with college degrees and learned assessment skills, we as professionals need the autonomy to make decisions in the moment to reflect what is best for both patients and staff, and have the ability to allocate staffing resources based on that moment's need. Healthcare is anything but predictable, and having dictated ratios that are based on number and not acuity is scary and goes against our pledge to do no harm. It does not allow us as professionals to appropriately staff based on patient needs. Rather, it forces us to conform based on numbers alone. Patients are not numbers. They are human beings. They're our family, our friends, our loved ones with unique needs. 18 years ago, California passed a similar bill. In those 18 years, I was able to find any research with proven correlation between mandated ratios and better patient outcomes. Specifically, the rates of many hospital-acquired conditions were unchanged. In contrast, emergency room wait times increased, emergency room diversions increased, wage cost has increased by the need to hire travel nurses, further translating into budget cuts elsewhere. nurses have lost their much desired and earned autonomy to make decisions based on their experience and judgment. At Middlesex Health and our current staffing model, our nurses are involved in staffing decisions and are encouraged to challenge those that do not fit with the current patient demands. Changes are made and staff are allocated to the areas of the greatest need. In summary, if you are still in support of this bill or even on the fence, I ask you to imagine yourself, your friend, a loved one, being told that you will have a long wait in the ER because we are at capacity based on staffing mandates. Excuse me. I ask that you further imagine that there are empty beds in that very hospital that without ratios could have been used to get you the care that you were seeking in a more timely and safer fashion. Our nurse to patient staffing model is important. Absolutely, 100% yes. I don't think anyone here would challenge that. But if your overall goal is safe patient care and nurse satisfaction, let the nurses be part of the decision-making in the moment. Support nurse autonomy, support hospitals, support staff. I ask you to seriously consider what benefit this bill would have to people on the front line and their patients. I can tell you that what we want as a profession, we went into this profession because we care. I started as a PCT, a patient care technician, then a nurse resident, a charge nurse, a preceptor, an assistant nurse manager, and now a manager, and I dabble in home care on the weekends. I would rather take an additional patient any day, knowing that their care is not being delayed based on them waiting for a ratio staffed bed. Passing this bill would create a one-size-fits-all approach to hospital staffing and simply does not make sense. Thank you so much.
Thank you so much. And thank you for staying here with us for so long today. Of course. Seeing and hearing no questions or comments, we wish you a wonderful rest of the day.
Thank you.
Next online, we have Bill Garrity. Welcome.
Good evening. Thank you very much. Can you hear me?
We can hear you, but we cannot see you.
I don't know why.
I think you have to accept the promotion in order to be able to turn your video on. I don't know if you're able to do that.
How about now?
We saw you for a minute. Now, you want to try that one more time?
Working on it.
Oh, there you are.
Wonderful.
Wonderful. Welcome.
Hi, good evening. Thank you very much. My name is Bill Garrity. I am a registered nurse of 33 years with 27 years at the University of Connecticut Health Center. Representative McCabe, sorry, I guess my camera's going out. Representative McCarthy-Vahey, thank you for being here, along with the rest of the Public Health Committee. I'm very happy to be able to speak today on in support of 1067, Senate Bill 1067. I've already provided written testimony, and there is a you've heard quite a bit through many nurses and many administrators through this. Unfortunately, I'm hearing so much about the nurse-patient ratio piece of this. I really want to talk about the whole bill, but let's just start with some of the other stuff going in here. This bill has stuff that healthcare workers have been working on for decades. I'm just going to say this, the elimination of mandatory overtime. The very first time I was in the state of Connecticut, the very first time I was up at the Capitol more than 20 years ago, was to talk on mandatory overtime, was to try and speak out against it. I was 26 years old, 27 years old at the time, I think. I was scared then. I'm not so scared now. That's a good thing. The next part of this bill is probably the whistleblower protection. I want you guys to ask yourself, why in the world did so many nurses go ahead and put in anonymous testimony? Because they are afraid of what's going on. You know, they're afraid of retaliation from their own management. And you've heard the management here going and saying these things about they're the ones who are in charge, and they're the ones who should be making these ratios. I sit on the nursing staffing committee at UConn Health. And believe it or not, I really believe we've got a fairly strong nursing staffing committee. The union is able to put the members on from the labor side. We have multiple discussions. We go over vacancies on a monthly basis. We go over every bit of mandatory overtime on a monthly basis. We are very collaborative as we look at these things, but it doesn't change the fact that we already have ratios in the state of Connecticut. Each hospital has to provide them to you guys. So I don't know why no one has gone ahead and said that. So that's part of an issue there for me. And they're just not in a great spot. They should be better. And the nurses who are at the bedside should be involved in those decisions to be able to make those changes. When we have issues and we have to fill out unsafe staffing forms and we work with these and they go to our nursing staffing committee, even when we go ahead and have our director of nursing look at these things and say, chief nursing officer, sorry, I'm an old guy. Look at these things and say, well, yeah, you're right. We could have done better. It's like, oops, oh, well. And at the time we've got nursing supervisors saying, just do your best. I spent 5 years in the emergency room before I was elected union president. And in the emergency room back then, we had patients in the hallways. We still have patients in the hallways after building a brand new hospital, brand new emergency room.
Excuse me, Mr. Garrity, but your time has expired.
Okay. The only other thing that I would like to add, if anyone has any questions for me, the only other thing I would like to add would be the one thing that a study from 2021 stated that each additional patient over a certain point was a 1 in 16 chance of causing an error, 1 in 16 chance of causing a fatal error. 1 in 16 I'm sorry, 16%, I apologize. 16%, 1 in 6 is 16%. It's a die, it's a 6-sided die. You know, do you want to roll the die? Because I don't. I've been a patient, I've been a staff member, I've been a nurse.
We have a question for you, Mr. Garrity.
Hi, Senator Summers.
Thank you. Senator Summers, welcome. Please proceed.
Yes, thank you. It's not really a question. It's more of a statement. I've been quiet all day. I know we have a lot of people to get through. I just wanted to, just respond on some level to a statement that Mr. Garrity had made about why nurses aren't testifying today. And I have heard from numerous nurses that they are uncomfortable testifying, not because of management, but because of this new group that has popped up. It's called Connecticut Nurses United. It's an Instagram group, and they have actually taken people's testimony that testified today in opposition of this bill. They have posted it up on Instagram. They are really like cyberbullying those folks that have that are in opposition to this bill today. And they've actually called out members of this committee on there. So that's why I'm hearing, I must have heard from I'll put it this way, more than a few nurses, that they were intimidated on coming and speaking in opposition of this bill today because of what's going on. It seems to be an anonymous site, but they are taking testimony of people from on this bill in particular and posting it all over. So I just wanted to make sure that I said that tonight. I wasn't going to mention it, but that is another reason why I think nurses have been intimidated and not have come in front of this committee to testify how they truly feel if they've been in opposition to this bill. So I wanted to get that on the record. Thank you.
Thank you for that. However, the testimonies that have been put forth that say anonymous, almost all of them do say that they are in favor of this bill. And again, the ratios are only one piece of this bill. And that's
I just want to make sure that was on the record because of, I wouldn't have mentioned it, but of what you said previously, so that there's a fair and balanced, recognition of what is happening also. Thank you.
Thank you, Senator Summers. Seeing and hearing no other questions or comments, Mr. Garrity, thank you for taking the time to be with us this evening.
Thank you very much.
For quite a period of time as well. Next on the list, we have Jason Lindy.
Yes, good evening. Co-Chair Senator Anwar, Representative McCarthy Vahey, Ranking Member Senator Summers, and Representative Clarice Ditria, and members of the Public Health Committee. Thank you for this hearing, and I applaud your stamina and your compassion. My name is Jason Lindy, and I'm the Senior Vice President of Government and Community Relations at FAIR, Food Allergy Research and Education, the nation's largest nonprofit engaged in food allergy advocacy, speaking on behalf of the more than 350,000 Connecticut residents with life-threatening food allergies. Connecticut's food allergy population is larger than the combined cities of Bridgeport, Hartford, and Danbury, and many years ago included my son, who was born at the wonderful Griffin Hospital in Derby, and he has a finfish and shellfish allergy. FAIR strongly supports and encourages the passage of SB 1073, a bill requiring emergency medical services personnel to administer epinephrine during an emergency. Every 3 minutes, a food allergic reaction sends someone to the emergency room, accounting for more than 200,000 visits per year. And epinephrine is the only medicine that will stop a potentially fatal anaphylactic attack from happening. Now, contrary to the prior testimony given this evening by the Connecticut Association of Paramedics and EMTs, I'd like to point out just a few things. Epinephrine auto-injectors are easy to use and have been the standard of care to treat anaphylaxis for decades. Some epi auto-injectors, namely AviQ, instruct you how to use the product. They are foolproof. Many distributors of epinephrine auto-injectors provide discounts for EMS providers. Also, epinephrine auto-injectors make it impossible for an individual to overdose on the medicine or for an emergency medical responder to give too much. Lastly, FAIR's no-cost 25-minute epinephrine auto-injector training course is ANSI certified and is used by the states of New York and Minnesota to teach thousands of teachers and public service workers how to recognize anaphylaxis and use EpiPens. We would love to make it available at no cost in Connecticut. Here's why all of this matters. Whether it was the deaths of 2 children in the food allergy community over the past 2 months because they had an allergic reaction and the first responders were unable to administer epinephrine immediately, or the untimely and tragic passing last year of New Britain's own Eddie Rubinowitz, who died as a result of a bee sting. We can't afford to lose another Eddie or another child when there exists such an easy solution to this problem. You can help prevent any further tragedies by passing SB 1073, and I'm happy to answer any questions you might have this evening. Thank you again.
Thank you. What great timing, Mr. Lindy. I wanted to ask one quick question. We heard testimony earlier about temperature sensitivity and storage. Can you speak to that very briefly?
Sure. And yes, there are some concerns about temperature settings. However, let's be honest, when I heard the testimony about cars not having air conditioning, I was sort of surprised, frankly. For an epinephrine auto-injector to be destroyed by heat, it would take prolonged exposure in a car that is extremely hot for hours on end. So I sort of smirked a smidge when I heard that. So I don't believe our police officers in Connecticut are driving around in cars that are in excess of 100 degrees.
Thank you.
You're welcome, ma'am.
Thanks for taking the time to stay here with us today and for your ongoing advocacy on this issue. We appreciate it
Sure. Thank you. Have a good evening. Bye-bye.
too. Okay, next on our list is Tom Keslow. Is Tom here with us? No? Okay. And then we have online Angela Duhame.
Hello, good evening. Senator Anwar, Representative McCarty Vahey, and the esteemed members of the Public Health Committee. I'm offering some quick testimony in support of House Bill 6914 and 6915. My name is Angela Duhame, and I'm the Executive Director for CRAC, which is a Regional Behavioral Health Action Organization for Region 3, which is all of Eastern Connecticut and 41 towns. And also the Vice President of the Connecticut Prevention Network, which makes up our 5 regions. So thank you so much for 6914 and 15 and understanding the need for settlement dollars and tax revenue to be appropriated toward youth and community prevention efforts, specifically related to electronic nicotine delivery and cannabis use. And I just want to offer you a few of the things that the RBHAOs will implement with this funding. We will provide information through training and educational presentations with community members such as youth serving agencies, local school districts, law enforcement, youth, families, and senior residents, coordinate with elected town officials to enhance local prevention councils and strategic prevention plans, coordinate regional and statewide prevention conferences to support workforce development and increase skill development, provide technical assistance to schools to improve health curriculums, support treatment providers to address early identification and intervention of nicotine and cannabis use disorder, connect residents to cessation programs to improve their overall health, host town hall meetings, community conversations that educate communities on public policy and identify social inequality. We will also work around national marketing and state marketing campaigns to address promotion restrictions and related to outlet densities and retailers, and increase education compliance with social hosting and proper disposal, and assist state local partners in ensuring adequate compliance with public policy and to work for top level quality improvement. By utilizing the existing infrastructure of the RBHAOs, we will integrate evidence-based practice across many state and regional local departments. So thank you for your time and support to serve 169 towns in the state of Connecticut and all of the residents that are being impacted by these two public health issues.
Ms. Tuhame, thank you so much for your work as the Region 3 Regional Behavioral Health Action Organization leader, and for the Vice President of the Connecticut Prevention Network. We really appreciate the work that you do, and I thank you for taking the time to stay with us to testify on 69, 14, and 15. Representative McCarty has a quick question for you.
Thank you very much, Madam Chair. And Angela, I just wanted to thank you and recognize CREC for all of the good work you are doing. And it's late. We'll talk again another day.
Yes, thank you, Kathleen.
Thank you.
Thank you, Representative McCarty. We appreciate Representative McCarty, all your support over the years too. Great advocate. Thank you so much for being with us, and enjoy the waning minutes of today. Next, we have in person, we have Winnie Ho. Welcome. Don't forget to press the button so we can all hear you. Thank you.
Okay. Hello, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Winnie Ho. I am a New Haven resident, an MPH student at the Yale School of Public Health studying harm reduction, and an organizer in the movement to establish overdose prevention centers in Connecticut. Today, I stand with 43 organizations and 325 Connecticut residents and out-of-state allies who have signed our petition letter to the committee to state our unwavering support for the harm reduction centers proposed by SB 9. I will submit this petition after my testimony to be distributed to the committee. Like many others here today, I want to emphasize the human cost behind these numbers. I am here because I have been told to my face by strangers that the people I serve deserve to die for their decisions to do drugs and that they do not deserve our help. There are people who I love that use drugs. There may be people that you love that use drugs. We have talked a lot today about the lives that have been lost, but I wanted to introduce something that's often said in harm reduction. We remember our dead, but we fight like hell for the living. I'm here to not speak only in support, but in urgency. When we have something 100% effective at saving lives, every single day we go without it is like deliberately withholding water from a burning house fire. We have very few public health interventions that are this perfect at preventing death. But far too often, the lives of people who use drugs are deprioritized and devalued until something is too dire to be ignored. The best way to honor those we have lost is to make sure that preventable death does not happen to those who are now fighting for their survival. I would like to address some comments earlier made about Rhode Island's OPCs, as our colleagues were unfortunately unable to join us today, but have submitted written testimony. Their OPC is actually poised to open later this year. An amendment to extend the legislation that they passed a few years ago was recently heard and is expected to pass favorably. Our colleagues have been tirelessly paving the way for their OPC, and I want to recognize their willingness to support Connecticut as we start our own journey. In 2016, I was 18 years old and a freshman when an OPC was proposed in my college town of Ithaca, New York, by the then Ithaca Plan. It's 2023, Ithaca still does not have one, but they knew that this was hard, and it was, but they wouldn't accept not trying. I don't want to go another 7 years of waiting and seeing while people die when we have had the answer all along. Yes, the federal law needs to change, but so do the laws here in Connecticut. One will not happen without the other. Connecticut has taken bold steps to be a leader in syringe exchange 30 years ago. I ask Connecticut to be a leader again in common sense drug policy. The road forward will not necessarily be smooth. But not only do we need to take this on, we do need to do it like something is on fire, because again, it is. In the time today, and I know that I am speaking as we hit midnight later, 4 more people have died in this state.
Excuse me, Ms. Ho, but your time has expired. Thank
Yes, I have
you.
my last sentence. Thank you. More than this bill, we need your unwavering support and commitment to keeping political will strong for the fight ahead. Thank you for listening today. Please support SB 9.
Thank you so much, Ms. Ho, for your passion and your articulate testimony at 10 minutes to midnight and for being here all day with us. It's really, truly admirable. I see others waving their silent clapping. That's right. Senator Anwar.
Winnie, wow. Amazing, amazing. And I can tell you that we are very awake and ready because you were talking about the place being on fire. You're on fire, and then you've been doing good work, and then you've been an amazing organizer. And I can't thank you enough for all the work that you're doing and raising that awareness in so many ways. So we hear you. We are so impressed and thankful to you for your leadership. Thank you.
Senator Anwar.
Thank you, Madam Clerk.
Thank you very much. Seeing and hearing no other comments or questions, we'll go next to Sherry Dayton.
Hello. Distinguished members of the Public Health Committee. My name is Sherry Dayton and I live in Quaker Hill. I am in support of SB 1067 and I hope you are too. I work as a registered nurse at Plainfield Backus Emergency Care Center, but I have worked in several RN positions. I've worked telemetry, Department of Developmental Disabilities, cardiac step down, float, visiting nursing, and emergency. They were all different experiences, but the one common denominator was they all were short-staffed. Most assignments have more work than any nurse can get done in one shift. We all have to-do lists at our jobs, but when a nurse's to-do list doesn't get done, that means that someone has been laying in their own urine or feces. Someone has developed a pressure ulcer because they were not turned. Someone has fallen because they tried to get up by themselves because it took too long for help to come. Someone's laying in pain because they haven't gotten their medication, or worst case scenario, someone has died. I know some will say that this is a nursing shortage, and I refute this because there are 89,000 nurses in Connecticut, 44,000 practicing in Connecticut, and of the practicing in Connecticut, 23,000 are staff nurses. How do we get a lot of them back to the bedside? Make our working conditions better. No mandating and safe patient limits will do this. The current staffing statute is ineffective, and I will give you several examples. I was a chair on a committee that branched out of our shared governance. Basically, the committee planned appreciation events like Nurses Week. On review of the bylaws of this committee, I realized that we were the designated staffing committee. We never talked about staffing. Once a year, management would come and give us a presentation on what an FTE was, and I guess they thought that was sufficient. We had to advocate through contract negotiations that resulted in a strike to get an actual staffing committee. But even then, despite meeting every month, management still presented their matrix to DPH without bringing it to the staffing committee. We had to arbitrate it. Even with the staffing committee and discussions, management still sees these recommendations as recommendations and not an obligation to actually collaboratively work together with the bedside nurses to come up with the matrix that they submit to DPH. Currently, Backus Hospital submits DPH numbers for oncology of 1 to 4 to 7, med surg 1 to 4 to 8, orthopedics 1 to 4 to 8, telemetry 1 to 4 to 7, progressive care unit 1 to 3 to 4, critical care 1 to 2 to 3, emergency 1 to 4 to 9, psych 1 to 4 to 8, and labor 1 to 1 to 2. No nurse on the floor would agree with any of those higher numbers on the end of that spectrum. Studies have shown that hourly rounding on patients increase good outcome for patients. Logically, every interaction takes a minimally of 10 to 15 minutes. So having more than 4 to 5 patients automatically decreases the patient's chance of a good outcome. I started in the medical field at 18 years old and have been a nurse for about 17 years. I have more stories than time will allow me to tell you of the risk of poor staffing on patients outcomes, but I will leave you with this one. One morning I got to work and I had a very sick dialysis patient with a low blood pressure, a very difficult time getting intravenous access. Then another patient walked in short of breath and needed help breathing with BiPAP. And then a little while later, another patient walked in with abdominal pain, chest pain, and the concern was that he ruptured his aorta. These are all one-on-one patients where nurses cannot leave the room. We only had 2 nurses with 3 critical patients. We had a paramedic stay with the 3rd patient, and thank goodness it was not an aortic dissection. Another issue was every other patient in the emergency department got no care for hours until we stabilized these patients. If there had been one more critical patient in there, there's no doubt in my mind that next critical patient that walked through the door would have had a really bad outcome. What if the next critical patient that walked in that door was your loved one?
Thank you.
Thank you. Okay, I just have a little tiny bit more, if that's okay.
Go ahead. If you can
Okay.
summarize and complete, that would be great.
Okay. Healthcare professionals prioritize by patients, and they are leaving the bedsides because it's no longer the priorities of larger healthcare organizations. We are experiencing a retention problem. This bill will help that. We also are getting hurt more at work, either by filing workman's comp for mechanical muscular issues or from workplace violence issues. These statistics will improve because we can seek help and find it when we're looking for it if we have better staffing. The healthcare organizations are spending money on bigger buildings to consolidate offices. It costs $40,000 to train a new nurse. So this will save them money. It will make better working conditions for nurses, and it will also give patients better outcomes.
Thank you. Thank you for being here with us today and sharing your experience and perspective. Seeing and hearing no comments. I also thank you for your service as a nurse, especially during this difficult time. Next on our list, we're going to go to Peter Zarabozo.
Hi, my name is Peter Zarabozo. I've been a registered nurse for 12 years and have worked in acute care, in a management capacity, in an operating theater, and currently in an ambulatory setting. The previous speaker, Sherry Dayton, has done an excellent job of summarizing the points to support Bill SB 1067. These nursing ratio proposals are absolutely critical to ensuring safe patient care. And I want to take the time to address some comments from representatives and other speakers. The true reason that people don't speak out in opposition to this bill, or nurses don't, is because there is no floor nurse that is opposed to this bill. The opposition you see here today are executives who used to be nurses, and in my opinion, and in the opinion of my peers and former colleagues who still work on the floors, are traitors. We know that the conditions in the hospital are dangerous, and that
Mr. Zarabozo, I'm just going to ask, I've said this many times in this committee, it's to assume intent, and we just want to, as we approach this issue, make your case about why you are supportive without just impugning others' motivations, if you would.
Sure. Because nursing shortages in this state are not a real issue. And I firmly believe that if we had nursing ratios, we would make the nursing environment a lot more attractive and would end up importing nurses from numerous states. Nurses find California very attractive. And if we do have a nursing shortage, which I do not believe we do, what we have is a poor working condition for nurses, and nurses migrate outside of the profession, or they migrate into non-acute settings. So this notion that this would worsen the nursing shortage, I find is fictitious, because this is something that nurses desire, and being in a geographical area that we are, we would likely pull in many, many nurses from surrounding states in the region to solve that issue and bolster the settings of our hospital and improve overall patient safety. Thank you.
Thank you very much. And I'll just comment, as I have earlier in the discussion today, there's a lot of emotion around this issue, and it's understandable because we've heard clearly from so many nurses here today, and not just here today, about the incredibly dire and difficult circumstances that you all have worked under over the past number of years. And as nurses who are working on the floor, you're not making the decisions in the way that some of those who are testifying are. So I do understand and appreciate the difficulty and the stress of that. I think we may have lost you. I don't know if you're still here. Okay. Thank you for your testimony. Next up, we have Russell Maynard.
Hi there. Thanks so much to the Public Health Committee. I'd like to speak to Senate Bill 9. And I want to try and build on the earlier speakers because you've already heard a lot of really compelling information about supervised drug consumption services. And I just want to talk about bringing the drug poisoning crisis in America into a public health realm and help save American lives. And I'm coming to this with about close to 20 years of firsthand experience at working with what's at the heart of supervised services. And I want to build on what Kaylin C. and Professor Heimer had said earlier, and especially when Kaylin started talking about what is the simplicity, what is the core service that we're offering. And I want to offer an analogy and try not to repeat. So it's late there, and I understand that you've been at this for a long time. And I want to introduce an analogy, a way of having a visceral sense of what's going on in those settings. And that is as a lifeguard. Families no longer have to worry about children or loved ones drowning at public pools. There was a time in the early 20th century where drowning was a much more common thing. And the innovation in those days to save lives was lifeguards. And essentially, when we're working at supervised injection facilities or drug consumption services, we are lifeguards. The intervention is almost identical. The only difference is if you're using a medication to reverse the effects of the opiates. But getting people breathing and the rest of it, the CPR intervention, is identical. So I just want to leave you with that sense that what we're talking about is introducing lifeguards into a crisis that's striking all across North America, well over 100,000 Americans a year. And the solution, to some extent, is creating a scenario where lifeguards can supervise people who are doing what they're doing anyways. And further, I'd like to just build on what Professor Heimer was talking about. When people are in that setting, we're talking about a population that much more typically is really hard to connect with, hard to build relationships, hard to build trust. And so we can do that in that setting. And where I have worked in Vancouver, this Insight, the supervised injection site there, connects over 400 people a year that go directly into treatment, into detox. And I can tell the committee, there isn't another setting in North America, not in Canada, not in the US, not in Mexico, that sends anywhere near, no single setting that sends anywhere near 400 plus people. So the message there is that there's a profound ability to connect people to services. And Kaylin and Dr. Heimer touched on that, but I just want to emphasize.
Excuse me, Mr. Maynard, but your time has expired. Thank you.
Okay, that was short. Wow. Okay, thanks, everyone.
Okay, thank you. Yes, it does. It goes very quickly. Your analogy is very powerful. I appreciate that. Senator Anwar.
Thank you so much. We're just talking about what a beautiful way to help people understand this harm reduction in such a smart way. So I appreciate your example. Would you be able to just finish the last minute or so of your testimony?
Well, I was going to talk about in Vancouver, the Vancouver Police Department. Often people want to know, how do these services work with something like law enforcement? And in Canadian settings, I think law enforcement often in the beginning, it's counterintuitive to everything you've kind of been trained and understand as law enforcement. And over time, and we're talking 20 years in Vancouver, the Vancouver Police Department is very supportive. And what's the motivation for that? Officers don't particularly want to attend many overdoses over and over again. And so there's the cost savings. There's the obvious cost savings. Every time an ambulance lights up and races across the city to try and save someone's life, again, in a setting like Kaylin described in New York City, you're really profoundly starting to chip away and create efficiencies in the public health system and change the way we view folks that are living on the fringe of our community, and start connecting with them and building relationships and really being able to offer everything from housing services, basic food, daily contacts, and then even things like treatment, etc.
Thank you. Thank you so much. We appreciate your patience with us and sharing your thoughts with us. Thank you. Thank you, Madam.
All right.
President.
Thank you, Senator Anwar, and thank you, Mr. Maynard, for being here with us and for your work in this area.
Okay, all the best. Good night.
Thank you. Seeing and hearing no other comments, next is Richard Liverano here. Welcome.
Are we on? There we go. Baby's first testimony. Let me be the first to say, distinguished members of the Public Health Committee, good morning. My name is, yeah, I know, I'm sorry. Thank you all so much for being here all day. It is so very appreciated. My name is Richard Liverano. I am the Manager of Institutional Giving and Impact at Liberation Programs. I live in Hamden. I'm testifying today in support of SB 9. I support this bill because it represents a wildly bold step in public policy. It's one that will undoubtedly save lives and connect people who use substances to essential services in order to keep them safe. I know that's been said many times today, but it's so important to reiterate exactly what it will do. Because Connecticut has the 10th highest overdose mortality rate in the country per 100,000 people, with almost 1,500 preventable overdose deaths in 2022. And since 2015, 9,230 preventable overdose deaths. We can't continue to go down the road we are going on, and we have to act. And that's what this bill does. I'm not going to recap it because we all know what's in there. I don't necessarily have the extreme experience that somebody like a Mark Jenkins or a Liz Evans has. I have a music degree. I've only been in this field for a few years, but at the same time, I can recognize the extreme need that is still here. I've lived in Connecticut for nearly 9 years, since 2014. Since then, we've lost approximately 10,000 residents. I'm fortunate enough to not have experienced a loss in my own life, but we've heard so many stories today, like the story of Tim. Since 2014, there's 10,000 of those stories in Connecticut alone. I can only imagine the pain and the loss felt by 10,000 families since 2014, since I've been here, those 9 years. I am a new homeowner here in Connecticut. My wife and I just purchased a house in Hamden, so we're here for a while. And I hope the next 9 years represent this bold move forward that we need. Substance use isn't a metric of character, it's a matter of chemistry. We have to provide support for people who use substances in the same manner how we provide support for people with other chronic conditions, respectfully and without stigma. For people who have been stigmatized and made to feel like they've failed, the best thing we can do as a state is to support them every single step of the way. So I ask for your support with this bill. It's one that protects some of the most vulnerable and at-risk folks in the state. Thank you all again so much for your time throughout today. I'd be happy to answer any questions you may have.
Thank you so much. I appreciate the good morning.
Of course.
And that's a powerful statement that substance use is not a measure of character, but chemistry. Thank you for that reminder. Representative Carpino.
Thank you. Thank you for us this morning. Just a quick question. I'm looking at what I think is your website, Liberation Programs Recovery for Life. Okay, thank you.
That is us, yes.
I had the right website, and you have a link. You list a number of the services that you offer, and there's a hyperlink to everything except harm reduction services. Can you just tell me specifically what harm reduction services you offer that doesn't have a detailed hyperlink on your site? So I don't want you to have to repeat everything that's available.
Absolutely. That part of the website's under construction, so that's why we don't have it just yet. Full disclosure, Liz Evans, who was here earlier, is part of Liberation Programs as well. She heads up our outreach programming. So we have 2 mobile wellness vans that go throughout Lower Fairfield County, typically Stamford, Norwalk, Bridgeport. We are expanding. They provide syringe exchange services, access to safe use materials, condoms, bottles of water, linkages to care, anything just to put a face there for somebody who needs to see somebody for a little support that day. We are also working on deflection programs with police departments throughout Lower Fairfield County, most notably in Bridgeport and Stamford. It is a partnership with the McCall Behavioral Health Center. So we're making strides.
Thank you. Thank you for what you do, and thank you for the entire organization's efforts. Thank you,
course.
Madam and Mr. Chair.
Thank you very much, Representative Carpino, and thank you. We as Fairfield Cares have been able to participate in many events with Liberation Programs and
Thank you for that.
and have had the van and seen at many community events, and it is just great work that you're doing. So thank you for taking the time to be here with us today.
Of course. Thank you for being here.
Much appreciated.
Thank you.
Next is Mark Jenkins here with us. Wow, you all are amazing. And those of you online too. Welcome.
Good morning. I would like to submit, if I may, some graphic testimony to the work that we presently do, if it is allowable.
Absolutely. We'll have you give that to our clerk afterwards and we can get
So-
that. Yeah, we want to right over here.
Alrighty. So
Please
my name is
proceed.
Mark Jenkins. I am the CEO of the Connecticut Harm Reduction Alliance. Also Reduce Harm Incorporated and United Syringe Trust. I'm also the co-chair of the Connecticut Harm Reduction Action Group. I'm a harm reductionist. It is my job, my duty, my calling. Some might say, if not for my language, my ministry to help individuals reduce the amount of harm they cause themselves and their communities as a result of illicit substance use. My organization has, as well as myself, I've done the work frontline, engaging individuals, as Dr. Heimer so eloquently spoke earlier, of this work going on for as long as it has in the state. I've been doing it firsthand for about 25 years. My organization in the past year, just for information like the graphics that you're going to see, engaged over 3,600 people hand to hand for over 24,000 transactions. So a lot of the information you heard earlier today, even from outside organizations, I'm so glad to hear from Liz earlier, from Kaylin. These are some of the things that we do on a daily basis. Last year here in the state, we handed out well over 150,000 sterile syringes and collected over 770,000 of them back off of the street. One of the things that we've done, throughout COVID is we never stopped. We kept our doors open because we understand the opposite of addiction is connection. And COVID has really done a lot to separate those individuals seeking recovery from services. And what, how things begin to look, pretty ugly. Making sure that the community has access to food. We presently make over 500 sandwiches a week. And I think that, added up to over 26,000 sandwiches last year that we handed out. We're constantly, we have a COVID vaccine in the clinic itself. And we have an RV that's in the community. We have 5 minivans that are out there. We provide services in Hartford and New Haven. And we have something we call the Rover, which right now helps to expand harm reduction best practices throughout the state. And we have approximately 35 of those rovers serving over 26 communities around the state. So it's always a constant, push to continue to see how we can make sure we're engaging individuals, to make sure they're staying safer, because that's what harm reduction is about. It's the non-judgmental service delivery. It's saying that you can try for abstinence or not, but let's keep the lives of your lives and the lives of those around you safe. Let's, keep you alive while we try and make sure that you're connected to services that have validity, that have value to the individual, so that there is a return, so that there is a constant, because we know it quite often there is just a repetition in these services. So
Excuse me, Mr. Jenkins, but your time has expired. Thank you.
Thank you. I think we have a question for you from Senator Antwar.
Mark, I think one of the things you did not mention that I need to mention is that you are not only a leader in the state, you are a national leader in harm reduction. In harm reduction conferences and conversations, you are one of the most experienced and knowledgeable hands-on information in the community, and in Hartford and the greater Hartford area. You are doing some very important work. I had the honor to be able to visit your site and spend quite some time with you. And it was very good to see that you're helping people out with fentanyl strips that you're giving for free, and also giving naloxone or Narcan free to people who are in need of it. So, which is very important. You're starting a lot of wraparound services and help and support at this time. And if this bill was to pass, how would that help you?
Well, as you mentioned, we are the state's largest hand-to-hand distributor of naloxone, doing over 6,000 kits last year. And not only with fentanyl test strips, which we introduced here in the state back in 2016, and they're really now just becoming widely acceptable, but we also have 2 other methods of, drug checking. We're part of a national drug checking coalition, as well as developing a relationship with the state laboratory, where we help them initially develop, their GCMS by supplying urine samples that they have used to test for decedents. Well, now we're going to develop that further to rapidly test the drug supply and just further things. But basically what you're saying is like, we're ready for this. It's like we see need, we meet need. So we see this coming, and while we're testifying for this, also, I think I have to mention that if I may, Senator, I forgot to, there's another House bill that's coming down that we have to look at the language when we're talking about mobile methadone, because it's restrictive. And see, we really are about meeting people where they are. And mobile methadone will be one of those ways where we're able to save lives. And if we're too restrictive in how we're able to meet people, it will be counterproductive to something that I think will be probably just as important, if not more important, as the Suboxone that we presently have.
And Mark, one of the conversations we had was in the intensive care unit. Nowadays, we are seeing individuals who's stopped breathing. They have taken a medicine, and we can't find any test to be positive for fentanyl or opioids or anything like that. So there are a lot of synthetic stuff that's there. And looks like you at your center are able to communicate with the law enforcement to tell them what's new in the market and get us prepared in advance to see what is out there and then gives us a feedback loop to be able to be better prepared to take care of those patients. Can you speak to that?
Yes, sir. Well, as various synthetic drugs, continue to hit the market, xylazine is what we see now is really wreaking the most havoc. And I'm sure my peer Peter will talk about this. He has a ton of information as well. But because of how it responds, and individuals are slower to respond to the Narcan. So therefore, it makes people want to, give more and more doses of Narcan when we have to teach new language continually to people on the front line, that we have to make sure people are breathing. It's not so much anymore that we want to see people upright and talking again, but just to make sure that they're breathing and not to keep adding, Narcan and naloxone when it's of not going to have any more, effect. So having the ability to see what's coming, to see the trends, to allow law enforcement to see the trends, to allow our participants to make educated decisions about the drugs that they're consuming. These are all very, very important things.
Thank you again for all that you do, and thank you for your testimony, and thank you for being with us from 9 a.m. till now, essentially back and forth. Thank you.
Thank you all. You talked about rock stars earlier. I'm truly impressed that you all are still here at this hour of the morning.
We're more of a band. Thank you.
Oh my gosh, I'd love to hear the band names that we've got. Oh, Mark, thank you so much for being here with us and for your good work day in and day out to help save people's lives. Thank you. And we have Peter Canning. Welcome.
Hello, hi. Thanks for having me, and thanks for this wonderful setting. I mean, this is just democracy in action here, to have listened to all the things that have gone on today and to all your thoughtful questions to people. My name is Peter Canning. I've been a paramedic in Hartford for almost 30 years. When I started, I thought people who use drugs had a character flaw. I'd tell them, you better stop using or you're going to end up dead or in jail. Only when I began listening to their stories did I learn that addiction is a disease, and that many people who use drugs began their perilous journeys because of doctors' prescriptions following an injury or illness. I heard the same phrase over and over from my patients. I used to be a normal person once. And they had been. They were loved people, all who were sent on journeys that they could not have anticipated, and which for many proved impossible to extricate themselves from. I have found people dead behind dumpsters, down alleyways, under bridges, alone in parked cars, in basements without light, and behind locked doors in public restrooms and family homes. Stigma and law drive people into the shadows where there is no one to help them if they overdose. According to the CDC, 91% of those who died of fatal overdoses died using alone. A few years ago, I was called to an overdose in a wooded area of an abandoned lot right next to the community health center on Grand Street. The medical staff there up on the 4th floor had looked out into the abandoned lot, and they saw someone who'd been using drugs, and they saw he was motionless. So they called 911. We got there and were able to revive him with naloxone. The next day, I responded to a medical emergency in the community health center up on that same floor. I talked to the staff about it, and I thanked them for calling and said they'd saved the person's life. And then I had a suggestion. I thought, wouldn't it be a great idea if instead of hiding in a wooded area of an abandoned lot, that man could have come into the health center to a special area where he could have used under the watch of a caring health professional who could have treated him if he overdosed, provided ointment for his abscesses, and talked with him about his life and his problems and helped guide him toward treatment. A little known part of the Hippocratic Oath says, "Into whosever house I enter, I will enter to help the sick." Wouldn't it be nice if the sick could enter our medical houses and be treated like everyone else with dignity, with care and love? I support the creation of overdose prevention sites in Connecticut. They won't save everyone, but they will save those who walk through their doors. Thank you again for this wonderful hearing that you put on and for your consideration of this issue. I'm happy to answer any questions if you have them.
Mr. Canning, this committee in this session has heard a lot of very powerful and very emotional testimony, and I've made it through all of it. But somehow your description of how alone people are is just hitting me in a very different place. Maybe it's because it's after midnight, but to say that 91% of the people who died alone. And if there's nothing we do that's more important in this committee is to make sure people know that they are not alone and that they have help. And I want to thank you for your testimony here today.
Thank you.
Oops.
All right, the next person on our list is Philip Hawley. Welcome. Thank you for your patience with us today.
Good morning.
Good morning.
My name is Phil Pauly. I'm a registered nurse in opposition of SB 1067. I've been a nurse in the state of Connecticut for over 11 years, and the majority of that time has been in the emergency department. I've worked as a staff nurse, a resource nurse that travels between emergency departments, and a charge nurse. And in my time, those roles, I've learned one thing: we must be flexible. While safety is always first and foremost in the care that we provide, we nurses must be allowed to use our critical thinking ability that we hold so dear. I am fortunate to work for an institution that embraces that skill, and while working as a charge nurse in the emergency department, use that skill frequently. SB 1067 would inhibit our ability to care for patients by potentially limiting access to physical space. Having rigid ratios would make it impossible for charge nurses and managers to mitigate the flow of patients and balance the department. SB 1067 would not only limit access for patients, but this bill would also increase the stress and anxiety of nurses. We all came into this profession to help those that are sick and injured, and being bound by law not to flex will lead to new challenges. As a departmental leader, there have been times when we have had to adjust our ratios based on the acuity of the patients established after assessments, and my team members were receptive to flexing when the plan was communicated to them. We have heard how there will be exceptions for critical circumstances, but more often than not, you may not know how critical a situation is until you've had the opportunity to assess the patient in a room. Yes, a gunshot or stabbing victim is obviously critical, but what about the abdominal pain? That could be an aortic dissection or the small headache that is actually a cerebral hemorrhage. If rooms are closed because of rigid ratios, it can increase the risk of mortality for patients. Currently, California is the only state that truly has a safe staffing law for almost 20 years. That has not changed their nursing shortage. We have heard that the safe staffing law would increase nurse satisfaction and bring nurses back. This is false. California has a shortage of over 44,000 nurses, and granted that number is proportional to the size of the state, that is a deficit that is not improving. It's only getting worse. California has had to augment their staff with travel nurses, which puts further strain on health systems, both with the quality of retained nurses and the cost of those travel nurses. SB 1067 would make it harder to do our job and make access to healthcare more challenging than it already is. On my last day in nursing school, I had a professor who stressed the importance of not calling myself an RN and to let the world know that I'm a professional registered nurse. The key to that is we are professionals at what we do, and what we do is patient care. We are the masters of our trade and often have to make hard decisions that impact patient care. Our goal is always the same: to provide safe care that improves outcomes for those we care for. We are dedicating to bettering ourselves through education and our professional autonomy so that we can change our lives for the better. Thank you.
Thank you so much for your testimony, and thank you for being here with us this afternoon, evening, and night and morning. I have no questions. I don't see anybody with questions. We appreciate your testimony. We really value it. Thank you for being here. Next is Ed Hawthorne. You're on remote. Welcome. Good morning.
Well, I was going to say good evening, but I'll go with good morning. Senator Anwar, Representative McCarthy Vahey, and the members of the Public Health Committee. My name is Ed Hawthorne. I'm proud to serve as the president of Connecticut AFL-CIO, a federation of hundreds of local unions representing almost 250,000 working men and women in the great state of Connecticut. It is on their behalf I testify in strong support of SB 1067. There are certain places where you should feel safe and taken care of. Your home, place of worship, school, of course, a hospital. The uncomfortable truth is our hospitals are in crisis due to unsafe staffing levels. The pandemic revealed chronic understaffing in our healthcare facilities, but unsafe staffing levels and the shortage of trained, experienced nurses weren't created by the pandemic. This crisis we find ourselves in was created by the greed of hospital executives over a much longer period of time. Their short-sighted and reckless decisions to put profits ahead of patient care and worker safety meant that nurses have dealt with unsafe patient loads and impossible expectations, increasing levels of workplace violence, fatigue, and mental health stress for way too long. I hear from hospital executives, as I'm sure you do all the time, about the need to train more nurses, which is true. But what I fail to hear is the pressing need to retain the nurses we have now. Burnout is real and nurses are quitting in record numbers. A 2022 national survey conducted by AFT Healthcare found that 23% of healthcare workers, nearly 1 in 4, were likely to leave the healthcare field soon. We must stop the bleeding and focus on retention in addition to training more nurses. By requiring hospital nurse staffing ratios to have minimum staffing ratios, patients will get the care they deserve because nurses will be able to focus on fewer patients. Nurses won't be put in dangerous situations where they unintentionally make mistakes or are forced to deliver substandard care to ourselves or our loved ones. This bill will help retain experienced nurses and recruit new ones. And furthermore, Brother Garrity earlier, the definition of mandatory overtime in hospitals is included in this bill. It prevents workers from being forced to work more than 12 hours per day, 48 hours per week, and during the 10 hours after their last shift ended. It is a stressful job. They need time to recover. This staffing crisis isn't some mysterious problem that we don't know how to fix. It requires hospitals as employers to put patients, the welfare of the workforce first, ahead of their own profits and greed. By adhering to staffing ratios, we can achieve the goal we all have, which is to improve care, save lives, and make our hospitals safe once again. I thank you for the opportunity to testify, and I'd be happy to answer any questions that you may have.
Thank you, Mr. Hawthorne, for your testimony. And we're just wanted to thank you for the time that you have taken to stay with us this evening and earlier in the day. We don't have any questions, and that's nothing to do with the importance of the issue or your testimony. It's just a bandwidth issue.
No worries. Have a great evening.
Thank you. Stay well. And next is David Pfau. Is David Pfau here? Not okay. And Ruth Kenobi. I think she's not here either. She was going to be online. And I think we have Kimberly Sue. Dr. Sue, you're on. Welcome.
Hi, good morning. I haven't been awake this late since residency. To this esteemed Public Health Committee, I just wanted to convey my passionate support for SB 9 and specifically the call for harm reduction centers. So my name is Kim Sue, and I'm an assistant professor of medicine and public health and core faculty in the program in addiction medicine at Yale School of Medicine. I am the former medical director of the National Harm Reduction Coalition, where importantly in that role, I've prescribed treatment on demand with buprenorphine in programs much like these programs, these harm reduction centers, in 2 of New York's syringe service programs. And I currently see patients at the Apt Foundation Central Medical Unit, which is a methadone clinic in New Haven, as well as at the Yale New Haven Hospital on the addiction medicine consult service. And I invite you and implore you to come spend a day with me. I'll be on service in the hospital in April for the whole week, caring for people surviving overdoses, sometimes facing organ failure, brain death, anoxic brain injury, people with preventable infections related to unsafe injection practices, such as endocarditis, an infection of the heart valves that requires 4 weeks of IV antibiotics and oftentimes open heart surgery to replace a wounded valve, or with people who have large skin wounds risking possible amputation related to xylazine, which is causing tremendous pain and distress for our patients. Everything has largely gotten worse during the COVID pandemic, and essentially I'm begging you and pleading with you to help us help patients. Really, this is something that I cannot prescribe for my patients, and this is the policy, one of many policies that I hope we can implement here in Connecticut. I was actually looking back at testimony that I'd given in 2017 to the state assembly in Massachusetts for a very similar bill. So I've been testifying, in Massachusetts, in New York, and now Connecticut, where I work and live, for these kinds of sites, which simply are evidence-based. There's over 100 in the world and not one single death, as Winnie Ho pointed out. I can think I've visited Vancouver, learned at from Russell Maynard and all of the people you've heard, Kaylin, et cetera. And, I've even visited, overdose prevention centers that are a closet with simply an IKEA table, Clorox bleach, and people with naloxone and oxygen that could keep people alive. So this is a very cheap intervention overall that could help me save lives. In 2019, I was giving a talk with DA Larry Krasner in Philadelphia, and I was literally looking at the parents of the organizers at Fordham University. Their son had just resumed use and relapsed and died. Like, he was organizing this session on safe injection facilities or sites, and they were crying. And I said, wouldn't you just want a place where I could have taken care of him, where I could have administered the medication that we use in the hospital and that Mark Jenkins gives out so liberally to save lives?
Excuse me, Dr. Asu, your time is up. Thank you.
Okay.
Dr. Sue, why don't you just finish your sentence and your last thought?
Yes, I'm just happy to continue the conversation, and, please come visit me. I'm a national, expert in harm reduction, xylazine, and treatment, which I do every day, is not mutually exclusive from what happens in these programs. Dead people don't recover. And so I cannot do this without you. So please come to me, and if you have any questions about treatment or anything, feel free to reach out to me and the program in addiction medicine at Yale.
Thank you so much for your testimony, and thank you for your patience with us. Can I ask a question about xylazine?
Of course, yeah.
2 questions. One is, New York is not seeing a whole lot. Pennsylvania saw a lot, and then New Haven is seeing quite a bit. How did it bypass New York and then came to Connecticut?
I mean, this is like an interesting question of, we do know that New York is just beginning to track for it and monitor it. So with my colleagues who are in the New York City Department of Health, like, they are not seeing these wounds. I'm in this whole text message chain of what are we doing about these wounds, and I think there's a lot of different drug distribution pathways that, HIDA in Connecticut can help us with. Bobby Lawler can help us out. But, there's a lot of different distributions, maybe up 95, and New York is a separate one.
And the second thing was that we have a pretty hefty, ambitious plan on Narcan. There is a fear that the xylazine mixture is going to increase, and Narcan is not effective in that situation. Are there any theoretical antidotes that we can look at?
It's a good question. I just went on the news in Chicago about the xylazine in the fentanyl yesterday, and we have no antidote at this time. It is a veterinary medication. There are a couple a couple possible things, but no one is really looking at it in human development as an antidote. So it's going to change. It has been and is already, as Mark said, is already changing overdoses. It's only getting scarier for our patients.
And another one is, are you seeing a lot of MRSA in the wounds, or what are the bacteria you're identifying?
There is a lot of MRSA. There is a lot of MRSA and a lot of MSSA, methicillin sensitive Staph aureus. That really could be eliminated by having access to a safe space where you can clean your skin like you would in a hospital, or any safe, well-lit place like you've heard about these centers. So if people actually had access to what they needed, we could prevent with skin cleaning, with alcohol wipes, like in hospitals, we could be preventing these injections, the injection related infections. Yeah. Okay. Endocarditis is a huge, 4 weeks of IV antibiotics, staying in the hospital, plus an open heart surgery. I mean, that is a huge economic cost to this whole state.
Yes. Thank you so much for your testimony. I'm not seeing any questions or comments. We appreciate you being with us. I will probably take you up on your offer.
Okay, I look forward to it. Thank you all. Good night.
Kristen McCarthy will join us too.
Okay, perfect.
Perfect. And Representative McCarthy as well. Good. We have a team. All right. We'll continue our meeting over there. Next person on the list is Donna Handley. Is Donna Handley still here? Okay. And Gabby Bottino. Not here. Janet Short. 3. And William Scheitinger. Here. All right. If we wait long enough, people leave, right? Virginia Moore here. No. And Michelle Karen. No. And Tara Degassi. All right. I know we're about to give up hope, and you just brought about hope. Welcome. Thank you. Thank you.
Hi there. Thank you so much for listening to me today. My name is Tara. I'm a bedside registered nurse in a cardiothoracic ICU at a level 1 trauma center in Hartford, Connecticut. I am in support of SB 1067. Many of my nursing colleagues have presented statements describing the working conditions in Connecticut hospitals. This has shown how urgent this problem is and how it affects every one of us, not just nurses. All of us will become ill or disabled during our lifetime. Are you comfortable with the care you will receive after hearing these stories? I can navigate this system because of my knowledge and training. I'm here for those who do not have that privilege, which includes most of my patients. I'm here on my day off or night off because you can never be too dedicated to a job that could kill someone if you do it wrong or rushed. This bill will not negatively impact my ability to do care. Assignments will still be made the same way, but hospitals will now have to adhere to a safe standard of care. It will be a difficult transition for some hospitals that have been relying on these lean staffing models for a better bottom line, but ultimately it will support bedside providers, reduce turnover, make care more efficient, and reduce morbidity and mortality in our patients. The CNOs and hospital administrators will now have to refocus on long-term workforce planning. We need 1067 to make conditions safe so that experienced nurses see a long-term future in bedside nursing. The term nursing shortage sometimes can bring up some hard feelings with nurses because we hear that term a lot from our administrators. Our hospital administrators often use this term to avoid taking responsibility for the conditions they continue to create and benefit from. They oppose this bill for selfish reasons, and I hope you will recognize their insincerity. These are the same administrators that tell us nurses to use the proper channels to improve and try to have a say in things in the hospital. As a nurse who has been in numerous meetings with management, CNOs, CEOs, all the C's, all the O's, anything you could imagine, personal phone numbers, none of it worked. We exhausted, and I mean myself and other nursing colleagues, we exhausted every proper channel. They continuously disrespected and dismissed us. They have control over these proper channels, which is why nothing changed and our patients continue to suffer. It is tempting to call out a CNO that testified earlier today who was part of those meetings, but I won't. Oh. Sorry, I'm gonna keep going. Hospitals cannot be trusted to maintain safe ratios, which is why Connecticut needs 1067. Current bedside healthcare providers are here and sharing our professional judgment in support of this bill. I also find it interesting that the opposition will also applaud nursing resilience when they have been a part of not only creating these obstacles that we face, but also have the power to currently remove these obstacles already, but choose not to because it is inconvenient for them. We need to stop glorifying this suffering by telling us how resilient we are and recognize it for the burden that it is.
Excuse me, Mr. Gassi, but your time has expired. Thank you.
Thank you.
If you want to finish your last sentence, you welcome.
Sure. I was going to say, since the hospital administrations continue to refuse to listen to bedside nurses, we are using our voices outside of the hospitals because, as it has been said earlier today, we are always there to pick up the pieces.
Thank you for your testimony. Just don't go away yet. Senator
Sure.
Kushner has a question or a comment online.
Sure.
Well, I just wanted to say to Tara, I had the opportunity to speak with you briefly today, and I told you I would be listening even if I wasn't in the room, and I am listening. And I really appreciate you staying so late in the night, even though you don't have to work tomorrow. I know you've been working hard, so we really appreciate you. And I appreciate the testimony you gave tonight. I think it was really informative. So thanks so much for being with us and for your advocacy.
Thank you so much for that.
Thank you so much for your testimony. See no other questions.
Can I just say one thing, Senator Anwar?
Go ahead.
Would you let Kristen know that I'm almost home because she wanted me to text her? I'm almost home. I'm safe.
Okay, our
Thank you.
call of duty is way above and beyond every aspect. We want to make sure everybody goes home safely. We'll be calling every single person who testified today.
Thank you.
Thank you.
Thank you.
All right, moving on to, is Dale Cunningham here? Welcome. Good. You want to turn on the mic?
But hear me anyway. I hope I'm not too loud. I get.
It's okay.
So good morning, Senator Anwar, Representative McCarthy, Vahey, Senator Summers, and Representative Clarice Detra, and members of the Public Health Committee that are left here. I've been here since noon, listening to everybody because this has been a passion of mine for 40 years. I've been a nurse for 47, but I've been fighting unsafe staffing for 40 years. My name's Dale Cunningham. I'm a registered nurse. I graduated from the University of Bridgeport in 1976, but I've been fighting for safe staffing since 1980 after working several years in New York. I want to tell you back then, night shift was 1 to 16 patients. So that started my career. I worked as a med-surg nurse, an intensive care nurse, a pediatric nurse, and then a NICU nurse and a neonatal ICU nurse. I've been doing that for 40 years. I started fighting unsafe staffing in California, which now I talk to my friends out there. It has worked. Ratios have worked. They're more satisfied out there. Yes, you talk of a nursing shortage. Yes, and you talk about I've heard about the baby boomers. That's me. I'm here because I'm hoping that in my last year of working at the bedside, that we achieve better staff levels at the bedside here in Connecticut to make every citizen and every worker that works in a hospital safe. I wear two hats. I am president of the Registered Nurses Union at Lawrence Memorial Hospital. I've been involved in the union since 1999. At first as then I was a rep first, and then I was many officers. So I have been here before. I was here when the first staffing bill was put in place. I've sat on the staffing committee since it started. Yes, we go through the motions. There's ratios in your staffing committee that are not being met, but there's no penalty for anything that is not achieved in the workplace. So you talk about ratios don't work, but there's ratios in the bill. We just want to make the ratios more safer and have guidelines. Some of them maybe you don't agree with, but we could all sit down and collaboratively come up with a guideline in ratios that will be safe for when a person walks in the hospital, that will make my colleagues in nursing feel more supported by administration. When I started, the team that I worked with was a head nurse, maybe one or two nurses and an aide. We all worked together, but as time has gone on, the head nurse or your manager has moved up into an office. She's not down in the trenches with you unless maybe she has experience and can lend a hand. There's many managers that manage a nursing unit that cannot function in that nursing unit.
Excuse me, Ms. Cunningham, but your time has expired. Thank you.
I have so much more to say. It's written down. I've talked about nursing in a NICU. I've talked about how just different things. So if you have any questions, can I just say one more thing?
Wait,
Okay,
can I ask you a question?
sure.
Do you have one more thing to say?
Yes.
Okay,
Just go out and talk to 5 nurses. Just go ask them. Yes, today there was lots of support, but I agree with my colleague over there who got so frustrated. I was like that when I was her age. I just want to see our patients be taken care of better. As the nursing president, I get called, I get texts round the clock of distressed nurses.
can I ask you a question? You know, I work with the understanding and a strong belief that nobody goes to work to do anything less than perfect. And I know the hospital administration, with all that they go through, they are not in this just to make money and run to the bank with happiness. It's not happening. They want to do good, and the nurses in the administration are from the nurses from the bedside. So what are the causes in your mind for them to have to do this?
I think they look at things differently now. You come up, they have a plan. They look down, how many FTEs do I need in my department? Over time, they've whittled them down. They have whittled them down so tight.
Why?
I don't know. They have special formulas. Over the years, they've given us tools like acuity tools to so they could do graphs to find out how the ratios were. Well, we had a tool. I can't remember what the name of it was. So at the end of your shift, you had to plug in, you know, what you did, what care you did for each patient, so they could look at it through their tool. Well, one tool we used, we never even got the results because it was telling them they needed more staff.
So Tara, I have a theory. I think the Medicaid funding is so low and the Medicare reimbursements are so low and the percentage of commercial payment is so minimal that there is not enough money and they're trying to cut corners to be able to survive. That's how I sense it in many of my conversations. And I think that's what I sense is the issue. But I also know that it may not be the universal answer for every hospital. But I do know that there's an opportunity to make sure that the most critical part of the workforce, the nurses, the bedside nurses need to be protected. So we hear you, we thank you, and we appreciate you being here with us this evening and night.
Thank you.
Thank you.
Thank you for your time.
Of course.
And
Sorry,
you
Dale.
worked over your 12-hour shift.
Christina, finally, you're on. Welcome.
Hi. Hi, Senator Anwar, Representative McCarthy Vahey, who's not here at the moment, and members of the Public Health Committee. Thank you for having me here today. My name's Christina Mukon, and I am a family nurse practitioner, and I am here as the Health Policy Chair for the Connecticut APRN Society. And I feel like I need to note that it feels very special to be here today because my background is mental health and substance use, and this is something that's very near and dear to my heart, and I very much enjoyed being here. And I have been here to primarily trying to talk about the ways that we can help with the workforce issues and getting those topics addressed. And as I've heard everyone talking, it seems very important to note that even when we talk about the nursing shortage and a lot of the substance use topics happening, that if we can eliminate some of the barriers and increase the access to outpatient care as well, hopefully we can prevent a lot of those rehospitalizations and ease some of that burden. You have my written testimony, and I have other topics written out as well. And I think that in light of some of the things that I've heard earlier, it might be helpful to kind of switch gears and address some of the topics that have come up for clarification purposes as well. I know Dr. Schneiderman talked. We had a number of different other people speak as well. There are a number of barriers for APRNs in the state of Connecticut being able to practice, and it seems that there is a little bit of a discrepancy on if these are scope of practice issues or not. I know that Senator Anwar has said that he thought that they were coming from DPH. We have been told from DPH that they're not scope of practice issues. Right now, in the state of Connecticut, there's more than 8,000 APRNs. They do need to have 2,000 hours and 3 years of practice of experience before they can practice independently. But that collaborative agreement that they need in the meantime with only a physician is significantly impeding practice. We have so many examples of APRNs leaving the state because they say they cannot find a collaborative partner in the practices that they want to work in. Adding an APRN to that collaborative agreement does not change the training that we would receive. It does not change or expand the services that we are providing. And it does not change. There's one other component, and my mind is blanking because it's 12:30 in the morning. It doesn't change our training. It doesn't change the services. Oh, and it doesn't change our oversight. I think that's the big component that is a misunderstanding with a collaborative agreement, because it's not supervisory. There's no supervision with a collaborative agreement. A lot of the examples that we have, I know of one psych APRN that was trying to find a collaborating physician, and she found a nephrologist that was in California that was licensed in Connecticut, and that met the statute. And that's the type of thing that's happening because it's not relevant to practice. When we're actually practicing and we need to collaborate, we collaborate with peers, with a specialist if we need to. So it's really just significantly impeding practice. And
Excuse me, Ms. McComb, your time is up, but thank you.
I could give you other information, but I won't. I think that was the gist of it.
Actually, no. Please give us another example.
I just wanted to highlight as well that the areas, the problems that we're having right now, we know are going to continue to get worse as the rate of physicians are increasing from the Bureau of Labor Statistics. They expect it to be 3% from 2020 to 2030, and it's 45% for APRNs. So it's going to continue to worsen. In addition, the main concern, of course, is providing high quality care. That is, if we added APRNs that increased access, but it decreased quality, that would in no way serve the patients of Connecticut or the residents of Connecticut. But there's so much robust evidence behind APRN quality of care, as well as those checks and balances in place to make sure that there's not a deterioration of training. which is the safeguard that we want to make sure is in place. So there's not a deterioration of that quality of care.
So Christina, thank you for being here. Thank you for your advocacy and thank you for the time that you've given me in the past few times when we've had pretty long conversations. You give me a lot of homework every time I see you.
I appreciate your candor.
And here's what I want to share with you. Now, from the American Association of Nurse Practice, their website, a nurse can have their BSN in anything, geology, history, and then they can have 1 year training to become an RN. And they graduate from RN and then can go into an online course to become an APRN over 2 years. And if you, I was involved directly in training APRNs as part of our entire effort. The reason was that we felt the APRNs that we were working with, they were ICU nurses for 10 years. They were like gold, if nothing else, because they could walk into a room and know what's happening with the patient, because for 10 years, if you're a nurse in the ICU, you have seen more or less everything. And when they were APRNs that were working and had advanced practice experience, they were superior. And we just loved them. We had 3 nurses that we had trained. They were part of our group and we loved. But then it started to become shorter and shorter and shorter. And then it said, you don't even need to have clinical experience to become an APRN. So this dilution of education is somewhat harmful to the institution, if you will. And what was the strength of nurses was the clinical bedside experience. And that's not happening anymore to the level as it was. Again, you may or may not agree with me, but that's what even your website says that.
May I respond to that?
Please, please.
I'm not familiar with any at 12 months. Some of them are longer as those second degree programs. Being involved in some of those, I think it's really important to consider, though, that even to get into that, you need to always have a very significant amount of scientific prerequisites for science courses. You might have a bachelor's degree in English, but then you also have to had another 20 to 24 credits in sciences, anatomy and physiology and pathophysiology, even though your bachelor's degree is in English, showing those. And I've seen that pretty universally with those second degree programs, and it's program specific, but it's not that you can just go get a very quick degree in nursing after having a non-science based or non-healthcare based bachelor's degree. In addition, within all of those second degree programs that might be quicker, there is a clinical component, so that no matter what, that day one of an RN entering into a graduate program to become an APRN, they do have clinical experience. Although there might be a different level of clinical experience for that person that's been an ICU nurse for 10 years. I loved your comment that you referenced before on the Institute of Medicine. That was nicely put. And it seems relevant that the IOM did also put out a very, very significant report way back in 2011, but it did focus on making sure that APRNs were having that seamless transition, and nurses. So actually doing away with the need to have those practice requirements because it wasn't evidence-based. And the evidence base in terms of supporting that practice and practicing to the full extent of their scope and training was there.
So again, I'm going with what your website says. And your website does not talk about the BSN requirements to have science in it. It says that whatever the BSN is, you can have an expedited 12-month RN, and then you can actually get 2 years of, and then 60+% of all the programs are online. And so theoretically, I'm not saying that's happening, but theoretically, you can become an APRN without seeing a single patient or touching a single patient with how things have been diluted over time. And then if you look at that scenario and that specific APRN who is being trained, he or she, when they are going to have another APRN who has had similar experience to be training in a clinical scenario, as a Connecticut resident, I don't want that for my family. Then how can we make a policy that we want it for every other family? why don't the APRNs work on a residency program so there is a formalized training, clinical training and experience that happens? And that's something that happened in the 1890s in the medical field. And for the residency programs, not a single minute of the medical residencies have changed or reduced. It has increased, but it has not reduced. And it's like there was this whole mindset that to pursue excellence. Now the whole thing is that we are going to not pursue excellence. We're going to generate people faster than we can ever imagine. The institutions are making a lot of money because it's a good business, because humans are a good business to train and so on. But we are losing out on the rigorousness of training. And I know the studies, I've seen the studies, I can tear them apart because they're not specifically asking those questions that the APRNs are saying from the studies. And that was the homework of 2,000 or so pages that you gave me. But that because you gave me 3-4 pages of multiple different articles, and I started to look at those articles and I said, no, they're not true. They are not even asking the question that you're making an assumption on. So, but that's a different conversation. But if there was a way, and as a leader within APRNs, I would love for the APRNs to use their skills, make sure that every nurse goes through nursing work at the bedside. We'll solve the nurses' issues at the bedside too. And then after 3-4 years of bedside nursing, go into APRN, not just go randomly without any training.
I very much appreciate that you highlight that clinical excellence is absolutely necessary. And I very much agree with you. Clinical excellence is paramount, and that high quality care. In terms of what you referenced about the clinical training, I understand there's kind of two components there. We have the concern with online education, and then there was a mention of not laying hands on patients. The not laying hands on patients, that might not be something that you see in terms of what you're in for advertisements on A&P if they're trying to give you a highlight, but every single program includes clinical hours and putting hands on patients in clinical practice, both for RN and then additionally for APRNs. The didactic components that might be online, I am from a different generation as well. And when I thought about school, I was like, I don't want to do online. There's no way I can do that. I wanted to be in class and in person. And I know that the world has changed a little bit. And from my own generation, me not wanting to do online, I recognize now that's very different. And unfortunately, I'm kind of outvoted when we look at the evidence of education. A number of medical schools have changed to do more online education as well as residencies as well. I was speaking with the CMO of one of the community health centers in Danbury, and they, in their residency, especially in COVID, they did much more online. And fortunately, the evidence supported that there was continued positive outcomes from that, which I granted I had a bias about that was somehow second tier, but I was proven wrong with that, of the quality of education with that. So I think that there might be some just as technology is changing, that is part of how we're changing the educational system, but the clinical components are definitely still there.
So we'll continue this conversation. I appreciate you waiting all night for the conversation, but look, I respect you. I care about the APRNs. That I'm willing to work and work what needs to be done. But I want to have the quality. I want that rigorousness that is part of it. And the litmus test is that would it be good for my family? The APRNs that I've all worked with, any day I would have them see my family. The new ones that are coming in, when I talk to the people who are physicians as well, they said they're scared to have them work. And this is the official, so we are scared because they have not had even the didactic information to the level that they should. And it's almost like you're trying to work with a group of individuals who have not been to the level that they should be. And that's part of the hurdle. But what we need to do is, because the future has to have APRNs in it, the future have to have PAs in it, the future have to have doctors in it, and they have to work together. And we have to address some of these challenges for the workforce. And we will have to have, after this session, literally put APRNs in a room, physicians in a room, and figure out a strategy of what are the areas of opportunity to improve it. I know you are focused on excellence within APRNs too. I know that. Right?
Yes, absolutely.
And so the goals are similar, and let's figure out how we can do it, because right now it's not necessarily happening.
Well, I appreciate your considerations and time in that. I look forward to talking again after the session, and I hope you still add the substitute language to 1228. So thank you.
Okay, thank you so much. Oh, wait, don't go yet. Representative McCarthy.
Thank you very much. I just wanted to thank you also for being here. And I know that I missed a portion of your testimony because I had to step out, but I too look forward to talking with you and working together. I appreciate Senator Anwar saying that the future must and we need our APRNs. I saw one this week, and our PAs and our doctors. So I look forward to ongoing conversations after tonight's meeting. Thanks, Senator.
Thank you.
Thank you. The next person on our list is Mallory Payne. No, Danielle Brochot.
Yes, sir, I'm here.
Welcome. Good morning.
Hello, I apologize. I was there for a few hours earlier today, but didn't realize I should have packed my cooler. Senator Anwar, Representative McCarthy Vahey, and honorable members of the Public Health Committee. My name is Danielle Brochu. I've been a registered nurse in the state of Connecticut for nearly 7 years. And in a few short weeks, I'll be graduating with my doctorate of nursing practice from Sacred Heart University. I'm here today in support of Bill number 1067 concerning healthcare staffing. Chronic inadequate staffing for nurses and nursing assistants has led to increased staff turnover, decreased patient satisfaction, and higher instances of preventable negative outcomes, such as infections, falls, pressure ulcers, and 30-day readmissions. In my years at the bedside, I have noticed that patients are coming in much sicker with multiple comorbidities, especially in the wake of the COVID-19 pandemic. These steadily increasing workloads with high patient acuity, along with lack of resources and inadequate staffing, have left staff unable to properly attend to all patient needs in a timely manner. Recent data shows that adding just one patient to a nurse's workload results in a 7% increased risk of 30-day in-hospital mortality. The proposed legal mandate of staffing ratios would enable nurses to provide complete and holistic care to each patient, which in the long term would reduce healthcare expenditures. The state of California has already implemented such a law, and their nurses, hospitals, and patients have all reaped the benefits of safe staffing. If passed, this bill would hold hospitals accountable for ensuring that patients will be properly cared for by nurses who have reasonable, safe assignments and have the necessary resources to care for them. Statistics show that of the 86,483 nurses in our state, slightly more than half are currently employed in the profession. This shows that there's not a nursing shortage, but a decreasing number of people willing to work under conditions that set nurses up for failure and result in moral distress, mental health concerns such as anxiety and depression, and overall burnout. It's a heartbreaking truth that even new graduate nurses are leaving the bedside or the profession altogether within the first few years of their career, mostly because of burnout and inadequate staffing. As a nurse educator and current bedside nurse, I implore you to support this bill that will make the provision of acute nursing care safer for patients across the state. Thank you, and I welcome any questions you may have.
Thank you so much. Just wanted to check, are you a night nurse as well? You look too awake for.
I was a night nurse for 5 years, yes.
All right, good. I think in future I'll be a night nurse because I can do better meeting coordination. Thank you so much. I see no questions or comments. We appreciate your testimony.
Thank you, sir.
Thank you. The next person on our list is Greg Gonzalez. He's not there. Caitlin Cuas is here. No.
Hello.
Oh, you are. Hey, Caitlin, welcome.
Hello. Good evening, or I guess I should say good morning. Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claritas Deretria, and distinguished members of the Public Health Committee. My name is Caitlin Quas. I am an RN and a member of the Connecticut Nurses Association Government Relations Committee. Thank you for the opportunity to provide testimony on behalf of the Connecticut Nurses Association, with recommendations for you to consider adding to SB 1067, an act concerning adequate and safe healthcare staffing. So throughout the day, yesterday, and now, you've heard from my colleagues, nurses at the bedside and nurses in leadership. The work of a nurse is stressful on a good day. Lives of patients are in our hands. Not only are we caring for their immediate needs, but supporting their overall physical and mental health, their families, and continually assessing to identify any emerging issues to quickly intervene. It is clear that when staffing is stressed, patient care is stressed. Solving the staffing issues is complex, and we need to do something now, immediately, to begin to change the workplace environment, address workplace violence and staffing. We appreciate the steps the legislature has taken to increase the nursing workforce by investing in educational pathways, scholarship, debt relief, and nursing faculty. We hope this produces more nurses. But the data has shown us that it is new nurses, less than 10 years of experience, and under the age of 44 leaving the profession. How are we going to retain them? The solutions are not simple. Hospital sizes vary, skill mixes vary, and patient populations vary. The testimony submitted on behalf of the association identifies several strategies taken from staffing webinars and dialogue forums that we held last year, as well as strategies other states are using to strengthen existing staffing committees. We focus on strengthening the staffing committee because we have heard from nurses they did not even know one existed, did not know where they met, or what they did, or how to share information with them. So the staffing committee that is expected to lead the work of staffing really needs to do that work universally across all hospitals in the state. Some strategies we are sharing to strengthen the staffing committee is increasing bedside nurse membership from 50% of bedside nurses to 55% to ensure bedside nurses are present when the work is being done. Next, we would like to require a bedside nurse to be the co-chair of the committee, a true part of leadership of the committee. We would like the committee to be a dedicated staffing committee bearing that name so that all nurses know that that is a staffing committee. Lastly, the staffing committee shall regularly review and problem solve staffing issues, address concerns from units and nurses about staffing, creating more frequent reporting to DPH for oversight. My other Connecticut Nurse Association colleagues have also shared strategies to provide whistleblower and retaliation protection, and it is shared in our written testimony. It calls for protecting a nurse from being penalized for raising concerns regarding staffing or workplace environmental concerns, creating a system of accountability and collection of Connecticut nurse staffing data to drive future decision-making and improve transparency of the staffing committee and staffing plan. Thank you so much.
Excuse me, Ms. Chaz, your time is expired. Thank you.
Perfect timing. Caitlin.
Yep.
you did
I was
very
able to
well.
finish, so thank you so much for the opportunity to speak, and I'm happy to answer any questions.
Thank you. Seeing no questions or comments, we wanted to thank you for your time and your patience with us today. Thank you. I hope you get some rest. And
Thank
think
you.
about people who won't get any. And next is 176, Rebecca Allen. Welcome. Thank you. Thank you for your patience with us.
Thank you so much. Good morning. I hope I can do this justice. Good morning, Senator Anwar, Representative McCarthy Vahey, and other distinguished members of the Public Health Committee. My name is Rebecca Allen, and I am a resident of Columbia, the Director of Recovery Advocacy for the Connecticut Community for Addiction Recovery, or CCAR, and have a master's degree in public health from the University of Connecticut. Thank you for the opportunity to provide testimony on Senate Bill 9, specifically sections 4 through 5, which relates to establishing overdose prevention centers, which I support. I've already submitted written testimony on behalf of CCAR, so I want to use my time to share with you about my experience. First and foremost, I am a woman in recovery, and what that means to me is that it's been over 25 years since the last time I used heroin. As a former IV drug user, a survivor of an overdose, and as a sister to a brother that unfortunately lost his life to an overdose when he was 29, I know firsthand the stigma, shame, and outright discrimination that people who have a substance use disorder face. During my active addiction, harm reduction services were an emerging resource for people who use drugs. But those services were critical in my ability to remain healthy until I was able to both initiate and maintain my recovery. As important as those harm reduction services were, it was the staff who delivered those services that I most remember. Being treated kindly with respect and care was so important to me during that time. I was so isolated and estranged from my loved ones. That is the secret sauce that, in my opinion, is missing and something that overdose prevention centers offer. The evidence that these centers save lives, improve health outcomes for participants, and reduce harm to the communities is clear. This is public health. We've spent the last 25 years trying to change hearts and minds. It's time to act. I'm asking this committee to vote to advance Senate Bill number 9. Thank you for your time, and I'm happy to answer any questions.
Thank you so much for your testimony, and thank you for sharing your pain with us, and then your courage to share your personal story. It really is important. And I think you did say the magic word today about the magic sauce, which is unconditional love. I can tell you, when I visited the site that's managed by Mike Jenkins and his team, I saw acceptance and love for everybody who was walking through that area. And there was no judgment. Anybody who came, they needed a fentanyl strip, they would give it to them. And then they need Narcan, they would give it to them. No questions asked, just greeting them with love. And at one point as well, I did go there, and when I was coming back, I was talking to people. I found it to be a spiritual place, because spirituality is about unconditional love and acceptance of everyone, and especially the ones who in general are not accepted. Is the most important thing we can do is to accept people. So thank you for putting that in perspective. And I hope as a state, we can do that, even as accepting and getting rid of the stigma, so people would be able to be who they are and then be accepted who they are. And then within that acceptance, they'll find solutions collectively.
Thank you. And I want to acknowledge that I stand on the shoulders of 23 million other Americans that are living in long-term recovery. So it's possible, but we need to be brave and we need to do something different. And this is a step in the right direction.
Amen. And I saw you this morning around 9 a.m. So you've been here the whole day and whole night. So thank you for that. Thank you.
Thank you.
Any questions? Mike?
I know my colleagues may want to have my head, but your voice as a person in recovery, we've heard about others who have battled and have lost their battle, and your reminder, 23 million Americans, that means that today, of all of us sitting here in this room, that there are a whole bunch of us who are most likely people in recovery as well. And your willingness to talk about it openly and share that with us is exactly what helps us to get rid of the stigma and to embrace the conversation with so many so that we can actually make progress. So thank you. Thanks, Mr. Chair.
Thank you.
Thank you. Thank you so much.
Of course. Seeing no other questions or comments, we'll move on to the next person on our list. I have Stephen Courtney. Is SCAD Center here? You're the SCAD Center? 177? Courtney, yeah, please go ahead. Sorry about that. And people who are attendees, please accept the promotion so you can actually be able to speak. So you will get an invite to become a panelist. Welcome, Courtney Dollar. Welcome, number 177.
There we go. Okay. Hi, good morning. Senators, representatives, members of this committee, thank you for this opportunity to speak in support of Senate Bill 9, sections 4 and 5, specifically related to harm reduction centers and overdose prevention centers, or OPCs. My name is Courtney Dollar. I do not like public speaking, but I am here because this is very important. I am the program director at Connecticut Harm Reduction Alliance, and I live in Bristol, Connecticut. Overdose prevention centers save lives and benefit communities. How do I know this? I'm from Canada. I worked at an OPC back in Ottawa, Ontario, before I moved here to Connecticut in 2018. I very quickly realized after moving here that harm reduction looks very, very different in the US. Overdose prevention centers have existed in Canada for decades. They provide compassion, dignity, and care to our communities. They offer a range of harm reduction services, including drug checking, access to treatment services, and linkages to important health and social services. More importantly, they're a source of safety and of connection and belonging within the community. Bad laws kill people. People are dying in their homes, in public bathrooms, in homeless shelters, and in the streets. Do you know where they're not dying? In overdose prevention centers. We are in a public health crisis. What we are doing here, despite our best efforts, is not working, and we're tired. We are tired of our friends, of our coworkers, of our participants, and our communities dying. And I'm going to get really emotional here. Our drug supply is toxic. It's not about overdoses. It's about the fact that our drug supply is poison. We have the opportunity to try something new to us, something that has existed for years in other communities, something that research shows improves health outcomes, lowers death rates, and reduces infections. This is especially important as xylazine in our drug supply is causing horrific wounds. And for this to succeed, it's not just about supporting OPCs. It's about ensuring that we are properly devoting funding and resources to support the wraparound services that OPCs provide. It also means looking to other models of harm reduction that are working in other communities, including safe supply programs, managed alcohol and managed opioid programs, and low barrier shelter options for people who use substances. Too many of our participants here are being discharged from emergency shelter programs because of their substance use. These are supposed to be safe places for people to stay, especially in the winter. One thing I want to emphasize is that people who use drugs have been our first responders throughout this epidemic. They were responding to overdoses and caring for their communities when professional services went remote only during COVID. They are our experts. They need to be involved in all aspects of this conversation and the actions to create OPCs in Connecticut. I appreciate folks in recovery coming to speak here, but what we're missing from this table are people who are actively using. You do not need to be a certified health professional to respond to an overdose. The reason why Connecticut Harm Reduction Alliance's model is so effective is because we involve the communities that we serve, our peers, people who use drugs, and people in recovery.
Excuse me, Ms. Dollar, but your time has expired. Thank you.
Do you want to finish your sentence?
If I could, that would be great.
Please.
I would love to speak to the questions previously asked about the number of people connected to detox or treatment from these centers. I would also, ending this, I would urge to support Senate Bill 9, sections 4 and 5. I also want to voice support for SB 9, sections 6 and 9, and HB 6913, section 2. And lastly, I want to thank all the nurses who have spoken today. We see you, we love our healthcare nurses. And I want to say that healthcare should not be a for-profit industry. That's where your answers are going to come from. Thank you for your time. I'm happy to answer any questions.
Thank you so much. There's a lot of powerful things that you've said today. And I'm so glad you waited for us because I know I saw you early morning as well, so you've had your entire day with us. We appreciate you.
I did skip out a couple times because I have a dog at home, but yeah.
But thank you for that because it was very meaningful for all of us. Thank you. I see no questions or comments. We'll move to the next person on our list. Joel Chazen. Oh, he was not accepting the promotion, so we'll go on to the next person, Stephen Courtney. Mr. Courtney, you're on. Welcome.
Welcome. Good morning, distinguished members of the Public Health Committee. My name is Steve Courtney. I'm the Managing Director of Danbury Proton. And I have to say, I admire you for your tenacity tonight. I had in fact planned to be with you in person myself, but when I saw my lottery number of 186, my plans changed. Also, given the late hour, I would point you to our detailed written testimony. And tonight, this morning, I will just summarize in short 30 seconds, our support for HB 6894. Number one, there's lots of room for improvement in the CON process, as has been explored quite well in 2017 and again this past year. In short, our testimony focused on three key concepts: transparency, competition, and patient-centeredness. Transparency in not only providers, but OHS as well. Competition, not as a panacea, but fully considered in every decision that needed to be made. But most importantly is patient-centeredness, making patients the center of decisions and not hospitals, doctors, pharmacists, insurance companies, or even clinics like ours. We need to find every way we can to place patients, people, at the center of medicine. Thank you, and I'm available for any questions that you might have.
Thank you so much for your testimony. Seeing no questions or comments, we appreciate you being here with us today. Thank you.
Have a good morning.
You too. Next is Kimberly Sandor.
Good morning, Senator Anwar, Representative McCarthy Vahey, Senator Summers, Representative Claire Dietrich, and distinguished members of the Public Health Committee. I was with you there earlier, but I did head home. My name is Kimberly Claire Sandor. I am a nurse, and I'm the Executive Director of the Connecticut Nurses Association, and I'll be speaking about Senate Bill 1067, an act concerning adequate and safe healthcare staffing. Thank you so much for hearing everyone's comments today. Nurse staffing is such an important issue, and your care in listening and really hearing the nurses and giving them a constructive place to advocate on their own behalf has been really great to see. And I believe together we can provide a path forward to make a change in the hospital workplace environment for the better of nurses and patients. Our written testimony online provides many strategies and thoughts to improving the current staffing regulations, and my colleague Katie just went through them all. We ended up being much closer in numbers than we thought, but really what we are prioritizing is being able to put something in action right now. You heard the desperation, you heard the stories that are going on in people's experiences at the moment, and we need to do something right now. And we took a very thoughtful approach, taking our input from our nurses and looking at other states to put forward basically 4 areas that we think we can improve upon the existing regulations for staffing, begin to create our own data in the state about the ratios that Connecticut hospitals are using and what are some of those challenges, and be able to use real Connecticut data to inform some decision making. So to give you a little time back, I'll stop there. It's all in writing, and I think my colleagues have really covered the bases on how we think we can really make some change right away. Happy to take any questions, but most importantly, the Connecticut Nurses Association really hopes we can be part of moving this bill forward. Thank you.
Thank you so much for your testimony. Thank you, Kim, to be here with us tonight. I don't see any questions or comments. Are you a night nurse too?
No, and I'm a recently new empty nester, so going to bed is something I really look forward to. But you're all in it. I'm all in it. We're doing it all for our people and the public that we love and we serve, and we want the best outcomes for everybody. So we do it. We're here, and I'm here with all of you, lifting you up. And I do hope you all get home safely too.
Thank you so much. And the next person on our list is Yana Giampati. Ms. Giampati, you're there?
Yes, hi.
Hey, welcome.
Thank you. Greetings, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Yana. I'm a first-year student at Yale, and I am speaking in support of Senate Bill 9 for a couple aspects of it, the reproductive healthcare aspect of it, and also the harm reduction aspect of it. So firstly, reproductive healthcare has been protected for decades in the state of Connecticut. However, equitable access to healthcare and reassurance of safety when accessing this healthcare is not yet guaranteed. SB 9 does a few crucial things for the reinforcement of reproductive rights in Connecticut. For one, it prohibits an individual from limiting another individual's access to assisted reproductive technology, such as IVF, prohibits infringement upon the rights of healthcare providers administering this service, and protects a patient's right to determine the use of all their reproductive genetic materials. And importantly, it also codifies legal repercussions for those attempting to obstruct an individual's access to reproductive healthcare. As a young individual, as a birthing person, it is important to me that my right to receive critical care without fear for my safety is protected, and that those who seek and administer reproductive care in any form are able to do so safely. Moving on, another key element of this bill that I would like to advocate for is the establishment of harm reduction centers in the state of Connecticut and creation of a bulk purchase fund to make opioid antagonists more affordable and available to residents, as outlined in sections 5 through 9 of the bill. During the school year, I live in New Haven, Connecticut, which according to the Connecticut State Department of Public Health was the county with the highest number of unintentional drug overdose deaths in Connecticut, accounting for 32.6% of the state's deaths by unintentional drug overdose. And I'll just save you from all the statistics. You've heard a lot of great ones today. And I'll just say that as an inhabitant of a relatively well-resourced corner of New Haven, I recognize my privilege that I experience in my proximity to healthcare and preventative measures. And to me and many of my peers, it is urgent that Greater New Haven and Connecticut receive similar attention and care in the form of safe places where residents who do use have access to testing strips and clean needles and access to Narcan and healthcare providers. And also personally as a student, I know I speak not only for myself when I say that having access to these resources would help us all feel better equipped to prevent a dangerous and very avoidable situation from happening. In addition to the introduction of harm reduction centers, one part of the bill also requires physicians to prescribe opioid antagonists such as naloxone when prescribing opioids to patients with a risk of developing or history of substance use disorder, and establishes a program which EMS providers can distribute opioid antagonists in need. And that's, in my opinion, really crucial. Overall, these motions represent a robust step towards tackling the growing opioid crisis in Connecticut. These lifelines can often mean the difference between life and death. This bill helps Connecticut do right by its citizen and provide that lifeline. For this and all aforementioned reasons, I urge you to vote in favor of this bill. Thank you.
Thank you so much for your testimony. You were within the 3 minutes, and that's pretty cool to do that at 1:37 a.m. So I appreciate your testimony, and we value what you have to say. We do not have any questions or comments. We thank you for your testimony. We'll move on to the next person on our list, Diane Lauricella. Welcome.
Oh, good morning. And I was just going to get a cup of espresso, but I thought better of it. Anyway, good evening. My name is Diane Lauricella. I reside in Norwalk. I appreciate being able to speak virtually, co-chairs Senator Anwar and Representative McCarthy-Vahey, and esteemed vice chairs, ranking members, and members that are still awake. This morning, I am speaking about lifting up and supporting SB 9, an act concerning health and wellness for Connecticut residents. Because of the title of that bill and the intent of that bill, I support it with some amendments and crucial additions at the end of the bill. I am a on the governor's GC3 Equity and Environmental Justice Working Group, both the first iteration under Governor Malloy and the current iteration under Governor Lamont. I'm a former investigator, senior investigator with DEEP, and my old pal, Representative DiCaprio, is no longer on, but I worked alongside of him in a same department, different division. I wanted to let you know that part of my work, even now in private practice as an environmental consultant, is identifying historic pollution sources and working with local officials to identify vulnerable populations and environments. The reason I'm mentioning that is on line 418 of SB 9 in section 10. I definitely support Healthcare Career Advisory Council, but I ask that you absolutely include people that would recognize and be able to value the benefit of having an epidemiologist, a toxicologist, and/or a hydrogeologist on that advisory council. Also, any place where you are looking at helping nurses and other healthcare providers who would be in an especially urban setting, for anyone that could recognize some of the contamination that happens because of exposure to contaminants. I don't see that in the listing of who you include in this. Lines 433 through 443 also talk about that. And because many of our towns have a toxic legacy because of New England and Connecticut's industrial history, pollution, heat stress, and climate change and extreme weather should become part of a local nurse and health department's duties to help the Connecticut DEEP, my former employer, recognize with eyes and ears out on the streets. That's why it is needed. I ask that you consider adding section 25 as a new section to study and get ready for next session about a modicum of a new role for health directors to be true environmental health, not just wells and septic systems, but also being part of the toxic recognition and remediation, so that it's just so, in my experience in working with some local health directors, including my own, I found that they're not quite engaged in an important part of environmental health. And by statute, health directors are assumed to be part of it, but if they're not, many of them, not all of them, many of them are not thinking that this is part of their duty. They are
Excuse me, Ms. Lauricella, but your time has expired. Thank you.
May I just please finish my sentence? Would that be possible?
Please go ahead.
Thank you. Also consider adding a section 26. When I saw section 24, where you had thrown in the splash pad out of the, it's very important and about splash pad signage for recirculating water. I also, besides adding section 25, I ask that you add a section 26 to conduct an updated study of artificial turf. The last time the health department conducted such a study is 2015, and much of the science has changed. People are being suspected of gaining cancer. The girls playing soccer out in Washington University, NFL Super Bowl, folks wanting to use natural turf. And lastly, in Philadelphia, the Phillies baseball players, several of them have died. Due diligence is needed. And if you could please just throw in at section 26 in this omnibus bill, conducting an updated study of artificial turf, I would be most appreciative. I just did not have time in my life to advocate for it separately in a way I know would have been better to start this winter. I just didn't have the bandwidth with all that I'm juggling. So thank you for listening. Good luck. And I would like to be part of the discussion even after the session, but also after tonight on these two things I ask for you to consider. Thank you.
Thank you so much, Ms. Lauricella. Did you submit a written testimony? I want to make sure.
I did not have time to finish it, so I'd be happy to submit it.
Please do, because there's a lot of information that you have. We truly appreciate the insight, and we will look into how we can address the bill a little bit more in more depth. Thank you so much.
Thank you very much. Good night.
And we don't see any comments or questions, so we'll move to the next person on our list, which is Kara Sepulveda. Welcome. Good morning.
Thank you and good morning. As someone who grew up in New Haven, I was no
Kara,
path.
Kara, do you want to turn your camera off? You have bandwidth is a little low.
Sorry about that.
Go ahead.
Can
Start
you hear me
again.
now?
Yeah, we
Okay.
can hear you. Start again.
As someone who grew up in New Haven, I was no stranger to substance use or the influence it has on my community. A graduate of Wilbur-Cross High School, I witnessed firsthand how many of my peers stumbled down the path of using drugs. A learned behavior for some, a coping mechanism for others, and for many, a method of survival. Despite its prevalence, substance use was not something we learned or talked about, even as the problem grew within the walls of the school itself and the community in which we lived. Undoubtedly, the overdose crisis knows no boundaries, impacting all ages, ethnicities, and communities. We've witnessed the crisis expand in the last 10 years alone, as illicitly manufactured fentanyl contaminates the street drug supply, reaching new populations and further complicating our response to prevention and treatment. We hear reports of overdoses regularly on the news and stories from family members of a life lost too soon, yet stigma continues to hinder our approach to education and seeking care. Working in public health for the last 5 years, I have seen firsthand just how challenging it can be to introduce unfamiliar concepts like harm reduction and get people to care about issues that may not impact them directly. However, throughout my time and through these conversations, I found that most people have their own connection to the overdose crisis, but shame, fear, and an overall misunderstanding of addiction has prevented them from sharing their story. I've learned to tailor my messaging to resonate with different populations and ensure they understand not only the principles of harm reduction, but also their role in preventing others from experiencing overdose too. In November, I had the opportunity to visit the first sanctioned overdose prevention center in the US and actually witness an overdose response in action. Not only was this person met with empathy and compassion, but it was empowering to know that had that site not been accessible, that individual would have been another statistic of a life lost to a preventable outcome. In public health, we're always working to identify ways to offer services in an inclusive environment to offer a one-stop shop to underserved populations. Overdose prevention sites are just that, as these incredible teams break barriers, foster community, and connect people who have been so misunderstood and isolated to an environment in which they are heard, valued, and accepted. Overdose prevention centers are not a new concept. This is not a pilot project in which we are determining whether their functioning is effective. We know these sites are capable of preventing fatal outcomes, improving access to other core health services, and expanding education to ensure people have the knowledge and resources to stay safe and healthy while using drugs obtained from such an unpredictable drug supply. The reality is that people are going to use drugs regardless. And for this reason, it's critical we learn from other strategies already implemented around the world that have been proven to be successful and evidence-based. Ultimately, everyone knows someone who uses substances. I encourage each and every one of you to get trained to respond to an overdose, to carry naloxone, and to continue sharing the lessons learned here today. Anyone can overdose and anyone can save a life. We all have a role in addressing this overdose crisis. Adopting Senate Bill 9 and implementing overdose prevention centers in Connecticut is just one step in the right direction. Thank you all for your time.
Thank you so much for your testimony. And I see no questions or comments. We'll move on to the next person on our list, which is Mehul Dalal. Mr. Dalal, welcome.
Hi, thank you. Senator Anwar, Chairwoman McCarthy Vahey, Ranking Members Summers, Claire and Claire DeStitra, and distinguished members of the Public Health Committee. My name is Mehul Dalal. I train as a physician. I currently serve as the Community Services Administrator, overseeing the Health and Human Services departments for the City of New Haven. I also serve as a municipal representative on the Opioid Settlement Advisory Committee. I am testifying in strong support of SB 9, the harm reduction provisions. Before I jump into the stats, which we've heard a lot of, I just need to acknowledge the courage of the individuals who have come forth, who've had family members succumb to addiction, and those who are in recovery and sharing their stories. I think those pieces are more powerful than any statistics that we can share. I think the rock stars and the academics who have shared their expertise lay evident that there's unequivocal benefit to these harm reduction centers. I'm a municipal official in New Haven, so I want to share a couple statistics there. I know the Connecticut trend, thankfully in overdose deaths may be trending down, but that is not the case in the city of New Haven. We've been hit hard with the opioid overdose epidemic, and the proportions of the tragedy are really difficult to even understate. In 2015, we had 26 deaths in New Haven due to overdose. By 2021 and 2022, there were 118 and 130 deaths respectively. But to put it in perspective, that's 50% greater than the deaths we had from COVID-19 in those years. We're seeing a larger share of our illicit drug supply contain fentanyl, fentanyl analogs, xylazine. Stimulants such as crack and cocaine are often adulterated with fentanyl, and the users may not be aware that they're ingesting opioids. Every week, 2 or 3 residents in our city lose their life to a suspected overdose. We have a front row seat to this unfolding public health crisis, and we are called to do more, and we are called to do so urgently. The previous speakers have said a lot about the statistics and the evidence, so I'm going to jump into just a couple of areas that are in my testimony, and that's also referenced in the written testimony if you care to refer to it. One thing that hasn't been emphasized as much is the economics of it. There was a rigorous economic evaluation conducted by a group in Boston called ICER, which provides economic analysis of usually pharmaceuticals. Their analysis in one of their models show that a harm reduction center, for every dollar spent on a harm reduction center, $8 could be saved due through reduction of ambulance rides, emergency departments, and hospitalizations. Diverse organizations, including the American Medical Association, the American Civil Liberties Union, and the Cato Institute, have written in support of harm reduction centers. As I stated, we fully support SB 9's proposal to establish a harm reduction center pilot program in Connecticut, and we strongly support the language authorizing the Department of Mental Health and Addiction Services to request disbursement of the opioid settlement fund dollars to support the establishment of this pilot. I'd like to add a couple of friendly suggestions to the committee for their consideration. Number one, the Rhode Island bill included provisions of liability protections. Although not essential, I feel that addition of liability protection provisions in the bill may help facilitate some organizations and some stakeholders to elect to implement such centers should the bill pass.
Excuse me, Dr. Dalal, but your
Sure.
time has expired.
Thank you, appreciate it.
Thank you so much. Can you finish the thought? Because you were at a pretty interesting part of your testimony.
Sure thing. The second thing I asked the committee to consider is that as we've seen in the New York model and other models throughout the world, it has been demonstrated that non-clinical personnel can be trained to safely provide monitoring and supervision in community-based settings. And the requirement in Section 4 that harm reduction centers are medical facilities and should employ licensed healthcare providers may pose an unneeded barrier to establishing harm reduction center pilot sites. So I would suggest the determination of professional licensure and facility requirements could be best handled during the agency rulemaking process, which under the bill would fall under DEMIS. So I offer that for the committee's consideration as well. Thank you.
Thank you so much for your testimony. Thank you for staying with us. You were here this morning, early morning, and you've been pretty much here. Is the city of New Haven going to pay you overtime for all this work that you did with us today?
That's a good question. I'll ask my boss in a couple hours.
Well, he texted and showed his support this morning when we were talking about this aspect, because I think New Haven is in some respects one of the most impacted parts of our state at this point, as you illustrated in your testimony. And I think the recommendations that you have suggested are very valuable. This bill is something that we should probably talk about, and I know that the city of New Haven has recognized that the status quo is not acceptable, and then there needs to be a better way of assessing this, and then more conversations need to happen how to be able to implement this in some respects. But we will be talking a little bit more in depth and looking at that aspect with you in future. Seeing no other questions or comments, we will move on to the next person on our list, which is Lori McDougall. Ms. McDougall, welcome. Thank you for being here with us.
Thank you. Thank you for having me. Thank you for everybody staying as long as you have, and good morning. So I'm here to testify in support of harm reduction centers, and I'm going to just dive right in. I want everybody to consider that consumption sites already exist. They exist in our back alleys, dumpsters, public parks, public and local establishment bathrooms, your local bars and restaurants. Every time you step into a bar or a restaurant, you're stepping into a consumption site. This list is extensive, but what is important here to note is that none of these places are even remotely well-equipped to handle an overdose and/or offer any kind of resources to the person that's struggling with addiction. There's one more site I want everybody to consider and to think about that we haven't talked about a lot, and that would be our homes. Our homes are also turning into consumption sites. Sharing with everybody, recently, while visiting us during a time when it was incredibly difficult for my son to access his life-saving medicine of Suboxone, he used and overdosed in the bathroom of our house. My home became a semi-harm reduction site. I say semi because I'm educated and equipped with Narcan, and my husband can administer CPR, and we were able to help our loved one during an overdose. We saved my son's life by administering Narcan and CPR. We were also severely traumatized. My husband, me, and my son. This experience taught us how difficult it is to administer CPR and Narcan and do all of the tasks necessary in order to revive him. When Mark Jenkins spoke earlier today, when he talked about dealing with the complications that come with the drug supply, I don't think people realize how difficult it is dealing with the body when somebody is experiencing an overdose and there's dead weight. It's really difficult to put your loved one on their side to help prevent aspiration. It was a monumental struggle. Now, I want you to imagine the benefits to the community, families, and individuals if a true harm reduction site with highly trained staff were opened. It will get people connected to a multitude of resources that will support people in their attempts at recovery. We know that people that attend harm reduction sites are 5 times more likely to engage with treatment. It will reduce the amount of trauma for the loved one trying to manage their illness, for the families, and reduce intergenerational trauma, keeping families healthier and better able to manage.
Excuse me, Ms. McDougall, but your time has expired. Thank you.
Thank you, Ms. Dougal. Do you have a sentence you were about to complete?
Yeah, there's one added thing I'd like to say, just in conclusion. I want everybody to know that there is one thing with my whole existence that I want is that my son stop using substances. But there's only one other thing that I want more than that, and that is to keep him alive so that he can have a future. And also, I refuse to let my son become a part of that 91% and die alone.
Thank you, Ms. McDougall, and thank you for staying with us throughout the day and in this night as well, and this morning. And we hear you, and that is part of our hope that we do whatever we can as partners with the family members to save as many lives as we can. Thank you so much for your testimony. It means a lot to each and every one of us. Thank you.
Thank you.
The next person on our list is physically here, Paul Bannock. Welcome. Thank you for your patience with us, and thank you for staying with us during the day, afternoon, evening, night, and morning. Your mic is not on.
I appreciate you all.
My name is Paul Bannock. I obtained my nursing degree from UConn and my master's in public health from Johns Hopkins. I spent the past 4 years working as a travel nurse at hospitals across the country, including hospitals that provided safe staffing ratios, including Kitsap County, Washington. When a child dies in a pediatric ICU, the parents have to, at some point, hand their lifeless child into my arms and walk away. The only thing that hurts worse than witnessing the death of a child is knowing you might have been able to prevent that child's death if you had safe ratios. Oh well, at least there was money in the budget for my CEO to get $1 million bonus that year on top of his base compensation of $2.5 million. And for me, I was offered a 1% annual raise, which prompted my resignation 2 weeks later. Hospital executives are saying a lot about improving the pipeline, but they aren't saying much about nurses like me, currently applying to jobs outside of the field of nursing, because I feel exploited at the expense of human lives for their profit. The troubling thing for us is that if your mom is in the ICU and she slowly suffocates to death because her breathing tube becomes occluded and there isn't a nurse available to respond to her ventilator alarm, her death is not reported as a staffing issue. Her death is reported as a respiratory arrest, and you are never notified of the circumstances under which she died. Nurses know that the death is directly related to neglect due to poor staffing, and that's what we're trying to tell you in our testimony. The number one job of a nurse is to keep you safe. So today you can believe the testimony of 97% of the bedside nurses in favor, or you can believe the testimony of James Yacobelis, Senior Vice President of the CT Hospital Association, who stated in his written testimony, SB 1067 second guesses nurses' clinical judgment. I'm unsure how James, who's not a clinician, can make a public claim about my clinical judgment, especially when the majority of my colleagues are saying we do in fact need safe staffing ratios. It's really frustrating to hear hospitals say that there isn't money to retain nurses when there is room in the budget to pay James Yacobelis $428,000 to represent the perspectives of millionaire nonprofit hospital CEOs that are in direct opposition to my lived experience. Danbury nurses who are suffering watch their CEO, John Murphy, get a $14 million payout during a global pandemic. I don't trust hospital executives receiving more taxpayer money without setting clear expectations for how they should prioritize spending it. Billy Miller was 23 years old when he died in the Yale Emergency Department in 2021. He went unmonitored for 7 hours. Meanwhile, the previous CEO, Marna Borgstrom, made $4.2 million, while Yale has made no headway in reaching safe ratios in their ER. Billy might not have died at Middlesex Hospital because Middlesex Hospital largely adheres to safe staffing ratios already. Not all Connecticut hospitals are the same.
Excuse me, Mr. Bannock, but your time has expired. Thank you.
I have one more sentence.
Yes, please go ahead.
California executives also fought safe staffing ratios vehemently when they passed it 20 years ago. But despite their false warnings, no hospitals closed and patients are not refused in their ERs. And we have 20 years of data to show that patients do have better outcomes. Thank you.
Thank you so much for your testimony. Appreciate you staying with us throughout the night, and thank you for sharing your experience and bring the ICU nurse perspective in the picture as
Thank
well. I don't think we have any questions, but we'll talk a little bit more. I'll talk to you offline in a bit. Thank you so much for your testimony. Next person on our list is Darwin Fisher. Mr. Fisher, welcome. You're
Hello,
on.
greetings from Vancouver. Can you hear me?
Yes, we can.
Great to see you. Out of respect for your stamina, which is considerable, I will try and be brief and to the point. I've worked for 20 years at Insight, which is North America's first supervised drug consumption site. And the numbers around Insight are staggering. In the last year, we had 81,000 injections, 0 fatalities. Over 20 years, we've had close to probably 2 million injections without fatalities. We've had hundreds and hundreds and hundreds of detox and recovery referrals, 2,500 nursing treatments in the last year, to a group and a body of people that hate visiting a hospital, it's an incredibly effective intervention. But what's most important are all of the countless hours of compassionate, non-judgmental conversation and interaction that goes on at these sites. And I want to reaffirm what some of the earlier speakers said about compassion being the lifeblood of these sites, and the fact that it's important to have drug users woven into the fabric of these sites as employees. As a culture, we've tried tough love, and it's a bunch of crap. It ends up being all tough and not very much love. What this situation needs is real love and compassion and non-judgment. And when you create those circumstances, people tend to move towards wellness. You don't have to coerce them. So create those spaces. You have a chance right now. Make history, save lives. There are a countable number of people who were instrumental in the formation of Insight. You heard from one of them this evening. Liz Evans was one of the prime movers. But some of those people, some of those heroic people who made a difference also sat on council and sat on health board hierarchies. So now's your opportunity. Make history, save lives, do it. Thank you.
Thank you very much, Mr. Fisher. We appreciate your work and just reinforcing that message of the importance of the compassionate, non-judgmental role in safe injection sites. Seeing and hearing no other comments or questions, I believe next we have Noosh. Go ahead.
Noshar Panapour Islami. Welcome. You've been here with us all day, Noosh.
Well,
yeah.
Great chair. Okay. Dear co-chair Senator Anwar and Representative McCarthy Vahey and distinguished members of the Public Health Committee. My name is Nushar Panapour Islami. I'm a resident of New Haven and currently an MPH student at the Yale School of Public Health. I'm here today to testify in support of Senate Bill number 9, specifically its introduction of harm reduction centers in Connecticut. So currently I work in the Yale New Haven emergency room on a Suboxone clinical trial where my role is to see patients, typically after an overdose, to determine if they're eligible for enrollment in medication-assisted treatment in the form of Suboxone or buprenorphine, if you know it by that name. My most recent encounter was with a 66-year-old gentleman who had overdosed after taking oxycodone pills that he had gotten off the street. They were laced with fentanyl and he overdosed. He was in this position for 2 reasons. So the first is he developed a dependence on opioids following a knee replacement surgery and was in the beginning stages of pain management with oxycodone while at a rehab facility. He was not a drug user, he was not a junkie. In our conversation, what I gathered was he was a church-going, Carhartt wearing, just average Joe that just happened to have a bad knee. He overdosed because he was discharged from his nursing facility, pending further evidence that he still medically required oxycodone. Certain nursing facilities like this that do nursing and rehab, they have strict requirements over who has demonstrated need to have pills like oxycodone administered within the facility. He was 2 weeks out from the appointment that would provide this confirmation, and so he found himself homeless and discharged at the New Haven Green. He came to the ER with a sticky note of a list of the images and the tests that he needed in order to be able to return to his nursing facility. And then he told me of his plan, which was to return to that nursing facility, become more mobile, transfer to a different nursing facility that he had heard from friends helps you with finding an apartment, which he hoped to find an apartment to live independently, because currently he was unable to find apartments that he could afford because, as I'm sure you may be aware, we're in the midst of a housing crisis and affordable housing in Wallingford was apparently very difficult to find. This shows that our healthcare system can't afford to not have harm reduction centers. Our system, even when it's navigated the right way, still has pitfalls, and we need to stop neglecting those who fall in them. We all have communities that we're in. I have my school friends, my soccer friends. I even have community when it comes to coming here and doing a hearing at 2 a.m. So, but things that I partake in, I have community in, And a harm reduction center is community for people who've been exiled from every other aspect. The question I would like to leave you all with is, should substance use strip you of that right to community? And never mind the millions of people suffering through no fault of their own, does it really require stripping them away of a right to this level of humanity and dignity? And with that, I'm happy to take any questions, and thank you all for staying here so late.
Thank you so much, Noosh. Noosh, can you just repeat what you just said? Harm reduction is a community for people who are exiled from
every other community, basically.
Very powerful.
Yes, it is. And in speaking of community, my written testimony is online, and it includes a chart that has a breakdown of the number of deaths for each of your constituents. So you can look in your specific district to see how many people have died of a drug overdose in your exact districts, both in the last 2 years and also since 2015.
How much work did you have to do that?
It's just a little Excel sheet in a couple hours, but it was worth it. Well worth it.
That's impressive. We can look at that in more detail. Anybody has any questions? Yes, Representative McCarthy Vahey.
The creaky microphone. Noosh, what you said about community and what we've heard about connection, I think Mark earlier talked about the opposite of addiction is connection. I'm thinking about our conversation earlier tonight when we were talking about the connection that you and I have. We've just met today, and I talked about the fact that I took a ferry into the town where you grew up, and that's where I commuted. And that I know Senator Anwar underscored that already, but the ability to have a place to not just have dignity, but connection is literally survival for people. So I just want to thank you for that aspect of it. I can't wait to look. I'm not, and I think Rep. Zupkis said earlier something about the word amazing. It's not the right language, but I really appreciate the fact that you broke that data down by district. And as I mentioned here many times tonight, we like to pretend, and especially in places like Fairfield, Connecticut, we like to pretend that it's not happening, but we know it is. Thank you.
Thank you so much.
Thank you, Noosh. Seeing no other questions or comments, we appreciate your stamina and a great testimony. Appreciate you. The next person on our list is Leslie Wolfgang is not here. I don't see her. And Bruce Baxter, you're on. Welcome and thanks for your patience.
Good morning, Senator Anwar, Representative McCarthy Vahey, Senator Kushner, Representative Parker, ranking members and members of the Public Health Committee. My name is Bruce Baxter. I am the president of the Connecticut EMS Chiefs Association, as well as being the chief of service and CEO of New Britain Emergency Medical Services, the city's 911 primary EMS provider. Appreciate the opportunity to offer testimony on 3 bills. The testimony has been submitted online for you to read, seeing how I have now about 2.5 minutes. I want to highlight a couple things. Number one, my thanks for you working with Tony Circa in raising Senate Bill 1073. I think the intent of the bill is good. We will be submitting an addendum with some recommended language changes to address some of the concerns for you to consider that was expressed by a previous speaker this evening. There are cost impacts for this. There are labor impacts for the bill. And there are also supply chain issues that we need to be wary of. Senate Bill, hang on one second. Senate Bill 1229, an act regarding emergency medical services, addresses the data issues associated with EMS. We believe from the Chiefs Association perspective that the Office of Emergency Medical Services does have a robust data system Unfortunately, they have a talented epidemiologist, but the OEMS office is not adequately staffed to turn around and be able to properly manage a comprehensive EMS system that's involved in Connecticut. It's also under distress. We're going to submit some additional testimony that suggests that in addition to keeping your bill as is, that you assure that OEMS has the staff and has the funding necessary in order to support the data requests that we're all looking for. It's not a criticism of the quality of people that are at OEMS. I think it's a funding issue which is plaguing EMS in general across the state. And finally, with respect to House Bill 6605, the Connecticut EMS Chiefs Association opposes that bill. We believe that there's a process in place that is workable for communities to make changes to their assigned primary service area responders should they not meet the needs of the community, or should the community choose to enhance the system in a different way that better meets the culture and the needs of that community. If we pass that bill as written, it will be a gigantic step backwards to a environment that existed before the PSA structure was in place, where the primary 911 EMS provider in a number of municipalities would change on a bi-yearly basis, and it was directly related to the political influence that the elected officials had.
Excuse me, Mr. Baxter, but your time has expired. Thank you.
Thank you.
Bruce, do you want to finish your sentence?
Thank you, Senator. Yeah, back prior to the PSA legislation, which was late 70s, early 80s, there was a fairly consistent habit in a number of communities where the election cycle usually resulted in a change of 911 EMS providers in local communities. And it created an environment where the owners of those services or the nonprofit organizations that were involved were very hesitant to make the necessary investments required to produce a quality level of service for the community. Hence, the regulatory environment came in, took hold. It was improved in 2013, and I think the opportunity is there. I think some communities are a little stymied because they don't understand the intricacies of it. I know 3 communities that have made changes successfully, and I would rather tweak the system a little bit rather than throw the baby out with the bathwater.
We hear you. Thank you so much. This is very helpful, Bruce. I think your testimony is very helpful, and we truly appreciate it. And it was worthwhile for you to be up so late at night time.
Senator, I can tell you that I learned a lot from listening to the testimony, and we appreciate what you and the Public Health Committee are doing to support our industry. Thank you so much.
And next time we meet, it'll be during the day.
Okay, great. Thank you.
All right. Thank you.
Good night, folks.
Thanks. The next person on our list is Jennifer. Oh, sorry. I'm sorry. Okay. And Jennifer Mugio, welcome. I'm sorry I mispronounced your name.
No worries. Thank you so much, Senator Anwar and Representative McCarthy Vahey and members of the Public Health Committee. Special hello to Senator Summers, Senator Marks, Representative McCarty, my colleagues from Southeastern Connecticut. My name is Jennifer Mugio, and I live in New London, where I'm the Deputy Director and incoming Director of Health for Ledgelight Health District, the local health department for 9 municipalities in Southeastern Connecticut. I'm here today to share the enthusiastic support of Ledgelight Health District and our partners on the Overdose Action Team of Southeastern Connecticut for Senate Bill 9, Sections 4 and 5, and to respectfully request amendment to language in House Bill 6913, Section 4. In Southeastern Connecticut, we're committed to working together to address the overdose epidemic, a public health crisis that requires us to implement every available evidence-based public health intervention. In partnership with our community members and community partners, Alliance for Living and the City of New London, we have implemented our comprehensive harm reduction NLC Cares project. We're constantly innovating and evolving our efforts to serve our community, and we invite you to visit us on your tour of harm reduction programs. But despite these efforts, people are still dying from something that is preventable. We must act with urgency to dismantle continued barriers to safety and well-being. As you've heard today, overdose prevention centers are an evidence-based strategy that will increase community and individual safety. We urge passage of this bill so Connecticut can lead with science and care for our community members. It's important to note that overdose prevention centers are one of many strategies we need to employ if we truly want to turn the tide on the overdose crisis. We also need to act with urgency to make it easier for people to start and maintain the gold standard of treatment for opioid use disorder by dismantling restrictions on methadone treatment. Through our work on NLC Cares, we've learned that bringing care into community and offering access to clinicians in non-traditional settings significantly increases people's interests and ability to participate in treatment. And we're eager to build on our work and offer mobile methadone. Like most cities, New London is densely populated and designed. You're basically almost always within 500 feet of one of the facilities listed in the proposed language. At the same time, systemic barriers to well-being mean that more people in New London lack reliable transportation, have multiple or unpredictable work schedules, face child or family care challenges, or have experienced discrimination in systems of care, all of which make the delivery of mobile methadone services at multiple and easy to access locations within New London that much more important. Please do not restrict our ability to increase access to this life-saving medication by imposing unnecessary restrictions that are rooted in discrimination and misperceptions about people living with substance use disorder. It has been my honor to submit this testimony on behalf of Ledgely Health District and our partners on the NLC Cares and Overdose Action teams. Overdoses are preventable, and we should be dismantling every systemic barrier we can to save lives. Thank you for your time, your long day today, and your careful consideration of our request.
Thank you so much, Ms. Melgio, for your testimony. And it's quite obvious that you love what you do, and it's very obvious, and we thank you for that. It's needed. And Representative McCarty has a comment or a question for you.
Just a very quick comment, Jennifer. Thank you so much for all of the tremendous work that you are doing in Southeastern Connecticut. And I know with the New London Cares Project and everything, and I will call you. I was texting earlier, so I'm glad that you stayed tonight to let me know what your position was with the Overdose Prevention Center. So I'm glad that you came in. I know it's late, so I won't keep you, but thank you so very much for all your work.
Well, thank you so much for all of your support, Representative. And for your kind comments, Senator Anwar. I always say, I hate that I have to do this work, that we have not solved this public health crisis yet, but I'm honored that I get to do it in partnership with so many amazing people in Southeastern Connecticut.
Thank you. We appreciate you, and we appreciate your testimony. Seeing no other questions or comments, we will move on to the next person on our list, which is Zoe Dodd. Ms. Dodd, you're on. Welcome.
Good morning, everyone. Good morning and evening. Good evening, representatives and committee. My name is Zoe Dodd, and I live in Toronto, Canada, which is a city as large as the population of Connecticut, and I work at MAP Center for Urban Health Solutions as a community scholar. My expertise is in overdose response, safe injection sites, supporting drug users and drug users' health. And I'm here to speak specifically to Bill 9, Section 4.5, I'm here also because I helped to establish the first overdose prevention site in Ontario in 2017. I was the coordinator of the site for a number of years. I worked in it to help with the policies with the provincial government, and I also helped expand naloxone in community. I have over 20 years experiencing and supporting and responding to drug users' needs. I'm someone who has had a lot of significant loss of family members, friends, and colleagues. And I think for many of us, we just felt like we just had to act, and we opened an unsanctioned site in Moss Park back in 2017. We wanted to show the government that it actually can be easily done. It was located in the epicenter of the toxic drug death crisis. And at that time, there was intentions to open 3 supervised injection sites, and they were marred down by consultations, exemptions, and meetings and politics. And it took 6 years to establish those sites. I sat on the committee for one of them. Toronto has roughly 15 sites now, and they are as minimal as tables with chairs with oxygen and naloxone and staff to support people in a room, to standalone sites offering wraparound services, to being in community health centers where a wide range of people actually access their healthcare. Our public health department and political representatives recognized that we were in emergency, and when you are in emergency, you act. There were leaders in the province I live in, along with community organizations and people who use drugs, and they were people like yourselves. And we went from 0 sites to over 20 in Ontario, and it's just one intervention amongst many that we need to use to respond to this crisis. So first, harm reduction site. It means that we act with compassion and care, and we do not coerce or force people onto what we may think they need. People have autonomy and self-determination, even when they are deep in it. Second, overdose prevention sites save lives, which we've heard a lot about, and that overdose deaths are preventable. And I was really taken from what Lori was saying. You know, we also take the stress off families. It is very challenging and upsetting to be reversing the overdoses of your own family members and friends. Third, those who use this site should actually have a say in the model. And I want to speak specifically to part of the bill and the advisory. You have to have people who use drugs now, not people in recovery, people who are actively using, people who would be using the sites on the advisory. And that would also include harm reduction workers and researchers who research in this area and have expertise. Fourth, this is a community space. And I heard that comment from the person from Yale about how people don't have community or they're exiled. Actually, people do have their own communities, and they've been taking care of each other. And what we offer in this space is a place for people so they can be uplifted and give people a sense of belonging. It also helps people to understand, like, we're not abandoning you to die. We are here. We are here to listen to you. And I can't think of anywhere else within the system when you're struggling that you can just walk in the door and there are people who are there to talk to you.
Excuse me, Ms. Dodd, but your time has
sure.
expired.
Okay,
Thank you.
thanks.
Thank you, Ms. Dodd, for your testimony and then staying with us. What's the time and where you are at?
Oh, I'm in the same as you. It's almost 2:30 here. So yeah.
Oh my God, you got to get a life. Like us.
I've actually been listening all day, and I've been so interested in what people have had to say. Has been a really interesting one. We also have a nursing crisis too, so, and a shortage and the same problems. I work in a hospital, so.
Say the magic word, the governance in Connecticut is better than Canada.
And we've also had these meetings go forever too, where we have been at them. And you know, it took leadership from people like yourselves.
It was a good try. Thank you. Well,
Thanks.
welcome and thank you for your testimony. We truly appreciate you.
Thank you.
And next person to testify is Elizabeth Ryder. Welcome, Ms. Ryder. You're on.
Yes, hello, thank you. Can you hear me okay?
Very well.
Okay. Distinguished officials, good morning, and members of the Public Health Committee. My name is Elizabeth Ryder, RN. I have a residence in Danbury, Connecticut, and I have worked as a registered nurse at Danbury Hospital for 45 years. I support SB 1067 as it mandates self-staffing ratios and eliminates mandatory overtime. Short staffing has become a standard of the inpatient hospital industry. The dangerous practice leaves vulnerable patients at risk of harm. And I just lost my page. Pardon me. Just trying to get it to scroll, it didn't go. At risk of harm and neglect. Short staffing has been more than a decade in the making, It used to be that when the staff schedule was being drafted, all efforts were made to be sure that staff assignments were filled and complete. Staff were expected to meet their control hours, and then any staff could bid for open shifts, followed by the opportunity for overtime. The subsequent matrix did not allow for pre-booking of overtime. Staff were told, "We will wait and see if we need the staff at that time." Well, by the time that shift rolls around, staff have made their own commitments and the opportunity to fill those shifts has passed. The corporate influence provided bonuses for upper management who accomplished budget reduction, and our CEO now makes upwards of $14 million. The shame is that now the undue burden of work placed upon staff at the bedside, the increased liabilities of patient care, physical and emotional stress that has been placed upon staff has led to a dire shortage of nurses at the bedside. Of 89,000 registered nurses in the state of Connecticut, only 23,000 remain at the bedside. This is a spiraling trend as the more nurses who leave the profession, the more liability and subsequent burnout falls to the nurses remaining. This dangerous situation has led to a reduction of applicants to nursing programs, and so the nursing shortage continues to worsen. Where once the managers saved money on overtime, they are now forced to provide monetary incentive pay. This stopgap measure lasts just so long as the already burdened staff is being asked to do even more, and eventually the money does not satisfy the work-life balance. Nurses are testifying today about the liabilities of patient care. Routinely, staff ratios have blossomed from 4 or 6 to 1 to as high as 8, 10, and even 12 to 1. Nurses are burdened with guilt and anxiety over substandard care, needing to take shortcuts and just having trouble keeping up. The stress is enormous when you are responsible for patient care and safety. The stress goes home with you and spills into your personal life, not only emotionally, but physically. These days, a day off is spent in recovery from a broken spirit and an aching body.
Excuse me, Ms. Ryder, but your time has expired. Thank you.
Thank you.
Thank you so much for your testimony, Ms. Ryder. We truly appreciate you staying with us throughout the night.
If I may, I have one sentence.
Please go ahead.
Your constituents should not bear the consequences of short staffing. They should be confident that their expectations of care is complete. SB 1067 will assist in a robust return of proud professionals to the bedside. I urge you to support this bill. Thank you for this opportunity to testify. I would be happy to answer any questions.
Thank you so much for your testimony. Seeing no questions or comments, we appreciate you being here with us. And we'll move on to the next person on our list, which is
Thank you.
Isabel Farine. Isabel, good to see you. Please join us. Welcome.
Good morning. My name is Isabel Farine, and I am testifying in support of Senate Bill 09. I am the co-founder and vice president of For Cameron Inc., a not-for-profit organization which aims to bring the focus to the fentanyl crisis by supporting harm reduction efforts and prioritizing the lessening of stigma surrounding addiction. For Cameron is pleased to see the vast progression in support when addressing the opioid crisis in Connecticut, but we are also honored to be able to testify today. Your support and your involvement are not only essential, but will also put Connecticut on the forefront of this issue. Connecticut residents deserve to have access to life-saving interventions like harm reduction centers. The concept of these centers isn't new, and they have been proven to be effective. Let's look at our neighbors in New York City. Thousands of lives have been saved. Thousands of deaths out on the streets were prevented because a safe space was created for people who needed it. The key word there being people. These are people who need our support. As a New Haven resident myself, it upsets me to live in such a forward-thinking state, but also live in a hotspot for overdose deaths. We need to do better. This could be our way of providing a safe space for people of all walks of life with all different experiences, people who have been through recovery, people scared to use alone, and so on. This is also a facility that allows safe cleanup, meaning nothing left out on the streets or in local parks, which we know is a massive concern for parents of young children. A lot of public use, meaning public restrooms, parks, etc., is because people do not have access to a space where they can feel welcomed or feel supported. Now, I know when I say that, the main question is, why do we want to supply that support for people taking part in something dangerous? Think of it this way. Uber is an app that allows someone to request a ride home in the matter of seconds. This app and other safe driver apps are utilized by anyone, but a large percentage of the trips are for people who have spent the night out drinking and need a safe way home. Does Uber encourage people to drink? Not necessarily. Does Uber encourage people to make a safe decision and lessen the number of people out drinking and driving? Absolutely. We are all aware that people are going to consume alcohol, just as we are all aware that people will use drugs. Just because we view drugs as dirty, we have the problem we are facing right now. We need to evolve past the massive stigma we have placed around drug use to save lives. It is time to put our stigmatizing view of those who use drugs to bed and take this seriously. We need to give more access to treatment. We need to create this safe space for people to go get this support. And most importantly, we need to keep them alive. I lost my brother Cameron to a pure fentanyl poisoning exactly 5 years ago this month in 2018. Almost 306,000 people in the US have died from fentanyl since the day my brother died. That is 306,000 families forever in mourning. We need some sense of closure and to know that you all are doing everything you can to help prevent this from happening to other families. How many more lives lost are we going to ignore until we decide it is time to start saving them? As a younger sister who found their big brother dead on his bedroom floor, I want to shield other family members from seeing what I saw. This is a way that we can help do that. Help me protect others. I am pleading with you to please hear my words. You have the opportunity to not only start saving lives, but to tell those like myself who have already lost someone that you can hear us, that you stand with us, and that you stand with those that have fallen into the stigma that shames them. Too many people are dying and we aren't doing anything about it. So I ask you to please support Senate Bill 09. Thank you for your time and consideration.
Thank you so much, Isabel, for your testimony. You were on time, and every time I hear your Uber explanation, it's very useful because sometimes people ask a question and we want to explain them about the Uber example that you have, which is very powerful. I have Representative Parker who has a question or a comment. Representative Parker.
Thank you, Mr. Chair. Thank you, Isabel. I know it's very late, so I'm going to be so quick just to say thank you for your advocacy. I know your mom, I believe, is on here, and somehow the two of you got a late draw here. But we're so sorry for your loss and admire the way that you continue to advocate for this community and for this issue. So thank you, and thank you to Fiona too. Thanks, Mr. Chair.
Thank you. Isabel, seeing no other questions or comments, we will move on to the next person online, and we'll see your mother soon too in the testimony. But the next person is Dr. Daniel Karakas. Dan, good to see you. Thank you for your patience. And it's good to see a surgeon in the middle of the night. So welcome.
Thank you. Thank you, distinguished members of the Public Health Committee. Thank you for allowing me the opportunity to speak tonight and for diligently listening to hundreds of people testify today. I'll be speaking in strong support of Senate Bill 9. We've heard a lot of fantastic testimony on this tonight, but I just wanted to share my perspective and to add my voice to the chorus. My name is Dan Karakas. I'm a resident physician training in general surgery in Connecticut. One of my duties as a surgeon is to cover the trauma bay in a number of Connecticut hospitals. One recent evening, I received a patient off an ambulance stretcher. The patient's daughter had heard her collapse on the other side of the bathroom door and called 911. Paramedics arrived and initiated CPR. Shortly after arrival in the trauma bay, we gave her naloxone, and a few minutes later, she was asking me where she was. This patient of mine was one of the lucky ones. She would live. Many do not. Many do not have a daughter home, or they have no one around them in the alleyway or the abandoned construction site, or whatever shadow they occupy that society finds acceptable for them to meet their needs. In 2021 in Connecticut, over 1,400 people did not have a daughter home. So instead of receiving naloxone, they died because they had nowhere else to go. If on the night of their death, one of them had instead used at a harm reduction center like the one proposed in this bill, they would be here with us today. If 100 had used that one, we would have 100 more of our neighbors here today. Those are the statistics. Nobody has died in one of these centers around the world. I support harm reduction centers because they're evidence-based healthcare. We've heard a lot about the evidence. At this point in the night, I just want to highlight one benefit that's received a little bit less attention. And that's the opportunity that these centers afford to provide early interventions for patients with an infection. As a surgeon, I have witnessed firsthand the devastating consequences of late presentations of infections from drug use. I have drained 6 abscesses on one patient at the same time. I have treated patients septic from infected heart valves, and I have amputated limbs. This high-risk population does not come to the hospital lightly, and harm reduction centers are superb at bringing needed and timely medical attention to them. While the measurable benefits are considerable, perhaps the most important thing a harm reduction center does is set a new tone. It opens its arms to a group of people that has been neglected and marginalized in our society ever since the war on drugs. And it says, I am here for you, I care about you, and I want to help. It is a statement from the people of Connecticut that we recognize that there is a disease afflicting many of us and of all ages and all colors, and that we want each other to get better. For the people it will serve, the center will be the only system they encounter that is designed to meet them where they are, rather than force sobriety upon them before they are ready, which is a treatment plan that has lethal consequences if a relapse occurs. To be blunt, I wish I didn't feel compelled to be here in Hartford today. I wish I could be doing my part from the hospital, but most people who overdose don't make it there. So I left the hospital to come here and to ask you to change our approach and to give thousands of our residents a place to go. So thank you for all that you do, and I invite any questions.
Thank you so much, Dan, for your testimony. Thank you for being here with us throughout the day. You've been here since at least 9 a.m. or if not earlier. And I appreciate you for even many months ago, you've been trying to work on how to raise the awareness about this. And I appreciate that. Can I ask you the cases with xylazine? What is the source of this infection and why is it impacting the skin, or is it impacting the organs as well?
That's a great question. I wish I had the answer to it, and I don't. Yeah, it's strange. I know xylazine is now contaminating 15% or so of the drug supply in New Haven, according to the drug checking services that we have there. And we're seeing some pretty severe infections associated with it, but I'm not sure the mechanism behind that. Something I need to look more into.
Yeah, but you're having to drain the abscesses on the skin more for the most part.
Yeah, and you know, abscesses are something that have been, you know, that are anytime somebody is using drugs with an unclean syringe, they're at risk for those. But with xylazine, for whatever reason, it seems like the wounds are more severe.
Okay. Thank you so much. This is very helpful. And I think the big question is, how do we get everybody else in the position of responsibility to buy into recognizing that the time is now, not a few months, few years from now, but now. And then that's where we'll need your help as well.
Absolutely. I'm here to help, and thank you for all of your work in this, and for all of your work for all of you.
Thank you so much. Thank you. Seeing no other questions or comments, we appreciate you, and we'll move on to the next person on our list, which is now Lynn Repsilber. Welcome.
Hi, good morning, everybody. Dear Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the Public Health Committee, my name is Lynn Rapsilber. I'm a nurse practitioner, and I am in support of Senate Bill 1228, an act concerning the state's healthcare workforce, with focus on adding APRNs as collaborators, reciprocity for out-of-state APRNs, and signature authority. I wanted to let you know that I was a part of the scope review process that occurred in 2013/2014, which became Public Act 14-12. And my colleague, Dr. Henry Schneiderman, gave testimony earlier today that he also sat on that review committee in support of the nurse practitioners. There is a primary care and mental health shortage in all counties in Connecticut. And with the passage of Senate Bill or Public Act 14-12, many APRNs have started practices to address these shortages. The issue at hand is these practices need the ability to grow. And with new nurse practitioners, when they precept them, they have the opportunity to train them, but then when they graduate, suddenly we're not able to take care of them as far as mentoring them in the workforce. We have to transition them to a physician to do collaboration. I think it's unnecessary, and it only adds cost to the nurse practitioner practice owner, as they have to pay oftentimes that physician collaboration. Also, finding these physician collaborators has been an issue. Even when the Scope of Practice Review Committee authorized this, the Medical Society did have a button on their website that would help nurse practitioners find collaborators. And for time and time again, it was very difficult for them to find a collaborator. And now that button doesn't exist anymore. And it is very difficult for them to come up with someone that will find a collaborator. I just want to let you know that right now there are 27 states, the recent addition of Utah, that allow full practice authority. And just to give you a perception about New England, New Hampshire and Rhode Island have no transition to practice. They can go right from their training out into developing their own independent practice. Maine, Massachusetts, and Vermont have a transition to practice of only 24 months with an APRN or a physician, so they allow both. They are less restrictive than Connecticut. We have 2,000 hours in 3 years. Only New York has 3,600 hours under physician, but again, they're fighting to get their APRN added to this language as well. I did provide a map, a link to a map looking at all the practice authorities in all the states across the country. Reciprocity is definitely a concern. We can't attract good quality APRNs from other states because they have to fall under the 2,000 hours in 3 years, regardless if they surpass that or previously worked in a full practice state. So we're losing out on the opportunity to have some really qualified APRNs come into the state. And lastly, we need to have the authority to provide our patients to be able to sign the paperwork. And due to outdated statutes, we're not able to do that. Each year we bring forth statutes to be corrected and allow us to sign those documents, but we're chipping away at it a few statutes at a time, and it's going to take a decade to remedy all of this. So we really do need that signature authority to mirror our practice. We also added PAs to this original bill. There are 355,000 nurse practitioners in the US, and about 88% of them practice in primary care. 83% see Medicaid care patients and 82% see Medicaid. So the
Excuse me,
NP
Ms. Rassler, but your time
Yes.
has expired. Thank you.
Thanks. I just wanted to let you know that a colleague of mine, she started a practice up in the Northwest corner. With the event of COVID, a lot of New Yorkers moved into the area. The first selectman of Cornwall called me and she wanted to know how we could help solve the primary care crisis in that area because there were only 2 primary care providers. And so my nurse practitioner colleague started a mobile practice. And from that, she'd started about 2 years ago. Right now, she has 2 nurse practitioners that work with her. She has 2 physical plants and she's buying another office. So her practice is growing. In 2 years, she's now at 1,600 patients, but she has 600 patients waiting. And she has a great student she wants to hire, and she can't hire that student now to help fill that void.
Thank you so much, Lynn, for your testimony. We
Thanks.
truly appreciate your testimony and you're staying with us throughout the day and night. The lack of questions is not because of lack of interest, it's lack of bandwidth right now. So we appreciate you.
I hear that. I hear that. And I appreciate your stamina, especially for the staff too, because I know they work really hard behind the scenes.
Yes, they are superheroes we have. We are very, very blessed. Seeing no other questions or comments, we move on to the next person on our list, which is Ms. Fiona Ferrin. Fiona, thank you for staying with us throughout the day and this evening, and welcome.
Good evening. Actually, good morning. I'm sorry. My name is Fiona Cullinan Ferrin. I'm testifying in support of SB 09 to bring attention and responsibility to the need to urgently strengthen our state's response to the fentanyl and opioid epidemic. I am the co-founder and president of Fort Cameron Inc., a not-for-profit organization founded when, after losing my son Cameron to an unintentional fentanyl poisoning in our home, we realized in our state there was zero public awareness of illicit fentanyl, minimal support for those with substance abuse disorder, and minimal support or compassion for those who lose a loved one in this manner. I am advocating tonight for something we know will have immediate benefit and reduce the loss of lives in our state: overdose prevention centers. Stigma is viewing drug use as a moral failing or a poor choice. But science tells us substance use disorder is a chronically relapsing brain disease, often rooted in trauma or inherited through genetics. Stigma tells us people with substance abuse disorder don't deserve the same respect to treat their disease as is afforded to some people with other medical conditions. When someone experiences cancer, we don't point a finger at choices they may or may not have made. The focus is on keeping them alive with evidence-based treatment and with unquestioning support. Internationally, and now one state over, overdose prevention centers have saved hundreds of lives and decreased public drug use in areas near these centers. We have an opportunity in Connecticut to structure these centers to also link people who would use them to medical and recovery care, including offering medication-assisted treatment, which is a game changer in substance use disorder, and with an aim to reduce the shame associated with drug use that often prevents people from seeking help. You have heard me refer to stigma several times as a contributing factor in this crisis. I would like to remind this committee that the Sackler family created this crisis by preying on those in pain for their own monetary gain. And when the numbers of the dying became too great to ignore, the Sacklers and the executives of Purdue Pharma right here in Connecticut marketed stigma to the public. By blaming the victim, they steered attention away from their evil acts so their profit line would not be affected. The opioid settlement fund was fought for and created to begin to right these wrongs. And I can think of no more fitting use for some of these opioid settlement dollars than the creating of overdose prevention centers here in Connecticut. In conclusion, it is not a one-issue problem, but creating policies takes time, and we have a duty to begin doing all we can to keep residents safe and alive while creating policies. Every person who loses their life to a preventable overdose in our state is failed by us. I see the commitment in this room. I see the compassion among you. Please, let's act on this now. Let's try something new, a new way to make a difference in our state. Thank you for the opportunity to testify so early this morning. In closing, I miss Cameron so much. But if we make a compassionate change, if we, from his loss and from the loss of countless others, we can collectively heal. We'll never forgetting those we lost, but fighting for those who are still alive and have time. Thank you.
Thank you, Fiona. Thank you so much for your testimony, and we're all sending you our love and hug, and you're honoring Cameron by standing up and making sure that we protect as many people as we can. So that's one of the best ways to celebrate his beautiful life. Thank you.
Thank you.
And seeing no other questions or comments, we wanted to ask the next person on the list, Josiah Schley, to speak. I'm sorry, I skipped you by mistake. You're on. Thank you so much, Ms. Schley. Josiah, you're there or no? I see her in the list right now. Yeah, and she's unmuted too. Okay. I see him on the panelist. Okay, well, we'll see if you cannot join us. What we'll do is we'll go to Christine Schilling. Ms. Schilling, you're on. Welcome.
Thank you. And good morning to our esteemed senators, representatives, and members of the Public Health Committee, those who are still standing. My name is Christine Schilling. I'm a 20-year labor and delivery nurse at Danbury Hospital. And I'm speaking today in support of Senate Bill 1067 regarding adequate and safe healthcare staffing. Those opposed to the bill have correctly stated that there should be flexibility in ratios and input from knowledgeable clinical staff. But the input of the bedside nurse that best understands the patient's needs, challenges, and safety requirements is not being utilized. Nurse administrators unilaterally decide on staffing levels that don't consider acuity, despite what they say. When they argue that the bill will undermine the nurse's critical thinking, they mean their own decision-making. They implement their own grids inconsistently while lecturing us on fiscal responsibility. It feels a little bit like leaving the fox to guard the hen house. Administration has had years to do this safely, and they're not getting it done. It's time for state oversight and laws that determine and enforce safe and adequate minimum staffing levels. I won't argue that this legislation will solve the nursing shortage, but it will address accountability. I work the night shift, where the least experienced new grads start. Staffing numbers are lower and resources are scarce. It's also the shift during which many unborn babies decide to enter the world. We gird ourselves to care for our admitted patients, as well as every pregnant woman who comes in for a labor check or obstetric concern. Yet, I personally worked an entire shift as one of only 2 nurses scheduled and staffing a unit that averages 2,000 births per year. This is horrifying. And there's no accountability for this on the part of the hospital because we managed it without reportable safety infractions. Another poorly staffed high acuity shift caused me to suffer my first full-blown panic attack on shift. Management was neither agile nor supportive that night. Also egregious to me are the stories of ambulances circling to find open EDs, and I really appreciate Senator Marks for questioning the veracity of that picture. It is very effective at eliciting an emotional reaction against the bill. However, a federal law known as EMTALA guarantees that patients having an emergency crisis or in labor will be evaluated immediately in the closest ED. To conclude, I have made many desperate calls up our chain of command to get help, resources, or divert patients because we had neither the beds nor the staff to care for them. Rarely do the decision makers come in and don scrubs to keep our patients safe, but they also won't close beds, even if those beds are broken, unmonitored, and unsafe. Until such time as hospital leadership considers patient safety paramount, we need these laws to protect our patients, our communities, and our caregivers. For these reasons, I support SB 1067 and urge you to do the same. Thank you for the opportunity to testify and for your attention and being up all night listening to all of our concerns on this issue. I would be happy to answer any questions you may have at this time.
Thank you so much, Ms. Schilling, for your testimony. We were willing to bet that you were a night nurse, and you just in your testimony proved that to us. So it's all coming so naturally to you in the middle of the night, and we are all struggling here, but thank you.
This is my finest hours.
Okay, welcome. Then the next person on our list, we don't see any questions or comments. We'll ask Christina Eva Capitan to join us. Welcome. Christina, you're on. If you can. Well, while we're waiting for Christina, maybe we can go to Carrie Bender. Going once, Carrie Bender, Christina. Going twice, Carrie Bender and Christina. And any taker? Peter, you want to testify? Anybody? No, okay, sorry. Fine, we have nobody else wants to testify, I guess. That means this is the time for us to say thank you to our administrators, each and every person, our partners in CTN, and also our amazing team of individuals. I will forget some of the names, but Kathleen keeping the time, Peter working on our side to make sure behind the scenes we're doing well, our fearless Bev, as well as all of our fellow legislators. We're going to get a picture together if you guys want to stay back. And we will close this public hearing. Thank you, everyone.